Hello everyone. So in endocrinology, there are a few high-yield topics that I should mention first of all. So everything related to thyroid, be it hypothyroid, hyperthyroid, or thyroid cancers, or the histological images of those thyroid cancers, everything is important related to thyroid. Then there's Cushing syndrome, then diabetes mellitus and its treatment. We have to remember all the class of drugs that are very high yield. Also, the system is very conceptual, I'll say. Like, you should know how to connect the dots between different diseases, between different mechanisms that goes around in endocrine system. And yeah, once you get to know all about it, the questions are a bit easier than the other systems. I like to think that it's easier than other systems. Right. So yeah, let's begin with the embryology. So the thyroid diverticulum arises from the floor of primitive pharynx and descends into neck, connected to the tongue by thyroglossal duct, which normally disappears but may persist as cysts or the pyramidal lobe of thyroid. Foramen cecum is normal remnant of the thyroglossal duct. So if this is the tongue, thyroid is going to, it is the floor of the pharynx. The thyroid is going to develop from here and it will descend into the neck. And this is the duct and it will form thyroid eventually here. Yeah, so this is the thyroglossal duct, and it can persist as a cyst. So this is a duct which should ideally, it should disappear, right? But if it is persistent, it can cause a cyst. This is a cyst. Like, this is the remnant. Okay, and here is the foramen cecum. Okay, so this is the remnant, and it can either form a cyst or it can persist as a pyramidal lobe of thyroid, that is at the top of the thyroid, right? This is the pyramidal lobe. Most common ectopic thyroid tissue is the tongue, that is called lingual thyroid, and removal may result in hypothyroid if it is the only thyroid tissue present. Now the thyroglossal duct cyst present as anterior midline neck mass that moves with swallowing, because it is connected to the tongue, right? So if during swallowing the tongue moves, so along with that the thyroglossal duct cyst will also move with the or protrusion of the tongue, versus persistent cervical sinus leading to the pharyngeal cleft cyst in lateral neck. So the persistent cervical sinus is nowhere related to the tongue or to the movement of the tongue, so it is not going to move with the protrusion of the tongue. And thyroid follicular cells derived from endoderm, and parafollicular cells arise from the fourth pharyngeal pouch. So yeah, if this is the base of the pharynx, this is foramen cecum. So this is the thyroid is developing through the thyroglossal duct. So this is the thyroid being formed here. And this is the thyroglossal duct, right? It can persist as thyroglossal cyst, which is in central neck mass, or it can form a pyramidal lobe. Another important thing is the blood circulation. That is there is this external carotid artery just behind thyroid, and just near to external carotid artery there is superior laryngeal nerve. Right, and there is internal carotid artery, there is inferior thyroid artery, there is superior thyroid artery. Superior thyroid artery arises from the external carotid artery, and inferior thyroid artery arises from the left subclavian artery. And yeah, this lingual thyroid. So lingual thyroid can enlarge at higher thyroid needs, right? Whenever there is increased need for thyroid hormones, like in pregnancy or puberty, the thyroid, if the lingual thyroid is present, it can enlarge. And if it enlarges here, it is going to press on the pharynx, right? So it is going to cause dysphagia, dysphonia, dyspnea, all those obstructive symptoms. So lingual thyroid can enlarge. And it can cause dysphagia, dysphonia. So I've annotated the Pathoma as well as the Uworld in this first aid. So whatever extra information that I'm writing here, just don't ignore it if you are watching this. So just don't ignore it. It is somewhere either in Pathoma or in the Uworld, right? I'm not writing down any extra information that we might not need. This is all very important information. Now the anatomy. So first is the pituitary gland. There's anterior pituitary and the posterior pituitary. Anterior pituitary is called adenohypophysis, and posterior pituitary is also called neurohypophysis. Anterior pituitary secretes all of those hormones except ADH and oxytocin, that is vasopressin and oxytocin. Vasopressin and oxytocin is secreted and stored and secreted by posterior pituitary. Every other hormone that you might not have to remember every hormone, just remember that every hormone is secreted from anterior pituitary except vasopressin and oxytocin. Right, so MSH secreted from the intermediate lobe of pituitary, that you have to remember, and derived from oral ectoderm, that is Rathke's pouch. And alpha subunit secretes hormone subunit. It is a hormone subunit common to TSH, LH, FSH, and HCG, and beta subunit determines the hormone specificity. It is not very high. And yeah, so propiomelanocortic derivatives of beta endorphin, ACTH, MSH, just three: beta endorphin, ACTH, and MSH. This is important. Why? Because in Cushing syndrome, when we will see that ACTH is increased, so along with ACTH increasing, there is also going to increase in MSH, and then that MSH is going to cause us hyperpigmentation. Yeah. Also in primary adrenal insufficiency, if the ACTH is increasing to stimulate the insufficient adrenal glands, there is also going to be increase in MSH, which leads to hyperpigmentation. Right, so there's which are the basophilic and acidophilic hormones. So basophils is B flat, that is FSH, LH, ACTH, and TSH. B flat. And acidophils are acid pig, that is PRL and GH, prolactin and growth hormone. Everywhere you will see prolactin and growth hormones will be related to each other some way or other. So just keep in mind that prolactin and growth hormone both are acidophils. Yeah, it is derived from oral ectoderm, that is Rathke's pouch. So what is Rathke's pouch? If you don't know, let me just tell you that it is a protrusion of the base of skull. If this is the base of skull, there is a protrusion that forms, that is called Rathke's pouch. So anterior pituitary is derived from this Rathke's pouch. I don't know if I'm pronouncing it right, but just bear with me. And the posterior pituitary is derived from if this is the hypothalamus. So posterior pituitary is extension of the neurons of the hypothalamus. Right. So this is anterior pituitary and this is posterior pituitary. So now you understand that why vasopressin and oxytocin is just released from posterior pituitary and why is it stored in posterior pituitary, because it is formed in hypothalamus, right? So from hypothalamus it travels down to posterior pituitary where it is stored and then it is released into the system, right? And this Rathke's pouch, it is important because craniopharyngioma, we'll see what a craniopharyngioma is. So craniopharyngioma is a benign tumor arising from the Rathke's pouch, right? So it has, I think, 3 components. That is, it should have calcification, it should have a solid component, and it should have a liquid component, I think. So you should be able to see 3 things in CT scan. First is calcification at the rim, then there's hyper opacity and hypo opacity or something like that. There should be 3 components which I don't remember very specifically, that tells us that it's a craniopharyngioma, right? So it is a benign tumor and it just has the mass effects on the anterior and posterior pituitary hormones. That's it. Now the posterior pituitary, it stores and releases vasopressin, and that is ADH, and oxytocin, both made in the hypothalamus in supraoptic and paraventricular nuclei. ADH in supraoptic and oxytocin in paraventricular nuclei, and transported to posterior pituitary via neurophycins. So this is called neurophycins. And posterior pituitary is called neurohypophysis. Via the carrier proteins. It is derived from neuroectoderm because, as I told you, that it is derived from the neurons of the hypothalamus. So it is derived from neuroectoderm. That's how I remember it. And the anterior pituitary is derived from oral ectoderm. And so yeah, this is just above the nose, right? So that is why any tumor removal procedures, be it craniopharyngioma, be it prolactinoma, it is done using FES, right? So that FES surgery is done through this intranasal pathway. So it's not just above the nose, like there's a sphenoid sinus. We have sphenoid sinus that we have to pierce to enter this Rathke's pouch. Now the adrenal cortex and medulla. So adrenal cortex is derived from mesoderm and medulla is derived from neural crest. The cortex is the outer area and medulla is the inner area. Cortex secretes, has 3 zones, that is zona glomerulosa, zona fasciculata and zona reticularis, and medulla has chromaffin size. Right. So there's a very good mnemonic, that is salt, sugar and sex. That is, salt is mineral or corticoid secreted from zona glomerulosa, sugar, that is glucocorticoids released from fasciculata, and sex, that is androgens, which is secreted from reticularis. And the chromaffin cells secrete catecholamines, right? That is epinephrine and norepinephrine, aldosterone, cortisol and DHEA. So DHEA is the precursor to testosterone, and from testosterone then estrogen is formed peripherally by aromatase enzyme. Yeah, so zona glomerulosa is regulated by angiotensin 2, because we know aldosterone is regulated by angiotensin 2. Cortisol secretion, cortisol synthesis is regulated by ACTH and CRH from hypothalamus and ACTH from anterior pituitary. And DHEA is again regulated by CRH from hypothalamus and ACTH from anterior pituitary. And chromaffin cells secrete epinephrine and norepinephrine. that is called catecholamines, and it is regulated by preganglionic sympathetic fibers. Right, and that's histology is important most of all. So here you can, I don't know if you can see this diagram or not, because I can't differentiate between the zones. We can just differentiate the zona fasciculata, right? Otherwise I have a different diagram that we'll see. So this is the capsule, right? Then there's zona glomerulosa, then the zona fasciculata, that you have to differentiate just zona fasciculata due to its light color, right? So that you know that this is zona fasciculata. So above that it should be zona glomerulosa, and below that it should be reticularis. And reticularis itself means net-like. Reticular means net-like surface. So you can see this zona reticularis looks like a net with pores in between. And the very dark basophilic region is the medulla, right? This is a good diagram. Yeah, and I also want to add on here just the we have seen this in the biochemistry section as well, the effects of epinephrine on endocrine system, right? Because we know epinephrine has sympathetic actions and all that. So what are its effect on the endocrine system? So it is mostly related to the glucose metabolism. So epinephrine increases. So epinephrine generally increases the glucose content in the body. It causes hyperglycemia, right? So how does it do that? It has several mechanisms to do that. Epinephrine increases glycogenolysis and gluconeogenesis. It releases alanine from the skeletal muscle. That is a source of gluconeogenesis. Then it also helps in breakdown of triglycerides. Into fatty acids, free fatty acids, that can also act as substrates to gluconeogenesis, and glycerol. And it can also increase glucose uptake in the tissues. Sorry, it decreases glucose uptake. It decreases glucose uptake in the tissues. So eventually that causes hyperglycemia. Now the endocrine pancreas cell types. So islets of Langerhans are collections of alpha, beta and gamma endocrine cells. Islets arise from pancreatic buds. So alpha secretes glucagon, beta secretes insulin, and gamma secretes somatostatin. So glucagon is in the peripheral cells, right? Alpha cells are in the periphery, then the beta cells are centrally situated, and somatostatin cells, that is gamma cells, are interspersed. Also one more thing, this catecholamine regulation is done by acetylcholine as well, because it stimulates the preganglionic sympathetic fibers. So that is important. Now the physiology. So these are just simple functions of different hormones that we just have to go through. It's not like you have to memorize all of this here only. You'll get to know more about these hormones and what it does in the upcoming sections, and you'll just remember it as we go through the system, right? But this is just like an overview of all the hormones. So ADH, we know that increases water permeability of DCT and collecting duct cells in kidney to increase water reabsorption. Stimulus for secretion is increased plasma osmolality, except in SIADH, where it is secreted nonetheless, right? More ADH is secreted despite the plasma osmolality. So if water is more, osmolarity is less. And if the content in the water, that is sodium and chloride and everything, electrolytes are more, the osmolarity is going to increase. Right? I like to keep things simple. Right? So CRH is function is increase ACTH, MSH and beta endorphin. That is stimulate the propiomelanocortin hormones. Right? So it secretes propiomelanocortin derivatives. And decrease in chronic glucocorticoid steroid use. So that this is the mechanism behind the tertiary adrenal insufficiency that we'll see later on. That a patient who is on chronic glucocorticoids has shut down the ACTH secretion. So if the ACTH secretion has been shut down due to glucocorticoid use, then so if the ACTH is no longer in the circulation, it is also going to shut down the adrenal gland, right? So because the patient is living on the glucocorticoids. So if the glucocorticoid steroids are stopped suddenly, so now the patient, as the patient does not have efficient adrenal glands, there is not going to be any cortisol or anything. So then adrenal crisis happens. That is one of the very few emergencies that endocrinologists get. Right? So there is weakness, vomiting, severe abdominal pain. So the person just needs steroids at that point of time. So once you replete the fluids and give the patient the steroids, the dexamethasone and fludrocortisone, the patient gets normal. Right, so that is the mechanism behind the tertiary adrenal insufficiency. Then the third is dopamine. Its function is to decrease prolactin and decrease TSH. Right, as I said, the prolactin and TSH are always related to each other and are always together. Also called prolactin inhibiting factor, dopamine antagonist, that is antipsychotics, can cause galactorrhea due to hyperprolactinemia. Right, I don't have to explain that. Fourth is GHRH, growth hormone releasing hormone. It releases growth hormone. Its analog tesamorelin is used to treat HIV associated lipodystrophy. Some amount of lipodystrophy is always there in the HIV patients, right? And if the patient is taking NRTIs, that is stavudine and all that drugs, stavudine and protease inhibitors, all with those navir suffixes, so the patient taking those NRTIs and protease inhibitors have increased tendency to have lipodystrophy, right? But some amount of lipodystrophy is always there in the HIV patients. Then GnRH, it's going to secrete FSH and LH. It is suppressed by hyperprolactinemia. So prolactin here inhibits FSH and LH release. Chronic GnRH analog leuprolide suppresses hypothalamic pituitary gonadal axis, that is HPA axis. So continuous GnRH analog is going to suppress. The pulsatile GnRH will lead to puberty and fertility. So continuous GnRH, that is continuous leuprolide if given, is going to decrease FSH-LH due to the down regulation of GnRH receptors on the anterior pituitary. But if it is given in pulsatile fashion, in cases of infertility or delayed puberty, right, mostly in the cases of infertility it is given in the pulsatile fashion. So if it is given in pulsatile fashion, that mimics the natural natural secretion of GnRH, there's going to be increase in FSH and LH. So with continuous GnRH analog, that is tonic GnRH analog continuously prolide, there's going to be increase in FSH LH initially for a brief amount of time, but then after it is going to reduce because of the down regulation of GnRH receptors. Then there's MSH, that is increased melanogenesis by melanocytes, causes hyperpigmentation in Cushing disease, as MSH and ACTH share the same precursor molecule, that is propionmelanocortin. Then there's oxytocin, causes uterine contractions during labor and responsible for milk letdown reflex in response to suckling. Right, it doesn't make milk, prolactin makes milk, and oxytocin helps secreting it. And it modulates fear, anxiety, social bonding, mood, and depression. Prolactin, it reduces GnRH, it stimulates lactogenesis. So in pregnancy, we know that there is increased prolactin, right? At the end of the pregnancy or after the birth of the baby, there is increased prolactin to stimulate milk production, that is to stimulate lactogenesis. So what prolactin will do is it is going to inhibit GnRH. So it is also going to decrease the levels of FSH LH, and if the FSH LH levels are decreased, there is also not going to be any kind of menstruation. So that is called postpartum amenorrhea. That is because of prolactin. So that is why breastfeeding is important for the baby as well as mother. For mother, because it gives her postmenopausal amenorrhea and also infertility for that amount of period that she breastfeeds her kids. So pituitary prolactinoma will cause amenorrhea, osteoporosis, hypogonadism, and galactorrhea. And breastfeeding increases prolactin, decreases GnRH, delayed postpartum ovulation. It acts as a natural contraception. Somatostatin, it inhibits everything. Right? It decreases everything, it inhibits everything. Right? So it decreases GH and TSH. It is also called growth hormone inhibiting hormone, GHIH. Analogs are used to treat acromegaly. So which is the analog? That is octreotide. It is more efficient than the somatostatin itself because it has a different kinds of amino acids. Right? So having those different kinds of amino acid, it is more resistant to clearance and hence more efficient than somatostatin. The last is TRH. It secretes TSH and prolactin. Increased TRH, that is example is primary and secondary hypothyroidism, may increase prolactin secretion, which will cause galactorrhea. Right, so TRH not only stimulates TSH secretion but also stimulates prolactin secretion. So whenever in primary and secondary hypothyroidism where T3, T4 is low, is going to cause increased TRH, increased TSH, but due to increased TRH, there is also going to be increase in prolactin, that is going to cause galactorrhea. Right, this is the diagram. We know which was the basophilic, that is flat, right? So FSH, LH, ACTH and TSH are basophilic, that is B flat was the mnemonic that we saw. And acidophils were GH and prolactin because they both stay together all the time. Right? So GH is stimulated GHRH, then somatostatin inhibits TSH and GH both. Then the dopamine is there, which inhibits the prolactin, and the prolactin in turn inhibits GHRH that was releasing LHFSH. CRH and ACTH are not involved in any of these brawls, right? They just live their own life and they just have their own diseases which are not connected to anything else, right? So yeah, this dopamine inhibits both TSH and prolactin, right? So as you can pair, if you want to pair these hormones, growth hormone and prolactin always stay together, like they were both acidophilic, like they are both released from the No, sorry, they are just both acidophilic. Then you can also pair prolactin and TSH, because dopamine inhibits both of them. And TRH stimulates both of them, right? So there's this TRH that is also stimulating TSH as well as stimulating prolactin, and dopamine is there inhibiting both prolactin and TSH. Now the growth hormone is also called somatotropin, secreted by the anterior pituitary. It stimulates linear growth and muscle mass through IGF-1, that is also called somatomedin C, secretion by liver, and it increases insulin resistance. That is why it is also called diabetogenic. Released in pulses in response to growth hormone, releasing hormone, that is GHRH. So it is not released continuously, but it is released in pulses. And secretion increase during sleep. That is why people say that you should get enough sleep. Hypoglycemia. That is why people say that you shouldn't eat all the time. You should have those breaks between the meals, or even the intermediate fasting is better. It increases during stress, because that is when we need the growth of our body the most, and I like to think it that way. Puberty is when we need the growth the most, and the exercise. Right, exercise. We do exercise for growing, right? For growing the muscles and everything. So that is when the growth hormone is secreted the most. And secretion decreases during aging, obesity, hyperglycemia, somatostatin. Somatostatin inhibits everything, so it inhibits growth hormone secretion too. Somatomedin, that is regulatory molecule secreted by liver in response to GH, acting on target tissues. Right. This is somatomedin, and IGF-1 is somatomedin C. That is regular molecule secreted by liver in response to GH acting on target tissues. So whenever the liver senses that GH is acting on the target tissues and we don't need growth hormone anymore, it is going to secrete somatomedin. And then excess secretion of growth hormone, that is pituitary adenoma, may cause acromegaly in adults or gigantism in children. Sorry if I'm talking too fast. I just had a huge amount of caffeine accidentally. I made myself a very strong cup of coffee, so that is why I'm very jittery at the moment. And the treatment is somatostatin analogs, that is octreotide or surgery. Right. So there is GHRH from hypothalamus, that is secreted, stimulated by all of these things, inhibited by all of these things. And it is going to secrete growth hormone from the anterior pituitary. And growth hormone acts on the body just with the help of IGF-1, not alone, but it secretes IGF-1 from the liver, which has several functions on the body. And only the direct function of growth hormone is that it decreases glucose uptake and increases lipolysis. And the IGF-1 on bone increases amino acid uptake, protein synthesis, DNA and RNA synthesis, chondroitin sulfate, collagen, cell size and number. In short, the growth of the musculoskeletal system. And in muscles, increase amino acid uptake, increase protein synthesis, right? The growth of the muscle. And you can remember all of these functions by just remembering that growth hormone increases everything except the glucose uptake. Glucose uptake is decreased. So in a sense, glucose in blood increases, right? So glucose in serum does increases. So everything increases. Now the antidiuretic hormone, that is also called vasopressin. So it is secreted from the supraoptic nuclei, I guess. And oxytocin was from paraventricular nuclei. Yeah, vasopressin from supraoptic and oxytocin from paraventricular nuclei. Synthesis in hypothalamus, supraoptic and paraventricular nuclei, stored and secreted by the posterior pituitary. It's a very basic question. Like, they wouldn't even mind asking these questions, that is it the posterior pituitary that makes ADH? No, it's the hypothalamus that makes ADH. Posterior pituitary just stores and secretes it. Function is regulates blood pressure through V1 receptor and serum osmolality through V2 receptors. Primary function is serum osmolality regulation. ADH decreases serum osmolality by reabsorbing the water, and increases urine osmolality by reabsorbing water from the urine. So urine will have less water, high osmolality. By regulation of aquaporin channel insertion in principal cells of renal collecting duct. So ADH acts on the collecting duct. ADH level is decreased in central diabetes insipidus, there is DI, and normal or increased in nephrogenic DI, because in nephrogenic DI they are just resistant to the action of the ADH, right? So there is enough ADH, but they are just the person is just resistant to the ADH. Okay. Nephrogenic DI can be caused by mutation in the V2 receptor. Desmopressin ADH analog is a treatment for central DI and nocturnal enuresis. In central DI, there is deficiency of ADH, right? So giving desmopressin, that is ADH analog, is going to help the patient, right? ADH can't be given in nephrogenic DI. Vasopressin is also a potent vasopressor that can be used to increase organ perfusion in septic shock. And regulation is by plasma osmolality and hypovolemia. Whenever there is hypovolemia, ADH is going to be secreted. It is going to reabsorb all the water from the urine, increasing the serum osmolality and also increasing the blood volume. That is causing euvolemia. Now the prolactin, secreted mainly by the anterior pituitary and structurally homologous to growth hormone. That is what we talked about. GH and prolactin are relative to each other. And function is stimulates milk production in the breast, inhibits ovulation in females and spermatogenesis in males by inhibiting GnRH synthesis and release, and excessive amount of prolactin associated with decreased libido. Right, because it is inhibiting spermatogenesis and right everything. So libido is obviously going to decrease. Regulation is prolactin secretion from anterior pituitary is tonically inhibited by dopamine from tubular infundibular pathway of hypothalamus. So prolactin in turn inhibits its own secretion by increasing the dopamine synthesis and secretion from hypothalamus. And so prolactin knows that it is inhibited by dopamine. So whenever prolactin wants to inhibit itself, it is going to stimulate dopamine secretion. Right, because dopamine will inhibit then prolactin. It's kind of a suicide. Right. So whenever prolactin wants to decrease, it is going to stimulate dopamine that can kill the prolactin itself. And TRH increases prolactin secretion and it also increases TSH secretion. Right, we saw that TRH increases two secretions, prolactin and TSH, like in primary or secondary hypothyroidism. Dopamine has stronger effects on prolactin regulation than TRH does. Okay. And dopamine agonists like bromocriptine and cabergoline inhibits prolactin secretion. Can be used in treatment of prolactinoma. Not can be, it is used in treatment of prolactinoma, right? In the medical treatment of prolactinoma. Dopamine antagonists like most antipsychotics and metoclopramide and estrogens, OCPs, and during pregnancy stimulate prolactin secretion. Right, this one is important, that antipsychotics, there are dopamine antagonists, that they stimulate prolactin secretion. But everything else you can just remember that during estrogen increase in pregnancy and OCP use, there is going to be galactoria, that is due to increased prolactin. And whenever there is prolactinoma, There is a pituitary kind of a pituitary adenoma. Most common type of pituitary adenoma is prolactinoma. There is going to be increased prolactin. So what prolactin does is, we saw that stimulates milk production. Yeah, that's all right. It's just going to cause galactoria, no big deal. And it also inhibits GnRH synthesis. That is what is important for us. So GnRH is going to be decreased, and LH is also going to be decreased, and somewhat FSH too, but GnRH has less effect on FSH, more effect on LH, that is luteinizing hormone. And due to decrease in luteinizing hormone, there is going to be hypogonadism. There is going to be an ovulation. We are just talking about the symptoms in female, alright, because prolactinomas are much more common in female than males. And then there's going to be amenorrhea, similar to what happens after delivery. And there's also going to be vaginal dryness and atrophy. So this is what similar happens to in menopause as well. Okay, there's vaginal dryness, amenorrhea, and ovulation, hypogonadism. Okay, decrease in LH and all that. Now, how is the prolactin regulated? So if during medications, chest wall injury, nipple stimulation, sight or cry of baby, that is going to inhibit dopamine, and due to inhibition of dopamine, there is going to be increase in prolactin, right? Then these are the final effects: ovulation, spermatogenesis, and son milk production. And during primary hypothyroidism, when TRH is going to increase the TSH, the side effect of that is it's also going to increase prolactin secretion. So in hypothyroidism, there can be galactoria in males. Okay, and pregnancy estrogen is also going to stimulate prolactin. Now comes the very important topic, both for physiology and for pathology, right? The thyroid. So thyroid produces triiodothyronine and thyroxine, iodine containing hormones that control the body's metabolic rate. Source is follicles of thyroid. 5' deiodinase converts T4 into T3 in peripheral tissues. So T4 is the major thyroid product that is secreted from the thyroid follicles, and it is then converted to T3, that is levothyroxine, in the peripheral tissues. And peripheral conversion is inhibited by glucocorticoids, beta blockers, and propylthyroid uracil. So that is why all of those drugs are used in hyperthyroidism. Right. So mostly glucocorticoids and beta blockers are saved for the thyroid storm-like emergencies. So, and day-to-day cases of hyperthyroidism can just be managed by propylthyroid uracil and methimazole. Right. Reverse T3, that is RT3, is metabolically inactive byproduct of the peripheral conversion of T4, and its production is increased by growth hormone and glucocorticoids. And functions of thyroid peroxidase include oxidation, organification, and coupling of monoiodine tyrosine, that is MIT and DIT. Right, so here thyroid peroxidase's functions are oxidation of iodine, that is I minus 1 to I0, that is oxidation, right? So oxidation, organification, that is binding of iodine with thyroglobulin, right? That is called organification. And then there is coupling too, that two MITs join and form a DIT. MIT and DIT may join and form, I don't know, TIT, something like that. It's just coupling reactions. Yeah, they form TIT, that is T3, in my opinion. Yeah, that was right. DIT plus DIT, T4. Why, I don't know why they call this T1, then T2, T3, T4. That would make things easier. But I guess that's not the way medicine works. So it is inhibited by propylthiouracil and methimazole. And DIT plus DIT is T4. DIT plus MIT is T3. Wolff-Chaikoff effect, which I could never remember. Now that I know this mnemonic, that is Chaikoff. So whatever happens, we have to turn off the thyroid peroxidase. We have to turn off the thyroid synthesis. Right? That is Wolff-Chaikoff effect. And that is protective autoregulation. Sudden exposure to excess iodine temporarily turns off thyroid peroxidase. So that is going to be decreased T3 and T4. Now the only free hormone is active, that is T3 binds nuclear receptor with greater affinity than T4. The functions of T3 are, so all the functions are performed by T3 after it is converted from T4 to T3. The 7 B's are brain maturation, bone growth, synergism with growth hormone. Just like growth hormone, it acts for bone growth. Then beta adrenergic effects, that is increases beta 1 receptors in heart, and increased beta 1 receptors means increased cardiac output, heart rate, stroke volume, contractility. And beta blockers alleviate adrenergic symptoms in thyrotoxicosis, that is thyroid storm that I talked about. So beta blockers are very handy in those emergency situations, especially the propranolol. The basal metabolic rate also increases via sodium, potassium, ATPase, increased O2 consumption, respiratory rate, and body temperature. The blood sugar, it increases glycogenolysis and gluconeogenesis. So that is going to increase glucose levels in the blood. Right? And it breaks down lipid. So there's going to be increased lipolysis, increased free fatty acids in the blood. It stimulates surfactant synthesis in babies. So this is important. Now its regulation is done by TRH mostly. TRH stimulates TSH release from the follicular cells. So it stimulates TSH release, and TSH in turn stimulates follicular cells. Now the thyroid stimulating immunoglobulins, PSI, may also stimulate follicular cells in Graves' disease. Okay. So Graves' disease causes hyperthyroidism. So there are thyroid stimulating immunoglobulins that may stimulate the follicular cells. Negative feedback primarily by free T3 and T4. Anterior pituitary, it decreases sensitivity to TRH. And to hypothalamus, it decreases the TRH secretion. Right. So not the bound T3, T4 gives the negative feedback, but regulation of TSH is done by free T3 and free T4. So it is going to act on anterior pituitary and decrease the sensitivity to TRH secreted from the hypothalamus, and then it is going to act on the hypothalamus to decrease the TRH secretion itself. And there's also thyroxine binding globulin, TBG, which binds most of the T3, T4 in blood, and the bound T3, T4 is inactive. Right. And this thyroid binding globulin globulin is a kind of protein, right? So this thyroid binding globulin increases in pregnancy in OCP use because estrogen leads to increase in TBG. And thyroid binding globulin decreases in steroid use because we are giving exogenous steroids. So TBG is a kind of steroid protein. Okay. So if we are giving exogenous steroid, there is going to be reduced endogenous TBG. And in nephrotic syndrome as well, because globulin is a protein counterpart, that is proteins are reduced in nephrotic syndromes, right? Now let's see a concept that during increase in estrogen, like in OCPs in pregnancy or hormone replacement theory for menopause, for hot flashes of menopause, so there's going to be increase in estrogen, right? So there's also going to be increase in thyroid binding globulin because it is a kind of steroid protein, right? So estrogen leads to increase in thyroid binding globulin. Once the thyroid binding globulin increases, it is going to bind all the free T3 and free T4 available in the serum. So that is going to lead to decrease in free T3, T4. And as we know, only free T3 and free T4 regulates the TSH secretion, right? So bound T3, T4 can't do anything, but free T3, T4 level regulates the TSH secretion. So if the free T3, T4 levels are decreasing, there's going to be TSH release. And TSH release is going to stimulate the follicular cells to release more of T4, right? And simultaneously, more T4 will get converted into more T3 peripherally. So this thing, increase in T4, T3 due to increase in TSH. Right. So they will keep on increasing till the thyroid binding globulin gets saturated, right? Because these are free T3, T4 being released from the thyroid. So they are going to keep being secreted in the body till it gets saturated by thyroid binding globulin. And once the TBG gets saturated with free T3, T4, everything is bound to TBG. The stores will be restored, and then the free T3, T4 will increase, right? T3, T4 will increase till TBG gets saturated. And once it gets saturated, then free T3, T4 stores will be restored. So then the person will become euthyroid. And total, if we count total T3, T4, it is going to increase because total T3, T4 consists of bound plus free. So we are increasing bound T3, T4. So that is going to lead to total increase in total T3, T4. And T3 and T4 are the only lipophilic hormones with charged amino acids and require specific transporters to diffuse into the cell. This facilitated diffusion. So now let's see first let's see these regulatory drugs. That somatostatin, dopamine and glucocorticoids will inhibit anterior pituitary to release TSH, right? And thyroid stimulating immunoglobulins in Graves' disease is going to stimulate thyroid follicular cells. Now the iodine that we take with the salt and everything, that iodide ion and sodium, they are being transported into follicular epithelial cell through co-transporter. And once it is in the follicular cell, the iodide undergoes oxidation and enters the follicular lumen and becomes iodine, I think I2. And there's thyroglobulin also being secreted from the follicular cell, that is formed by the tyrosine and MIT and DIT, right? So the amino acid behind thyroglobulin is tyrosine. And in the lumen, when thyroglobulin binds to I2, that is called organification. It leads to formation of MIT, right? And then there are coupling reactions to form DIT, T3 and T4. Right, so oxidation, organification and coupling, all three reactions are activated by the enzyme thyroid peroxidase. Right, all three steps: oxidation, organification and coupling. And once the MIT, DIT, T3, T4 are formed, they undergo endocytosis and enters the follicular cell again, and from that it enters the blood by proteases, because it is bound to each other, and also thyroglobulin. So to get separated from each other, like T3 and T4 and MIT and DIT all are joined to thyroglobulin together. So to separate them, there are proteases, which cleaves them and secretes the free hormones into the blood. Now in peripheral tissues, T4, and so T3 is also secreted from the thyroid, but it is in very low quantity, right? So the main source of T3 is from the peripheral conversion of T4 to T3 through 5-deiodinase enzyme. Like it's in the name itself, that deiodinase. So it is going to remove one iodide. So if you remove one iodine from T4, it is going to convert it into T3, and then it has all the downstream thyroid functions. All the functions are done by T3 and not T4. Okay. And the remaining MIT and DIT, that was also bound in the thyroglobulin. So after being separated by the protease, that MIT and DIT goes back to binding tyrosine and forming thyroglobulin again. And also from DIT, there is deiodination, that is removal of one iodine. So that is going to again form iodide ion. Yeah, so this is monoiodotyrosine, right? So we are going to separate iodine and we are going to separate tyrosine. So tyrosine goes back to forming thyroglobulin and iodine goes back to being iodide ion. Now let's see the drugs that act on these pathway. So there are just two drugs you have to remember, that is propylthiouracil and methimazole. Okay. So both of them inhibits thyroid peroxidase, and thyroid peroxidase stimulates all three of the reactions, that is oxidation, organification and coupling reaction. And propylthiouracil has an extra effect, that is it inhibits peripheral conversion of T4 into T3, that is inhibiting 5-deiodinase. Okay, here it is. And also there are beta blockers and ipodate, that is contrast agent, that inhibits the 5'-deiodinase enzyme, which leads to inhibition of T4 and inhibition of conversion of T4 to T3. Also there's one more drug, but whenever we give iodine, exogenous iodide, so that is going to inhibit this entry of iodide ion into the follicular cell, and also exit of T3 and T4 hormones into the blood. So it is going to inhibit iodide absorption into thyroid and secretion of T3 T4 from thyroid. So that is the Wolff-Chaikoff effect. Okay, so if there is sudden exposure to iodine, that is going to turn off everything, right? Now the parathyroid hormone. So the source of PTH is the chief cells of parathyroid. Its functions are to increase calcium in the blood, free calcium in the blood. That is the primary function, and that is the basis of all the pathways and all the mechanisms of these hormones. We will understand that it increases calcium in the blood. So to increase calcium, it also has to increase absorption from the GI system. It increases phosphate absorption too. It increases calcium and phosphate from bone resorption. Right? It increases calcium reabsorption from distal convoluted tubule. And it decreases phosphate reabsorption in PCT. So what it does to phosphate is it absorbs phosphate from the GI, it resorbs phosphate from the bones, it increases phosphate in the blood, and then also it increases the phosphate excretion from the PCT. Right. So it is just stealing phosphate from intestine and bones just to excrete it through the PCT. Right. And 1,25-dihydroxy D3, that is calcitriol, production is increased by activating 1-alpha hydroxylase in PCT. Right, that we've talked about sarcoidosis in the respiratory system. There was also 1-alpha hydroxylase activity in the activated macrophages, which was leading to increased calcitriol production and increased hypercalcemia. Right. So this is how it does that. Parathyroid hormone increases calcitriol production by activating the 1-alpha hydroxylase in the PCT. So try to make D3 in the PCT. Now PTH increases serum calcium, decreases serum phosphate by excreting it through the PCT, increases urine phosphate and increases urine CAM. Increases rank L receptor activator of NFK beta ligand secreted by osteoblast and osteocyte, binds rank on the osteoclast and their precursors to stimulate osteoclast and increase calcium, that is by bone resorption. So osteocytes and osteoblasts both have rank ligand on their surface, and osteoclasts have rank on their surface. So what PTH does is PTH is going to stimulate those rank ligands on osteocytes and osteoblasts and make sure that rank ligand binds to the ranks on the surface of osteoclast. So whenever rank ligand will bind to rank, there is going to be activation of those osteoclasts. Remember, osteoclasts, it leads to activation of osteoclast, and that will going to cause bone resorption, right? And if bone resorption is occurring, calcium is going to increase in the blood. So PTH is going to stimulate rank ligand on osteoblast. So osteoblast is activated, and activated osteoblast rank ligand will bind to rank of osteoclast, which is going to activate osteoclasts, It is going to cause bone resorption. And these effects vary on the levels of PTH, right? Because we know that osteoblast is bone forming and osteoclast is bone resorbing or bone cutter cells. I like to remember it that way. Clast for cutter, it is a bone cutter cells, so it is going to cut bone and increase the calcium in serum. And osteoblast is bone forming, so it is going to make bones and decrease calcium from the serum for forming those bones. So it all depends on the level of parathyroid hormones. Like if it's hyperparathyroidism, well, PTH is way too high, it is going to stimulate more and more rank L, right? But at the same time, it is also going to inhibit the OPG, that is osteoprotogerin, which normally inhibits osteoclasts. Yeah. So if we are decreasing the osteoclast, it does not inhibit osteoclast, but it inhibits the NFK beta of rank and rank ligand, right? So yeah, it indirectly inhibits osteoclast. So in hyperparathyroidism, it is going to stimulate rank ligand too much, and it is also going to inhibit osteoprotogerin, which was inhibiting osteoclast. So what happens as a result is osteoclast activation is more than osteoblast, right? There is no one to inhibit osteoclasts. So if osteoclasts are going to be more activated than osteoblast, there is going to be more and more bone resorption and increase in calcium levels in the serum. That we'll discuss it later on too. I will draw out the whole pathway of this bone formation and calcium mechanism, right? But I was just briefing about this to you. So bone resorption in intermittent PTH release, right? Now, bone resorption. So normal function of parathyroid hormone is bone resorption to activate osteoclasts eventually, but when it is secreted intermittently, it can also stimulate bone formation, right? Because it is activating osteoclast through osteoblast. Then PTH-related peptide functions like PTH and is commonly increased in malignancies like in squamous cell carcinoma of the lung and the renal cell carcinoma. This is an important paraneoplastic effect of squamous cell carcinoma. So the effect of small cell carcinoma is Cushing syndrome, Lambert-Eaton, SIADH, all that. The paraneoplastic effect of squamous cell is mostly hyperparathyroidism, and the other effect of adenocarcinoma is clubbing and osteoarthropathy, right? So that is not kind of a paraneoplastic effect, it's just an effect of lung cancers, that is effect of just lung malignancy. Then there's large cell carcinoma, its paraneoplastic is large breast, that is gynecomastia. So regulation is whenever serum calcium goes down, it secretes PTH to increase the calcium back to normal levels. Increase phosphate levels, it secretes PTH to decrease down the phosphate to normal levels. Decrease serum magnesium, it increases PTH. Calcium and magnesium have same effects generally on the body. Decrease serum magnesium will decrease PTH secretion. At very low levels of magnesium, there is also going to be inhibition of PTH. So common causes of decreased magnesium include diarrhea, aminoglycosides, and diuretics and alcohol use disorders. So let me write this thing down so that you can note it too. Pulsatile PTH, we've already discussed this. I'm just writing it down. High PTH, that is hyperparathyroidism. So I'm just trying to keep things as simple as I can, because this is the topic which was never clear to me during my med school. It was just when I'm preparing for step 1, I got this concepts clear in my head. So I'm trying to keep things very simple for you guys too. Ionized calcium decreases, phosphate increase, decrease in calcitriol. They are all going to stimulate PTH release from follicular cells, not follicular cells but the chief cells. Then it acts on the renal tubular cells, increase calcitriol synthesis, reabsorbing calcium, excreting phosphate, that is decreasing the reabsorption of phosphate, decreasing urine calcium and increasing urinary phosphate. That all leads to increased calcium in blood and decreased phosphate in blood. Right, so whenever calcium starts increasing, it is going to inhibit PTH by feedback inhibition. Whenever phosphate is decreasing, it is going to inhibit PTH. It does not need PTH anymore. So that is the meaning of feedback inhibition. Whenever hormone is enough in the body, normal enough in the body, it does not need its stimulating hormones anymore. So they are going to give feedback to that stimulatory hormone that now we don't need you guys, so keep it down. So it acts on renal tubular cells and also release calcitriol by activating, as we saw, 1-alpha hydroxylase in the PCT. Right. Now PTH released into circulation, this was the effect on kidneys. What was the effect on bones? So it is the PTH is going to stimulate secretion of calcitriol by activating 1-alpha hydroxylase, right? 1-alpha hydroxylase is also activated by decreased phosphate. And the calcitriol that is being formed, it will act on bone to increase calcium and phosphate resorption. So that is, bone resorption will increase calcium and phosphate in the blood, and on intestine it is going to increase absorption of calcium and phosphate. So the total effect here is increased calcium as well as increased phosphate. But in kidney, the total effect is increased calcium in the blood and decreased phosphate in the blood. So this is the method through which phosphate increases its own production too, right? Whenever there is decreased phosphate, that it's going to activate 1-alpha hydroxylase and activate the secretion of calcitriol. So it knows that calcitriol is going to resorb phosphate from the bone and increase the absorption from the intestine, and then the levels of phosphate is going to increase in the blood. So phosphate itself mediates this mechanism along with PTH. Let's discuss the osteoblast and osteoclast mechanisms, right? Because I want to add a few things to it too. So first of all, this is an osteocyte or osteoblast. It has rank L on its surface. So it has rank L on its surface, which can be stimulated by two things. That is, the first is parathyroid hormone, and the second is osteoprotegerin. Right, so we'll first talk about the osteoprotegerin. So whenever PTH stimulates the rank ligand, right, then it is going to bind to osteoclast. And once rank of osteoclast binds to rank ligand of osteoblast, there is going to be activation of osteoclast. That is going to lead to bone resorption and increase in calcium. Right. So in short, we can say that whenever there is high rank ligand activation, there is going to be bone resorption. But now what happens when osteoprotegerin acts? So the effect of osteoprotegerin is to inhibit rank ligand. Okay, so then it is going to bind to the rank ligand, inhibiting its function to bind to rank on the osteoclast. So when the OPG is binding to rank ligand on the osteoblast, it is preventing the rank ligand to bind to rank on the osteoclast, hence inhibiting the activation of osteoclast, hence decreasing the bone resorption. Right, so now let's further complicate things. You should note this down, guys, because I'm going to erase it all, and because I want to make space for something else. Right. So now let's see the whole picture and how different things affect different steps of these mechanisms. So osteoblast is formed from the osteoblast precursor, function of it is to form bones. Right. Then on the other hand, there's osteoclasts. Its function is to cut bones. Right. That is called resorption. And there are several things that affect both the formation of osteoblast and osteoclast. So for the osteoblasts, we have a few things like estrogen, first of all, can stimulate osteoblast formation. Then there was intermittent PTH. That stimulates osteoblast production, and also the rank ligand. I don't need to mention it, so that's okay. Right, so that's just these two main things. Right, for now, things will get more clearer. And the osteoclast, there are several things that stimulates osteoclast. Like first of all, the T3. Because hyperthyroidism may lead to osteoporosis by this mechanism. And so just keep in mind. And then there's PTH of hyperthyroidism, not intermittent. Intermittent parathyroid hormone stimulates osteoblast, but in hyperthyroidism, it stimulates osteoclast. And the main culprit here is the glucocorticoids. Glucocorticoids has effect on both of them. So first of all, it is going to inhibit the conversion of osteoblast precursors into osteoblast. It inhibits osteoblast precursors, right? It also decreases intestinal calcium absorption. And then it has a positive effect on NFK beta of rank and rank ligand. And as we know, the rank and rank ligand stimulates the activation of osteoclasts. And so I don't want to write this PTH here because it doesn't have direct effect on osteoclasts. It acts through the NFK beta. So PTH in hyperparathyroid activates NFK beta of rank and rank ligand, and there's another culprit, that is osteoprotegerine. That usually inhibits NFK beta, but the glucocorticoids takes care of that too by inhibiting osteoprotegerine. Right, so glucocorticoid will do anything in his power to keep activated osteoclasts in place. Right, it will inhibit the osteoblast formation, it will inhibit the intestinal calcium absorption, and it will inhibit the osteoprotegerine. He was trying to inhibit the rank and rank ligand. Glucocorticoids will make sure that it activates the NFK beta of rank and rank ligand so that it can activate osteoclasts. Right, so glucocorticoid does everything. And for the parathyroid hormone, in hyperparathyroid state, it is also going to inhibit osteoprotegerine. Right, so that is why once the osteoprotegerine OPG was the one and only thing that was inhibiting osteoclast, and now they are also out of the way because of parathyroid hormone, so there is nothing that is inhibiting osteoclasts. Right, so there is going to be more activation of osteoclasts than blasts, hence more bone resorption in hyper PTH states. There is also the estrogen that activates osteoblast. They are going to inhibit osteoclasts as well. Right, so that's it. Just go through this, make a sticky note out of this and stick it on the wall, like me, if you don't know how to keep remembering these things. Right, so these are the important points, that NFK beta of rank and rank ligand are always going to activate osteoclast, and glucocorticoids will activate NFK beta. Osteoprotegerine will try to inhibit NFK beta, and glucocorticoids and parathyroid hormone together is going to inhibit osteoprotegerine. Right, and glucocorticoids, as it is stimulating osteoclast, it is going to inhibit the osteoblast formation. Looks pretty. Okay, so now the calcium homeostasis, that is plasma calcium exists in three forms: ionized free, that is 45% active form. Only the free form, that is ionized calcium, is the active form, and that consists of 45%. Bound to albumin is another 40%, and bound to anions is another 15%. So ionized free calcium is primary regulator of PTH. Everywhere the free ions are the regulator of everything. Even in thyroid, the free T3 and free T4 were regulators of TSH release and TRH release. So changes in pH alter the PTH secretion, whereas changes in albumin concentration does not. Right, because as uh, we'll see that later on. So calcium competes with hydrogen ion to bind to albumin, right? So that is why it changes in pH, alter the PTH secretion, because increasing pH, which means alkalosis, which means less hydrogen ion, so there is more space on albumin, right? So albumin binds more calcium, and if the free calcium is being bound to the albumin, there's going to be less ionized calcium or less free calcium in the blood, right? And as there is less free calcium, it is going to increase the PTH release, because only the free calcium can regulate the PTH release. So decreased free ionized calcium will cause cramps, pain, paresthesia, carpopedal spasm, everything, and going to release PTH. And decreased pH, that is more H plus ion in acidotic state. So more hydrogen ion in acidotic state will take all the place on the albumin, and there will be very less space for the calcium to bind to the albumin. So there is going to be increase in free calcium, and increase in free ionized calcium is going to decrease the parathormone secretion. So just remember, in acidosis there is hypercalcemia, and in alkalosis there is hypocalcemia. There is acidosis state and there is alkalosis. Now the calcitonin that is released from parafollicular cells, C cells of thyroid, it also gives rise to medullary thyroid carcinoma of thyroid, where calcitonin is increased. The function is to reduce the bone resorption, increased serum calcium, and increased calcitonin secretion. So increased serum calcium is a regulator for calcitonin. So calcitonin opposes action of PTH, not important in normal calcium hemostasis. Therefore, there is no questions also being asked from the calcitonin section. Calcitonin tones down serum calcium levels and keeps it in the bones. Glucagon made by alpha cells of pancreas promote glycogenolysis, gluconeogenesis, lipolysis, ketogenesis. Right, everything that can help with increasing sugar in the body, increasing the glucose levels in the body, it will do everything, mostly the gluconeogenesis and glycogenolysis. Elevates blood sugar levels to maintain homeostasis when bloodstream glucose level falls too low. Secreted in response to hypoglycemia, inhibited by insulin, amylin, somatostatin, and hyperglycemia. So you must know that there are insulin syringes available for diabetes patients, right? Diabetes mellitus patients. But there are also glucagon syringes being available now for diabetes patients for in cases of hypoglycemia. Right. So in hypoglycemic emergencies, the patient will just take glucagon syringes, and what glucagon will do, so it will cause the glucose level to get normal very rapidly by increasing first glycogenolysis. So first it is going to increase glycogenolysis, and then it is also going to increase gluconeogenesis, and then it is also going to decrease hepatic glucose uptake. And the insulin is a long protein, and first it is synthesized in the rough endoplasmic reticulum of pancreatic beta cells as proinsulin, and thereafter the cleavage of pre-signal occurs, and it is formed as proinsulin stored in the secretory granules. Then the cleavage of proinsulin will then undergo exocytosis along with C-peptide, right? And both insulin and C-peptide are increased in endogenous insulin secretion, like in type 2 DM, and insulin secretagogues and insulinoma, right? Whereas exogenous insulin lacks C-peptide. That's very simple. So the exogenous insulin, like in people take in type 1 diabetes, they will lack C-peptides. So there's going to be questions around this. There will be increased insulin levels and normal C-peptide levels in the question stem, and then you have to figure out that was it from the endogenous insulin secretion, like was it from the insulinoma, or the patient is just taking exogenous insulin. It may be a kind of abuse, or it can be for type 1 DM. Right. So if it's insulinoma, the C-peptide levels are also going to increase. But if it's just exogenous insulin abuse or something like that, it's just the C-peptides level are going to be normal. Now the functions of insulin is to binds insulin receptors through tyrosine kinase activity, inducing glucose uptake, carrier-mediated transport into insulin-dependent tissues, and gene transcription. So insulin enters through tyrosine phosphorylation, tyrosine kinase pathway. It undergoes phosphoinositide 3 kinase, it is PIK3 pathway. And that PIK3 pathway is going to transport the GLUT4 to the membrane of the cells. So GLUT4s are contained into a vesicle in the cytoplasm. So activation of PIK3 pathway will activate those vesicles and make sure the transport of GLUT4 happens to the membranes. Right? So through that GLUT4 transmembranes, glucose enters into the cell. And it also PIK3 pathway also stimulates glycogen, lipid, and protein synthesis pathways. Then there's RAS and MAP kinase pathway, so that is going to increase cell growth, and DNA synthesis. Anabolic effects of insulin: increase glucose transport in skeletal muscle and adipose tissue, glycogen synthesis and storage increase, triglyceride synthesis increase, sodium retention in kidneys, protein synthesis in muscle, cellular uptake of potassium and amino acids. Right? We saw that only either insulin or potassium can stay in the blood. So whenever there is increased insulin, it is going to push potassium back into the cells. Decrease glucagon release because it was increasing the glucose. We don't need anything that increases glucose in the blood. And decrease lipolysis in adipose tissue. So lipolysis was causing increased free fatty acids that were substrates for gluconeogenesis pathways. So we don't need anything that increases glucose secretion in the blood. So we inhibit the lipolysis through insulin. Unlike glucose, insulin does not cross placenta. Right, so that is one of the things for fetal hyperglycemia, neonatal hyperglycemia, because if the mother is diabetic, there's going to be increased glucose, there's going to be hyperglycemia, so glucose will travel across the placenta into the fetus, but there's going to be insulin to tackle that in the mother, but there is going to be limited insulin in the fetus. So after birth, when there is increased glucose in the baby and not enough insulin to tackle it with, there's going to be fetal hyperglycemia in the diabetic mothers. Now the insulin dependent glucose transporters are just GLUT4, that is adipose tissue and striated muscle. Exercise can also increase GLUT4 expression for making the growth of the muscles. Insulin independent transporters are GLUT1 in RBCs, brain, cornea, placenta, and GLUT2, that is in beta islet cells, liver, kidneys, GI tract, all those that have two ways, right? All those which have bidirectional flows, like liver has bidirectional flow, kidney, GI tract. GLUT3 in brain and placenta, just like in GLUT1. GLUT5 is important because it also transports fructose in spermatocytes and GI tract. SGLT1 and SGLT2 are also again important, that it also transports sodium along with glucose. And we have SGLT2 inhibitors which inhibits these transporters, right? And brain prefers glucose but may use ketone bodies during starvation. RBCs utilize only glucose as they lack mitochondria for aerobic metabolism. And this you don't need a mnemonic to remember this. Just remember that adipose tissue and striated muscle are the only two things that require insulin dependent glucose transportation. So now the regulation of insulin. Glucose is the major regulator of insulin release. Increased insulin response with oral versus IV glucose due to incretins, that is GLP-1, glucagon-like peptide 1. That is only released when there is oral glucose intake. Glucose-dependent insulinotropic polypeptide, GIP, which are released after meals, and increased beta cell sensitivity to glucose. The release is reduced by alpha-2 and increased by beta-2 stimulation. Because as we know, alpha-2 is always inhibitory in nature. Right? Alpha-1, beta-1, beta-2 does vasodilation, and alpha-2 says, no, I'll do vasoconstriction. It is always inhibitory in that sense. So it is also going to decrease insulin here. And beta-2 increases insulin, and also M3 receptors in the pancreas will release insulin at the site of smell, and at the site or smell sensation, that is going to stimulate M3 receptors, that is going to release insulin. Now glucose enters beta cells after glucose intake. Increase ATP generated from glucose metabolism. So ratio of ATP to ADP increases, and there are ATP sensitive potassium channels. So whenever there is enough ATP inside the cell, those channels are going to close. Right. So there is also the targets of sulfonylureas. It depolarizes the beta cell membrane, so there's going to be increased potassium inside the cell, which is going to depolarize the membrane, and that depolarization is going to stimulate the voltage grid calcium channels. Right. So once the calcium channel is open, calcium always travels inside. So intracellular calcium is going to increase and cause exocytosis of insulin from the insulin granules. Right. These are the secretory granules. Right. Insulin is formed from the pre-proinsulin that was in rough endoplasmic reticulum, then the proinsulin that was in the secretory granules, right? And from that, a release of insulin and C-peptide occurs because of increase in intracellular calcium levels. Right. It's very simple. Also, there's I just want to add one more thing here. I don't know if it's related to this or not. It might not be related to the insulin section, but the brown adipose tissue in humans, right, it has thermogenin protein. So there is increased thermogenin secretion from the brown adipose tissue, and only adults have increased brown adipose tissue. And what thermogenin does is it uncouples the oxygen phosphorylation. What does uncouple means? It lets hydrogen leave the mitochondria without formation of any ATP. Right. So normal oxidation phosphorylation is going to it goes like it keeps on absorbing hydrogen from the mitochondrial membrane into the matrix, and that leads to ATP synthase formation, ATP synthase stimulation, and that leads to increased formation of ATP. But now H plus will leave mitochondria without forming that ATP, and that is called heat generation, right? Because it's an inefficient system. It's not producing any energy. It is just working out, right? Just like electronic item which is not repaired for a long time, so its efficiency is going to decrease and it is going to produce more and more heat, right? If there's a table fan that is working for years now, so there's going to be more heating of that table fan, and there's going to be less energy being formed in the form of rotation of the fan. And I don't know, it's a physics thing apparently. So it uncouples oxygen phosphorylation, hydrogen leaves mitochondria, without forming ATP, so the heat is dissipated. So it is important to dissipate this heat too, right? That is how we maintain homeostasis in adults. So in neonates, there's going to be decreased adipose tissue, right? Decreased brown adipose tissue. Brown adipose tissue is mostly in the back or the nape of the neck regions. So in babies, there's less brown adipose tissue, and hence they can dissipate the heat less and has less homeostasis. So they are more prone to hypothermia, right? That is why they are more prone to hypothermia. Now, the very important topic, right? There are so many questions from the 21 hydroxylase enzyme deficiency. You don't need to remember this whole chart by yourself. You just have to keep in mind that cholesterol synthesis is activated by ACTH and inhibited by ketoconazole, right? So it is not just inhibiting the cholesterol conversion into pregnenolone, but it is inhibiting the whole steroid synthesis. So ACTH stimulates that steroid synthesis from adrenal glands, and ketoconazole inhibit the steroid synthesis. So now, which three enzymes are important here to be discussed? That is 17 alpha hydroxylase, 21 hydroxylase, and 11 beta hydroxylase. So there are 4 parts of this diagram. The first is zona glomerulosa, second is fasciculata, third is reticularis, and fourth is the peripheral tissues. And we know that these 3 zones secrete salt, sugar, and sex. Salt is aldosterone, sugar is cortisol, and sex is the androgens, right? Partly androgens. The peripheral conversion will form estrogen, right? So yeah, now let's see this diagram slowly. So cholesterol forms pregnenolone, that forms progesterone, that forms 11-deoxycortisone, which has a MR action, mild MR action too, that is going to lead to hypertension in the case that we'll see. And this step is important. This you have to remember, that from progesterone 11-deoxycorticosterone is formed by the help of 21 hydroxylase, and from progesterone through 17 alpha hydroxylase 17 hydroxyprogesterone is formed, right, which will form 11-deoxycortisol. So corticosterone is formed, and from that aldosterone is being formed. So angiotensin 2 also stimulates active secretion of aldosterone, as we know. Then there's this enzyme is important, 17 alpha hydroxylase, because it also converts progesterone into 11 hydroxyprogesterone and pregnenolone into 17 hydroxypregnenolone. So it just adds its 17 hydroxyl group to the progesterone as well as pregnenolone, because the enzyme is 17 alpha hydroxylase. So that 17 hydroxyprogesterone will convert to deoxycortisol, which will convert to cortisol, right? And cortisol will convert to cortisone. That is not very important for us. Till here it is very important. That metyrapone also inhibits cortisol secretion. Right. So that is why it's also used in that metyrapone stimulation tests, right, in the Cushing syndrome. So if we administer the metyrapone, it is going to inhibit this step, right, formation of 11-deoxycortisol, and it is also going to increase 11-deoxycorticosterone and 17-hydroxycorticosteroid in urine. So it is going to increase 11-deoxycortisol in serum in the metyrapone stimulation test, and it is going to increase 11-deoxycorticosterone in urine, right? And if that happens, we can say that Cushing syndrome is positive. Yeah, so if these 11-deoxycortisol and 11-deoxycorticosterone increases, that is very normal. Okay, so in adrenal insufficiency, there is going to be low ACTH, right? There is going to be low ACTH, so that is also going to form less 11-deoxycorticosterone, and its levels are not going to increase as much as we expected. Right? So that is a positive meta-aeropon stimulation test. If these enzymes does not increase, that is how we know that is there is adrenal insufficiency there. Right, and the third in the reticularis, this 17 hydroxypregnenolone and 17 hydroxyprogesterone will form DHEA and androstenedione respectively. So DHEA is the main thing here. So from DHEA, there is going to be formation of androstenedione and then testosterone. Now, the peripheral aromatization takes place. So from estrone and androstenedione, estrone, that is E1, is going to form in peripheral tissues, and from testosterone, E2, that is estradiol, is going to form in the peripheral tissues through the enzyme aromatase. And testosterone, to have its effect on the body, is going to convert it into dihydrotestosterone through 5-alpha reductase. Right. And these are the drugs that have effect on the aromatase, that are anastrozole, letrozole, and hexamatase, which inhibits aromatase enzyme and conversion of these steroid hormones to estrogen. Right, so where are these needed? In cases like breast cancer, where we need to reduce the estrogen levels in the body, we give aromatase inhibitors. Right, so they are going to decrease estrogen and increase testosterone. So the decrease in estrogen will lead to decrease breast cancer size, and increase in testosterone will cause hirsutism as its side effect. And 5-alpha reductase inhibitor is finasteride. And finasteride is used in BPH, that is benign prostatic hyperplasia. So one of the effect of DHT is growth of prostate, so we need to stop that in BPH, so we give finasteride that can inhibit 5-alpha reductase to reduce the DHT levels. Now if the patient is taking exogenous steroid hormones, right, it is those steroid hormones can convert it into estrogen by peripheral aromatization, right? And so the estrogen and testosterone estrogen and testosterone ratio may get disrupted in the body, and it can cause gynecomastia. The estrogen increases and testosterone is normal because of exogenous steroids. That are peripherally being converted into estrogen. By aromatization. So this disrupted ET ratio can lead to gynecomastia. Now let's discuss the enzyme deficiencies. So the first is 17 alpha hydroxylase. So where's 17 alpha hydroxylase? Here it is. So if this step is cut off, right, there is not going to be any formation of hormones in zona fasciculata or zona reticularis, right? That's just going to be increase this pathway. Right. So everything down this pathway will be increased. So just so you know that zona glomerulosa forms aldosterone, and function of aldosterone is to retain the sodium and the water, which will lead to increased blood volume and hence increased blood pressure. And it also forms 11-deoxycorticosterone that we talked about. It has MR action, that is mineralocorticoid receptor action, right? So that too will favor the increasing BP, but it's not very relevant in 17 alpha hydroxylation. This MR action of 11-deoxycorticosterone is very crucial in 11 beta hydroxylase deficiency that we'll see later on. So mineralocorticoids will increase, BP will increase. Cortisol is secreted from fasciculata, so that will decrease. Sex hormones from reticularis, so that will decrease. And labs will show decrease androstenedione. Right, here is androstenedione, so we can test for that, and that is going to be decreased. And as sex hormones are decreased, so there's going to be decreased formation of sex organs, right? And in XY, that is in boys, it will present as atypical genitalia, that an undescended testis, and in girls XX, it is going to cause decreased secondary sexual development, like the breast formation or the pubarch, everything that will be decreased. Second is 21 hydroxylase. So here is 21 hydroxylase. So if this step is being inhibited, everything will go to reticularis, right? Whole this pathway will be overstimulated. So there's going to be increased sex hormones, that is reverse of 17 alpha hydroxylase. So what happens if there is increased sex hormones? So in girls, if there is increased sex hormones, that is increased testosterone, increased dihydrotestosterone, right? So that is going to lead to so dihydrotestosterone, the first thing you should remember about it is it helps in the formation of external genitalia. This dihydrotestosterone helps in the formation of external genitalia. So if in females there's or in newborn girls, newborn female, there is increased dihydrotestosterone, it is going to form virilization, that is enlargement of clitoris, right? So all the external genitalia are going to enlarge, and that is called virilization or ambiguous genitalia in female. So that is the case for female. But what happens to the male newborns? So during puberty, due to increased testosterone and increased dihydrotestosterone, there is going to be precocious puberty, right? Early puberty. Yes, and so that is the effect of increased sex hormones. But what is the effect of decreased aldosterone and decreased cortisol? So due to decreased cortisol, there is going to be decreased blood pressure, because the sodium and water will be wasted from the kidneys, right? So mineralocorticoid action is decreased. Potassium is increased, because now potassium can't be excreted out. BP is going to decrease, cortisol decrease, sex hormones increase. And how do we diagnose it? We diagnose it by measuring 17 hydroxy progesterone. Here is the 17 hydroxy progesterone. So that is going to, if this is just cut off here, so this 17 hydroxy progesterone is going to increase, right? And also renin activity will increase because there is less aldosterone, right? So it will be a veiled attempt to increase aldosterone by increasing the renin. And yeah, about this 21 hydroxylase, there are like 3 kinds of these deficiencies. So early onset, which is classical, that is salt wasting type. Then there's late onset and very late onset, that is in adult life. So in the classical salt wasting, that is in just few weeks after life, that is the salt wasting type. And in that, this hypotension effect is more pronounced. So at 1 to 2 weeks of life, there's going to be vomiting, hypotension. In adults, the hypotension isn't much pronounced. So in puberty, you just have to diagnose it by the precocious puberty and virilization or anything. Hypotension will be less pronounced. Okay. And there will be ambiguous genitalia in girls. There will be no difference in there will be no differentials in the genitalia of boys at the 1 to 2 weeks of life. So in boys, there will be just vomiting and hypotension, whereas in girls, there will be vomiting, hypotension, as well as ambiguous genitalia, that is enlarged clitoris, right? And so yeah, let me just write it down here, that hypotension is not much pronounced in adult life. But for theory purpose, we have to remember that 21 hydroxylase forms hypotension as well as precocious puberty and virilization. Also, if you want to just simplify things, remember that if it is a male, if there is a question of congenital adrenal hyperplasia with deficiency of enzymes, you just have to remember these things, that if it's a male patient, there's going to be precocious puberty, and if it's a female patient, there is going to be virilization. There is not going to be any other changes in the genitalia of patients with these enzyme deficiencies. Right. And in 17 alpha hydroxylase, you just have to remember that there is just absence of sex hormones at all. Right, so you don't have to worry about puberty being precocious or virilization or anything. The sex hormones are absent altogether. Right? It's just in the difference between 21 hydroxylase and 11 beta hydroxylase that we are confused about. And so 11 beta hydroxylase, here is the 11 beta hydroxylase. There's going to be inhibition at this level. So the sex hormones are going to increase, right? Just like 21 hydroxylase, but now 11 deoxycorticosterone is also increasing, which has action on the mineralocorticoid receptors, right? So it can activate mineralocorticoid receptors that are aldosterone receptors, but in a mild fashion. So there's decreased aldosterone, right? Because the step is being inhibited, so aldosterone is going to decrease. But BP is going to increase because 11 deoxycorticosterone results in increased BP. Right. And the other effects are just as similar to 21 hydroxylase. Like the cortisol is going to decrease, sex hormones increasing, renin activity here is going to decrease because there is mineralocorticoid action, right? There is increase in BP, so and there is increased enough GFR2, so there's no need to activate renin, right? Renin is always activated when there is low blood volume and resulting in low GFR, so that stimulates renin. But here, as the BP is high, there's high blood volume, there's no need for renin to activate. Presents in infancy severe hypertension or childhood with precocious puberty. And in females, it will cause virilization because of increased sex hormones. Right? And in male, it is causing precocious puberty. In female, it is causing virilization. And in infancy, no matter what the gender is, it is causing severe hypertension. So it's just like 21 hydroxylase, but there's just hypertension being added because of the MR activity of 11 deoxycorticosterone. Right, and there's very easy mnemonic, if not a mnemonic but just a thing to remember, that then if the enzyme starts with 1, it is going to cause hypertension. If it's ending with 1, it is going to cause virilization and precocious puberty. And if it starts with 1 and ends with 1, that is 11 beta hydroxylase, it is going to cause both. Right, so it's very simple. There's nothing wrong with remembering it this way, right? So all congenital adrenal enzyme deficiencies are autosomal recessive. Because it's an enzyme deficiency, it's most likely that they are autosomal recessive. Most are characterized by skin hyperpigmentation due to increased MSH production, which is co-produced and secreted by ACTH with ACTH, and bilateral adrenal gland enlargement due to increased ACTH stimulation. Because the adrenal glands aren't producing enough hormones one way or the other, either it's not forming enough aldosterone or it's not forming enough sex hormones, so there's going to be stimulation to pituitary gland to secrete more ACTH, and in response to that ACTH there's going to be hyperplasia of the adrenal glands. Though the problem isn't with the adrenal glands, but it's with the enzymes of the adrenal glands that is not letting the hormones form, right? So that is again a veiled attempt by pituitary's ACTH to somehow increase the enzyme levels by stimulating adrenal glands and causing hyperplasia of the adrenal glands. Right, and similar effect can be produced by metyrapone as well. So because metyrapone inhibits this enzyme 11 beta hydroxylase, so similar effect will be formed. Right. Hypertension, virilization, precocious puberty, everything. So what is the treatment of this adrenal hyperplasia, enzyme deficiency? We give glucocorticoids. Right. So what glucocorticoids does is it inhibits ACTH secretion, and once the ACTH secretion is being inhibited, there's going to be decreased hyperplasia. And also, if there's a deficiency of sex hormones, glucocorticoids will help with that too. So cortisol, it is secreted from zona fasciculata, bound to corticosteroid binding globulin. Its function is to increase appetite, increase blood pressure by upregulating the alpha-1 receptors on arterioles. That causes vasoconstriction, right? Increased sensitivity to norepinephrine and epinephrine, and at higher concentration can bind to mineralocorticoid receptors. So there are two ways by which it increases blood pressure. This is important. So it upregulates first alpha-1 receptors on arterioles, and second, it binds to mineralocorticoid receptors. So it will retain sodium and water, hence increasing the blood volume and blood pressure. But that function is done only at the high concentrations. It will also increase insulin resistance, so it is diabetogenic. It increases gluconeogenesis, lipolysis, and proteolysis, decreased glucose utilization and increased glucose levels in the blood, decreased fibroblast activity, that is poor wound healing, decreased collagen synthesis and increased collagen stria, decreased inflammatory and immune response. We all know that steroids decreases immunity, inhibits production of, but how? We will see that it inhibits production of leukotrienes and prostaglandins. It inhibits WBC adhesion, so it is going to cause neutrophilia, because once the neutrophils stick to each other, their numbers decrease in circulation, but cortisol inhibits that adhesion, causing increase in neutrophils. Blocks histamine release from mast cells. It will cause eosinopenia, lymphopenia, and just neutrophilia. Just neutrophils increase, but eosinophils and lymphocytes decreases. Also blocks IL-2 production, and decreases bone formation by decreasing osteoblast activity, that we saw, right, in much detail. Cortisol is a big fib, so this is just mnemonic if you want to remember it. And exogenous glucocorticoids can cause reactivation of TB and candidiasis because it blocks IL-2 production, so it is not going to let TH cells differentiation, right? And if the TH cells are not being differentiated, the macrophages will not get activated to contain the TB. So that is how it reactivates TB and candidiasis. So stress circadian rhythm will stimulate hypothalamus to secrete CRH, cortisol releasing hormone. It acts on anti-pituitary to secrete ACTH, and ACTH will act on zona fasciculata, which will secrete cortisol, and cortisol will in turn inhibit anterior pituitary ACTH secretion and also CRH secretion from hypothalamus. Right, this is just what we've discussed. So chronic stress may induce prolonged cortisol secretion, cortisol resistance, impaired immunocompetency, and dysregulation of HPA excess. So stress may lead to decrease in all of these things, right? Now the appetite regulation, that is by 3 hormones. So first is ghrelin. It stimulates hunger and growth hormone release. So stimulating hunger is called orexigenic effect, and increasing growth hormone release is via growth hormone secretagogue receptor, and is produced by stomach. And sleep deprivation, fasting, or Prader-Willi syndrome will increase ghrelin production. Ghrelin makes you grow hungry. That is a weird mnemonic, right? So it acts on the lateral area of hypothalamus, that is the hunger center, to increase appetite. So whenever you are hungry here, whenever you are fasting, the effects that you feel in the body, like growling stomach and wishing to eat, and all these feelings are due to the ghrelin hormone, right? So that is why in Prader-Willi syndrome there's increased ghrelin production, which leads to increased weight. And in hyperphagia, I don't know if that's the word for increased hunger. I think it's that. I may be wrong. Okay, just look it up. So there's increased weight, increased appetite in Prader-Willi syndrome. So leptin, it's a satiety hormone produced by adipose tissue. Mutation of leptin gene will cause severe obesity, and obese people have increased leptin due to increased adipose tissue, but are tolerant or resistant to leptin's anorexigenic effect. So obese people have more adipose tissue, right? And more the adipose tissue, more the secretion of leptin is. And what leptin does is it kills hormone after you've eaten, right? So that is satiety. And once you ate, so there's going to be increase in leptin, and that is going to make you feel that your stomach is full and you shouldn't eat more. So that is called an orexigenic effect. So in obese people, even though the leptin is high, but they are tolerant or resistant to its effects. And sleep deprivation and starvation will lead to decreased leptin production, because then we need more food, right, to survive. So we have to decrease leptin production, because leptin will not let us eat in peace. So leptin keeps you thin, acts on ventromedial area of hypothalamus. The endocannabinoids act at cannabinoid receptors in hypothalamus and nucleus accumbens, two key brain areas for the homeostatic and hedonic control of food intake. Increased appetite. Exogenous cannabinoids causes the munchies. So I bet all of you must be knowing what the munchies is. And if you don't know what the munchies are, just get a life, bro. So yeah, even if you ate a ton of things with exogenous cannabinoids, you are going to feel like you need to eat more and more, right? Be it ice cream or the pizzas or the frozen pizzas, doesn't matter. So yeah. Now I want to discuss functional hypothalamic amenorrhea. So what is FHA? So females who tend to eat very less to maintain their body structure, or right, so they undergo extreme weight loss, or patients of eating disorders, or with chronic illness, that is cachexia of chronic illness, that is weight loss, right? So there is going to be decreased adipose. tissue, there is going to be decreased leptin. So now if the leptin is decreased, there is going to be inhibition of hypothalamus. So no one is entirely sure how this exactly works, that why decreasing leptin reduces hypothalamic stimulation, but it does. Okay, so due to reduced hypothalamic stimulation, there's going to be reduction in GnRH, pulsatile release, because naturally the GnRH is released in the pulsatile fashion. So reducing that is going to cause reduce in LH and FSH levels, and that is going to cause decreased estrogen, and that reduced estrogen and reduced LH FSH is going to cause amenorrhea and bone loss. Because if you remember, I said that estrogen stimulates osteoblasts, right? So now if the estrogen is less, it's not going to stimulate osteoblast, and hence bone loss will form. So this is called functional hypothalamic amenorrhea. It is called functional because it's very, in a way, very physiological. The patient just has to eat right, and does not succumb to extreme weight losses. That's just the treatment right there. Now to the very boring topic, that is signaling pathways. So these are all secondary messengers and signaling pathways. So CAMP is used by FSH, LH, ACTH, TSH, CRH, SECG, ADH, just V2 receptors of ADH, not the V1 receptors. MSH, PTH, calcitonin, histamine, just the H2 receptors of histamine. Glucagon, GHRH, right? Remember if you want to. CGMP is used by BNP, ANP, and EDRF, that is nitric oxide. So think of vasodilation and diuresis. Vasodilation due to nitric oxide, and ANP, BNP leads to diuresis and nitriuresis, right? So CGMP has the role in vasodilation mostly of the smooth muscles that is in the vessels. IP3, that is GnRH, oxytocin, ADH, V1 receptor, histamine, VH1 receptor, TRH, angiotensin 2, and gastrin. Intracellular receptors include progesterone, estrogen, testosterone, cortisol, aldosterone, vitamin D, T3, and T4. So everything that is secreted from the adrenal glands uses intracellular receptors. Okay. Now the receptor, tyrosine kinase. So everything that is a growth factor in it, IGF-1, FGF, PDGF, EGF, and insulin, also that right. So that leads to that uses receptor tyrosine kinase. Non-receptor tyrosine kinase include erythropoietin, thrombopoietin, prolactin, immunomodulators, okay, and GCSF, every hormones that leads to secretion of other things, right? That uses non-receptor tyrosine kinase, like GCSF leads to, that is granulocyte colony stimulating factor, right? So that leads to different kinds of leukocytes. Erythropoietin will lead to secretion of RBCs, thrombopoietin, platelets, prolactin, secretion of milk, immunomodulators, that is cytokines, IL-2, 6, interferon, and growth hormone. This one you have to remember. Think acidophiles and cytokines. Okay, but how? So prolactin and growth hormone both are acidophiles, right? So they both use non-receptor tyrosine kinase. Somehow you have to remember that. So these three are very easy to remember. I would say even CGMP is very easy to remember because we've seen in the cardiology section as well that CGMP leads to vasodilation of the smooth muscle cells. It causes relaxation of the smooth muscle cells in the vessels, so that leads to vasodilation. And it also causes ANP and BNP release, that will cause diuresis and natriuresis. You have to remember is CAMP. So I just remember that if I can't remember if the hormone is in, or if all of these three or this fourth pathway is going to be using CAMP pathway, right? That is how I remember it. You just have to remember this difference that CAMP is for V2 and H2 and IP3 is for V1 and H1. Then signaling pathway of steroid hormones, as we know, it uses intracellular pathway. Steroid hormones are lipophilic and therefore must circulate bound to specific binding globulins, which increases their solubility. In males, increased sex hormone binding globulin SHBG, it lowers free testosterone, right? So that leads to gynecomastia. And in females, decrease in SHBG raises free testosterone, right? If increase in SHBG, be it female or male, increase in SHBG will cause decreased free testosterone, and decreased SHBG will raise testosterone. So raising of free testosterone in female will lead to hirsutism, right? Because testosterone itself is the function of testosterone. Free testosterone is to develop secondary sexual characteristics in males, that is facial hairs and muscle mass and everything, right? But the effect of dihydrotestosterone was to form external genitalia, right? Free testosterone is for the pubertal characteristics. So in females, it is going to cause hirsutism. Increased estrogen due to OCPs and pregnancies will lead to increased SHBG. So right, that is what we talked about, estrogen testosterone ratio. So increased estrogen testosterone ratio will lead to increased SHBG, and if SHBG is increasing, it is going to cause decreased testosterone. So apparently this ratio will decrease whenever there is hormonal imbalance between estrogen and testo. There's going to be gynecomastia. Right, and gynecomastia can be physiological. It's mostly physiological in puberty, in pubertal males, right? Because there is hormonal imbalances in puberty, which leads to gynecomastia. So what treatment should be given? So just reassurance should be given that in 1 or 2 years, the gynecomastia will disappear as your hormones will balance itself. So, but before that, you should rule out different causes of gynecomastia, like there is marijuana and opioid overuse. That is very less likely. And there are also certain medications that you have to rule out. So after ruling out opioid and marijuana overuse and different medications, you can definitely say that it's a physiological gynecomastia, and it will disappear within 1 or 2 years, and there's nothing to be worried about. So hormone will binding to receptor located in nucleus or in cytoplasm, that is intracellular. So here's the receptor, transformation of receptor to expose DNA binding protein, binding to an enhancer-like element in DNA, whatever that is. So from pre-mRNA, there is going to be mRNA through slicing out of the introns, right? So exons is what are important and carries the information. So we have to splice out the introns, and that mRNA will then cause translation into proteins, different proteins on the rough endoplasmic reticulum, and that will form the response after exiting the cell. Now let's talk about infertility a little bit before going to the pathology sections. So I'll just straight out write few diseases that the NBM is asked about and how to differentiate all of them. It's going to be very brief. So the first is germ cell tumor. So these are not exactly the causes of infertility, but I think there's confusion when these kind of questions arise. So there's confusion of whether the hormones increase or decrease or what that is. So writing these down help me with differentiating those questions. So I'm trying to do the same for you guys. So HCG increases in germ cell tumors. Okay, germ cell tumors of testis. Right. I need to write smaller fonts. So that is going to lead to decreased testosterone, right? Because HCG leads to decreased testosterone production and increase aromatase production. So what happens if testosterone decrease and increase in aromatase? Whatever the testosterone is being formed, it is going to get converted into estrogen, and that is going to cause gynecomastia. So this was the first case. Second case is, what if the pubertal patient has undescendant testis? Undescendant testis. I'm very bad with spellings, please forgive me. This is probably a D, I don't know. So undescendant testis is also underdeveloped testis, right? This is like a rule of thumb, that the undescendant testis is also underdeveloped testis. So if the testis is underdeveloped, the most commonly affected cells in the testis are the Sertoli cells. So Sertoli cells are going to decrease, causing decrease in inhibin, right? Because the function of Sertoli cells is to secrete inhibin. So if inhibin is also reducing, it is going to give feedback to FSH to increase. So in undescendant testis, the FSH is high, inhibins are low, and Sertoli cells are not functioning properly. The LH cells, the Leydig cells, which are activated by LH, are less affected by undescendant testis. Third is Klinefelter. So in Klinefelter 2, there is destruction of seminiferous tubules. So if seminiferous tubule as a whole is being damaged, the Sertoli as well as Leydig cells are going to decrease in number. So if they are decreasing, inhibin is also going to decrease because of Sertoli cells, and testosterone is also going to be decreased because of Leydig cells. So now if the testosterone is not being formed in the testis, so what it is not going to restore the peripheral stores of testosterone. and peripherally everything is normal, right? So aromatase enzyme is acting normally in the peripheral tissues, converting testosterone to estrogen, right? Whatever testosterone is available, it is converting it into estrogen, but there is not enough testosterone being produced in the testis to restore that levels. So testosterone will decrease and estrogen is going to be formed normally, so that is going to lead to hormonal imbalance causing gynecomastia. Third is hypogonadism. So that is just Kalman syndrome. There is defect of hypothalamic neurons to descend down to posterior pituitary, right? So there's reduced hypothalamic stimulation, reduced FSH, LH, which is going to cause decreased testosterone and also leads to decreased sperm count, because testosterone is low from the birth, right? In Klinefelter 2, the sperm count is very, very low. Right? But the difference between Klinefelter and hypogonadism is FSH-LH is increased in Klinefelter. Right? And also there's a theory that I didn't write that down, did I? So LH and FSH increase in Klinefelter syndrome because of decreasing testosterone and decrease in inhibin B. So there's not going to be any kind of feedback inhibition, so LH-FSH increases. There's also theory that LH-FSH can activate aromatase peripherally, right? So that leads to testosterone conversion to estrogen. And in here, hypogonadism and Kalman syndrome, FSH-LH are decreased. What if there's obstruction? And the vast difference, there's going to be azoospermia, that is decreased sperm count, but all hormone levels will be normal. Now fifth, that is cryptorchidism. That is just undescendant, where I just wrote that down twice in my own notes, so I was just copying down here. So this undescendant testis is called cryptorchidism, which we just discussed, that there is normal LH level and the FSH are high. And yeah, the last one that I forgot is if there's exogenous steroid intake or exogenous testosterone intake by the athletes, or it is called performance enhancing drugs, PD, that are usually banned in all kinds of sports, but still somewhere, or for people may take it for bodybuilding or something like that. So what exogenous testosterone does is it increases the testosterone in the serum levels, in serum, right? So that is going to inhibit luteinizing hormone. But you have to understand here that exogenous testosterone does not mean that there's also going to be testosterone in the testicles that is going to help us with the spermatogenesis. No, that's a different thing altogether. So this exogenous testosterone may help with muscle building and everything, but at the testicular level, as the increased testosterone is inhibiting the luteinizing hormone, there is going to be decreased endogenous testosterone released from Leydig cells. And because of this decreased endogenous testosterone, the spermatogenesis is also going to decrease, resulting in low sperm count. Now the pathology section. So first is SIADH, that is syndrome of inappropriate antidiuretic hormone, or as I like to say, syndrome of increased antidiuretic hormone. Right? So that is very easy to remember then, because inappropriate may also mean decreased ADH, right? So characterized by excessive free water retention, euvolemic hyponatremia, that is the key word, that is euvolemic hyponatremia. There is going to be so many questions where you have to figure out that there is hyponatremia. That is very easy to figure out, but then there will also be given serum osmolality, right? So from that you have to figure out that it's euvolemic hyponatremia, and there might have been history of head trauma or something like that, or CNS disorder. So most commonly it would be head traumas. So then you have to diagnose SIADH and then move forward in the question. With continued urinary sodium excretion, urine osmolality more than serum osmolality, right? Because it has all the sodium element. And body responds to water retention by decreased aldosterone and increased ANP and BNP. ANP and BNP are released where there is a stretching of the vessel wall due to increased water volume or increased blood volume, right? And ANP, BNP causes diuresis and natriuresis. So here they are going to cause increased urinary sodium secretion, normalization of extracellular fluid volume, and that is called euvolemic hyponatremia. Right, so why is there euvolemic hyponatremia and not hypovolemic or hypervolemic hyponatremia? That's because you have to understand that sodium is being excreted because of let's not explain it that way, but let's begin from the ADH. That function of ADH is to retain the free water, right? So free water is being retained in the blood. There's going to be increase in blood volume, and as there's increase in blood volume, increase in GFR, there's going to be decreased renin secretion, there's going to be decreased aldosterone secretion, right? And also as there is increased blood volume and increased stretching of the vessel walls, there's going to be increased ANP as well as BNP. So the combined effect of both of these, the decreased aldosterone, that will cause decreased sodium reabsorption from the kidneys, right? So there's going to be increased sodium excretion, and because of ANP and BNP, it has both diuretic as well as natriuretic effect. But decreased aldosterone has just natriuretic effect. So that is going to cause much more loss of sodium than of water, right? The blood volume is going to be relatively normal, right? Because also there's increased ADH. So there's going to be euvolemic hyponatremia. The treatment is just fluid restriction of all kinds, salt tablets that can replace the sodium, IV hypertonic saline, that is 3% hypertonic saline. The regular normal saline is 0.9%. Okay, then there's half normal saline, that is 0.45%. Okay, but always in hyponatremia, it's the hypertonic saline is given because there's increased sodium chloride in hypertonic saline. Then diuretics are given, ADH antagonists, that is conivaptan, tolvaptan, demeclocycline, right? These are ADH antagonists. And causes are head trauma, ectopic ADH from small cell lung cancer. Right. So as I explained earlier, there are three paraneoplastics of small cell, that is Lambert-Eaton, Cushing syndrome, and SIADH. Third is exogenous hormones, that is vasopressin, desmopressin, oxytocin may also lead to SIADH. Lung disease can lead to any vague lung disease. Then the drugs like SSRIs, carbamazepine and cyclophosphamide can also lead to SIADH. Let's see the diagram. So ADH is being secreted from the hypothalamus into posterior pituitary, and from posterior pituitary it acts on the medullary collecting ducts through aquaporine channels, that is V1 and V2, I think. V1 and V2. Right. So ADH has two receptors, V1 and V2. V1 acts on the blood vessels, and V2 acts in controlling the this water retention. So here the V2 is more important. Okay. So it acts on the medullary collecting duct and increase the urine osmolality by retaining the water inside the serum, and so that is why serum osmolality is going to decrease and serum volume is going to increase, which is going to inhibit hypothalamus from further secreting ADH. Right? And normally whenever there is increased serum osmolality, there's going to be stimulation of hypothalamus. So in central DI, what happens is both synthesis of ADH from hypothalamus and secretion of ADH from posterior pituitary is inhibited. Right. And in SIADH, there's this excess ADH. There's ADH antagonists, lithium and nephrogenic DI, that are going to inhibit the action of ADH on medullary collecting ducts. Right. Now the primary polydipsia and diabetes insipidus. It is characterized by the production of large amounts of dilute urine plus or minus thirst. So it is just opposite of SIADH. Right? Urine specific gravity is less than 1.006. Urine osmolarity usually less than 300 milliosmol per kg, because there is much more water being wasted in the urine. So urine is being more diluted. Right? And central DI may be transient if damage is below hypothalamic median eminence or in the posterior pituitary. Because below the what does it mean that central DI may be transient if damage is below hypothalamic median eminence? Because main source of ADH is from hypothalamus, right? So the hypothalamic median eminence is just the passage through which ADH travels, and posterior pituitary is a space where just ADH is being stored. Right? Even if they are damaged, ADH can be secreted from hypothalamus through the portal capillaries into the serum, right? And so ADH in hypothalamus can still be secreted systematically via portal capillaries in median eminence. And also if the damage is in the hypothalamic median eminence, this neurophysin there are the nerve cells that are emerging from the hypothalamus and forming the posterior pituitary. They can regenerate, right? So the central DI damage will be just transient. Now the primary polydipsia. It is due to excessive water intake. So yeah, there's excessive water intake. So the primary polydipsia is just a person who drinks more water, pees more, right? Drinks more, pees more. Okay, and why does the patient drink more? It's because of some psychiatric illness or hypothalamic lesions affecting the thirst centers, right? So serum osmolality will be less compared to central and nephrogenic DI. Serum osmolality is less because there is more water intake, right? And as there is enough water intake in the body, enough water in the serum, the ADH is going to decrease because it does not want to retain any more water from the kidneys. And with water restriction, that if we stop the patient from drinking more water, there is significant increase in urine osmolality, right? So it is proved that it is a primary polydipsia. And desmopressin administration is not needed in this because ADH levels are decreased on normal, right? And the treatment is water restrictions. So how is water restriction done? No water intake for 2 to 3 hours, followed by hourly measurements of urine volume and osmolality, as well as plasma sodium concentration and osmolality. Right. Now the central DI. So in central DI, there is less secretion of ADH, and it can be due to idiopathic brain injury, trauma, hypoxia, tumor surgery, or infiltrative disease, which can obstruct the secretion of ADH. So serum osmolality is going to be high because there is no water retention. So there's just proteins and all of the other stuff except the water in the serum. So that is going to increase the osmolality. ADH levels are down because that's the whole disease, right? ADH levels are decreased. And water restriction will not cause any change or may cause slight increase in urine osmolality. Right. And desmopressin administration is very useful because desmopressin is an alternative of ADH, right? So on administering desmopressin, there is going to be significant increase in urine osmolality, more than 50%. So that is diagnostic of DI, central DI, that on administering desmopressin, there should be increase of more than 50% in urine osmolality. Desmopressin is administered if serum osmolality is more than 295 to 300, plasma sodium more than 145, and or urine osmolality does not increase despite increased plasma osmolality. And now the nephrogenic DI. So there is ADH, but there is ADH resistance. The causes can be hereditary, ADH receptor mutation, drugs like lithium and demeclocycline, hypercalcemia and hypokalemia. Okay. Hypercalcemia, hypokalemia, sorry. And just like central DI, serum osmolality is increased. ADH level can be normal or increased because there's just resistance to that ADH. So in water restriction, no changes, slight increase in urine osmolality, same as central DI. And in desmopressin administration, there is minimal change in urine osmolality because even if we give desmopressin, there is already resistance to ADH. Right. And treatment is manage the underlying cause, low sodium dyes, HCTZ, amiloride, and indomethacin. Right. Many questions are asked from this section. It might seem very important, but more questions are asked from the SIADH section. Right? Yeah, so now the hypopituitarism. There's under secretion of pituitary hormones. It may be due to several causes, but hypopituitarism is under secretion of the pituitary hormones. It can be due to non-secreting pituitary adenoma or craniopharyngioma, which can produce stalk effect. Right? So there is a head, there's a stalk in the pituitary gland. So if the stalk effect is there, it is going to obstruct the releasing hormones coming in from hypothalamus into the pituitary, which will cause less secretion of the hormones from the pituitary gland itself. Right? Then there's Sheehan syndrome. There's ischemic infarct of pituitary following severe postpartum hemorrhage. Pregnancy-induced pituitary growth. There's pregnancy-induced pituitary growth that is around 125% of the normal pituitary gland, and increased susceptibility to hypoperfusion. So basically, even if if the small pituitary gland enlarges to a bigger size, it's going to need more blood, right? But how can we increase the blood going into the pituitary, right? So there are chances of hypoperfusion, and it usually presents with failure to, and due to that hypoperfusion there can be ischemia, ischemic infarct, and that usually presents with failure to lactate, absent menstruation, and cold endurance. This is all because of decreased prolactin and decreased TSH. Okay. So if TSH is low, there's going to be less T3, T4, causing hypothyroidism, and cold intolerance is the effect of hypothyroidism. And that will be secondary hypothyroidism, because TSH is decreased. That is why T3, T4 is reduced. That is secondary hypothyroidism. If it was Hashimoto's thyroiditis, there will be increased in TSH. And the third is anti-sella syndrome. Atrophy or compression of the pituitary, which lies in the sella turcica, is often idiopathic, common in obese females, associated with idiopathic intracranial hypertension. And it's not that important. Pituitary apoplexy, sudden hemorrhage of pituitary gland, often in the presence of existing pituitary adenoma. There should be pituitary adenoma already existing, and it's a sudden hemorrhage. So all the symptoms will be sudden, usually presents with sudden onset severe headache, visual impairment, that is bitemporal hemianopia. This is an important keyword, bitemporal hemianopia. Diplopia due to third cranial nerve palsy, and features of hypopituitarism. Right. So this is one of the few emergencies in endocrine. Right. So the first one I talked about adrenal crisis. There is also an emergency in endocrinology. Pituitary apoplexy is also an emergency. Then the fifth is brain injury, sixth is radiation. And treatment is hormone replacement therapy. That is all the hormones that are secreted by pituitary, we have to replace all of them. It is glucocorticoids, thyroxine, sex, steroids, human growth hormone, all of them. Yeah, there's failure to lactate and absent menstruation as well. So absent menstruation is because of decreased prolactin, and and failure to lactate is due to decreased prolactin, and absent menstruation is due to FSH, LH decreasing too. Right? So normally, if only prolactin was going to decrease, there was just prolactin being decreased, there will be no feedback inhibition on GnRH, and that will lead to increase in LH and FSH, right? But the whole pituitary is being affected, so LH, FSH are going to decrease as well. Now the acromegaly. So that means excess growth hormone in adults, typically caused by pituitary adenoma. Findings are large tongue with deep furrows, frontal bossing, coarsening of facial features with aging. So coarsening is like this lady has. So all of the facial features become more prominent, right? So nose became more prominent, these cheekbones became more prominent, lips are more prominent, and there is crowding of all the facial features, right? That is called coarsening of facial features. And there you can see there's frontal bossing and everything, right? Our upper eyelids are enlarged, right? And there's deep voice diaphoresis, that is excessive sweating, impaired glucose tolerance, that is insulin resistance, because growth hormone is diabetogenic, right? So there is going to be insulin resistance, there's hypertension, LVH, diastolic heart failure because of the LVH, and most common cause of death is diastolic heart failure. And diagnosis is by serum IGF-1, because as we saw that growth hormone does not make all the functions possible, but it stimulates the synthesis of IGF-1 from the liver, which carries out all the functions. Failure to suppress serum growth hormone following oral glucose tolerance test, and pituitary mass seen on brain MRI. So normally when we give oral glucose, so there is enough glucose in the serum, we don't need growth hormone, right? Because we only need growth hormone in the case of starvation and hypoglycemia and all that, right? Because it can increase the glucose levels in the blood by increasing gluconeogenesis, glucogenolysis, and decreasing insulin secretion and everything, right? But even after giving oral glucose, if we can't suppress the growth hormone, we can say that it's acromegaly, and or else pituitary mass should be seen on brain MRI if it's a case of pituitary adenoma. Treatment of pituitary adenoma is resection. If not cured, treat with octreotide, somatostatin if there's any residual tumor. Then there's pegvisomant, that is GH receptor antagonist, or dopamine agonist, that is cabergoline. So cabergoline, that is dopamine agonist, can reduce the synthesis of prolactin, right? Because dopamine inhibits prolactin. And increased growth hormone in children can cause gigantism, that is increased linear bone growth, which means increased height. And there can also be joint pain due to hypertrophy of articular chondrocytes. Or it can also be due to synovial hypertrophy. And what are the symptoms of pituitary tumor? Like basic symptoms, it's just two keywords, that is chronic headache plus bitemporal hemianopia. You're going to see tons of questions where there is bitemporal hemianopia given in the question stem. So straightforward, you have to assume it's a pituitary tumor, and then you have to move forward, like if it is producing mass effects, if it is producing extra hormones or whatever it is doing. If it's a pituitary adenoma, like the most common pituitary adenoma is prolactinoma, there's going to be increased prolactin and increased TSH and all that. But if it is producing mass effect, there is going to be decreased all kinds of hormone and just hyperprolactinemia and everything. So once you figure out that it's a pituitary tumor by headache and bitemporal hemianopia, you have to assume in most cases that it is most commonly a prolactinoma, because it is the most common adenoma of pituitary gland, right? And even sometimes it will be given that it is a non-functional mass, but still non-functional mass can have mass effect on the pituitary stalk, right? So if it compresses the stalk, that is called stalk effect, it is going to produce hypopituitarism. Plus hyperprolactinemia. Why? Because all the GnRH, GHRH, TRH coming in from hypothalamus will now be inhibited, right? So it is not going to stimulate anterior pituitary to produce any of these LH, FSH, then growth hormone and TSH. But also dopamine coming in from hypothalamus will be inhibited. But dopamine is inhibitory in nature towards prolactin. So if dopamine is inhibited, there is going to be increased secretion of prolactin from anterior pituitary. And you have to differentiate between this prolactinoma or pituitary tumor, not prolactin. You have to differentiate this functional mass with Sheehan syndrome, right? Because in Sheehan syndrome, there is a total hypopituitarism. Like even the prolactin is decreased because the pituitary gland itself is being infarcted, right? So if it is, even if it is infarcting and there's increased dopamine, it is not going to do anything because the whole gland is being destroyed. So there is going to be hypopituitarism, decreased prolactin as well. But in functional mass, due to stalk effects, there's going to be increased prolactin and decreased all other hormones. I'm telling you this because I think there was a question I can remember in Uworld where you have to differentiate whether the pregnant. It was a question of pregnant female, which had all of these symptoms, headache and bitemporal hemianopia and everything, and you have to diagnose whether it was Sheehan syndrome or was it just craniopharyngioma type mass that can cause mass effect. And so there I think there was increased prolactin. So to confuse everyone, they just put Sheehan syndrome in the options as well. And most of the people had selected Sheehan syndrome. But the answer was actually this craniopharyngioma, that is non-functional mass. And craniopharyngioma is non-functional. It does not produce hormone on its own. Right? It just has mass effects. Right. So now comes the most important topics of the whole endocrine system. Like if you want to do one topic and take step 1 from endocrinology, you have to do this section. Let me draw a pretty star first, then we will continue. So hypothyroid versus hyperthyroid. I think you all know what the symptoms are. The important part is this: all the histology of all these, how to differentiate all of these hypothyroid syndromes, how to differentiate these hyperthyroid syndromes, and the cancers are also the most important part. But symptoms you guys already know, I think, that hypothyroidism slows down everything, and hyperthyroidism quickens everything, right? Hypothyroidism slows everything down. And this quickens everything. So if it is slowing everything down, there's going to be cold tolerance, decreased sweating, weight gain, like decreased metabolic rate will cause decreased calorigenesis, that is going to cause decreased heat production. There can also be hyponatremia, because there's increased water inside the serum, water levels inside the serum, and thus decreased water clearance. On the other hand, heat tolerance, increased sweating, and weight loss are there in hyperthyroidism because of increased synthesis of sodium potassium ATPase, increased metabolic rate, increased calorigenesis. Hypothyroid people will have dry, cool skin due to decreased blood flow, coarse, brittle hair, diffuse alopecia, brittle nails, puffy faces, and generalized non-pitting edema, that is called myxedema. Right, it is a non-pitting edema due to increased glycosaminoglycans in interstitial spaces, which will cause increased osmotic pressure and water retention. And in hypothyroid, it will be warm, moist skin due to vasodilation, fine hair, onycholysis. Okay. That is breaking down of nails. Right. Here you can see separation of the nail from the skin, and it can also have pretibial myxedema in Graves' disease. Because so this myxedema is not very important to remember, also not very specific, right? Because there's non-pitting edema, myxedema in hypothyroidism, and there's also pretibial myxedema in hyperthyroidism as well. But in hyperthyroidism, it is just pretibial. Like if you want to ever check edema in the lower limbs, you do it against the anterior tibia, right? Because that is the most bony structure in the lower leg, right? So that is where you have to check for edema, and there's pretibial edema in hyperthyroidism. But in hypothyroidism, there is generalized non-pitting edema. Okay, so there is edema there's a little bit of facial puffiness too. There's also a tummy here, right? So you can differentiate hypothyroid patient very easily. Even if you've seen one patient of hypothyroid, there are all of these symptoms present in that one patient. It's very common to figure out these symptoms. These cold intolerance is a very common symptoms amongst the hypothyroid patients. And they'll tell you that they feel lethargic all the time. They feel like they need to sleep throughout the whole day. And they are like the classic symptoms of hypothyroidism, because everything slows down. The basal metabolic rate slows down, right? And the weight gain is also very eminent. And ocular is periorbital edema. This is the periorbital edema. And in hyperthyroid, there's ophthalmopathy in Graves' disease, including periorbital edema, exophthalmos, lead lag, retraction, increased stimulation of levator palpebris superioris and superior tarsal muscle. So all of these exophthalmos and effects are due to increased sympathetic stimulation of levator palpebris superioris. Gastrointestinal effects are constipation, because everything is slowing down, right? GI will slow down too, and thus in decreased appetite. So yeah, that is also a classic. Like patient will tell you that I have a decreased appetite, but still I am gaining some weight. Right? So that is very classical of hypothyroidism. And in hyperthyroid, there is hyperdefecation, diarrhea due to increased GI motility and increased appetite. And then there is reverse in hyperthyroidism, where patient will tell you that I eat a lot, but still I can't gain any weight. And also, doctor, I'm sweating out a lot. I can't tolerate even a bit of heat. I start sweating out as soon as little bit of warm temperature is there. Right. So that is classic of hyperthyroidism. In musculoskeletal, there is hypothyroid myopathy, that is proximal weakness, increased creatine kinase, carpal tunnel syndrome, myoedema, there is small lump rising on the surface of muscle when struck with a hammer. I've never seen this. And thyrotoxic myopathy, that is proximal weakness, normal CK, osteoporosis, increased fracture rate, that is T3 directly stimulates bone resorption, right? If you remember that section where I told you that T3, I also wrote it down that T3 stimulates osteoclasts, right? So that is how T3 stimulates bone resorption. And due to that bone resorption, there's going to be osteoporosis and increased fracture rate. So hypothyroid affects more of the soft tissue structures like the myopathy, then the carpal tunnel syndrome, then myoedema. And hyperthyroid affects most of the bony structures, that is osteoporosis, increased fracture rate, and there is normal CK, normal creatine kinase in hyperthyroid, increased creatine kinase in hypothyroid. Reproductively, there's abnormal uterine bleeding, decreased libido, infertility, right? And also in hyperthyroid, there's abnormal uterine bleeding, gynecomastia, and decreased libido and infertility. So pretty much the same, just gynecomastia is added there. And neuropsychiatric is hypoactivity, lethargy, fatigue, weakness. That is what I told you, right? That the patient feels lethargic and fatigue all the time throughout the day. Depressed mood, decreased reflexes, that is delayed and slow relaxing, decreased reflexes. In hyperthyroid, there's hyperactivity, restlessness, anxiety, insomnia, and fine tremors due to increased beta-adrenergic activity. So there's sympathetic overstimulation in hypothyroid, be it for fine tremors or be it for levator palpebrae superioris or superior tarsal muscles. There are increased reflexes, that is called brisk reflexes. Mild increase in reflexes are called brisk reflexes. And cardiovascular, cardiac dyspnea on exhaustion and decreased cardiac output. With hyperthyroid, it is very easily seen the tachycardia, palpitations, dyspnea, arrhythmias, is AFib, chest pain and systolic hypertension due to increased number and sensitivity of beta-adrenergic receptors, increased expression of cardiac sarcolemmal ATPase, and decreased expression of phospholamban. And that is not very important to remember, there is increased expression of sarcolemmal ATPase. So that is why it, I think, generates more ATP for the heart to contract, and that is why it causes tachycardia and arrhythmias and everything, right? And there's decreased expression of phospholamban. Labs, there's going to be decreased free T3, T4, and there's going to be increased TSH. So in thyroid, we just focus on the free T3 and free T4, right? Because only the free hormones can regulate the TSH secretion from the anterior pituitary. Right? And there's also hypercholesterolemia due to decreased LDL receptor expression. So there's going to be false high cholesterol in the patients of hypothyroidism. Yeah. In hyperthyroid, there's increased field T3, T4, which is going to decrease TSH if it is primary. If it is secondary, the TSH is going to increase first, and then T3, T4 are going to increase following the TSH. That is secondary. And decreases LDL, HDL, and total cholesterol. And what if it's a subclinical hypothyroid and subclinical hypothyroid? So subclinical hypothyroid is very common, that there's just increase in TSH, but there's normal to high T3, T4, mostly the T4, right? Focus on T4 more, because T4 is more important for diagnosing hypo and hyperthyroid, because T3 has shorter half-life. It is also produced peripherally. Right, so T4 enacts the function of thyroid gland most directly. So that is subclinical, because even if there is a small change in T4 secretion, it is going to cause a huge effect on the TSH secretion. So that is why TSH is the most important hormone to look for in the TFTs to diagnose hypo or hyperthyroidism. Because even if there's a mild decrease in T4, there's going to be a huge increase in TSH. So that makes us easy to look for hypo or hyperthyroid conditions. Right, so that is subclinical hypothyroidism, where only TSH is increased. And in subclinical hyperthyroidism, that's going to be just decrease in TSH and normal to increased T4. Now the hypothyroidism, different kinds of hypothyroidism. So the main cause of hypothyroidism is thyroiditis. Right? The other cause is congenital hypothyroid. So what thyroiditis means, there's inflammation of the thyroid gland. So depending on the duration of that inflammation and depending on the period of that inflammation, we differentiate them, right? And depending on the etiology too, we differentiate the different thyroiditis. It can be Hashimoto thyroiditis, it can be subacute granulomatous thyroiditis, that is Riedel's thyroiditis, and there can be these are different. Subacute granulomatous and Riedel's both are different, and there can be postpartum thyroiditis too. So how can we differentiate all of them? So Hashimoto's is when there's antibodies that inhibit the function of thyroglobulin or inhibit the function of thyroid peroxidase, which leads to conversion of T4 to T3. So they are anti-thyroid peroxidase and anti-thyroglobulin antibodies. So whenever there is autoimmune antibodies involved, it is Hashimoto's thyroiditis, or it is also associated with different autoimmune diseases like diabetes type 1, and can also have history of lupus and everything like that. In short, any autoimmune disorder, right? Now if it is following a viral infection and the onset is subacute, like in weeks, then the thyroid is very painful. It can be subacute granulomatous thyroiditis. Now if there is a history of a fibrosing disorder like retroperitoneal fibrosis, sarcoidosis, or anything like that, pancreatitis, fibrosing pancreatitis, right? So that is going to lead to Riedel's thyroiditis. And thyroid is not tender here, but the thyroid is very rock hard, right? Because there's fibrosis happening in the thyroid gland. So that is Riedel's thyroiditis. And if it is occurring within the 1 year of delivery, it is called postpartum thyroiditis. Right? And that is because of the rupture of the follicles, and rupture of follicles initially causes transient hyperthyroidism, but when all of those hormones from ruptured follicles are secreted into the blood and then cleared off, there is going to be phase of hypothyroidism. That is why it is put in the hypothyroid section, right? Because eventually there's going to be hypothyroidism. Same is the case with subacute granulomatous thyroiditis, where there is transient hyperthyroidism because of the over secretion of all the thyroid hormones because of the inflammation. But when the thyroid runs out of the hormones to secrete, there's going to be phase of hypothyroidism. And TSH secretion is normal in subacute granulomatous. So as the time passes, TSH is going to replete all the stores of T3 and T4, and then there will be a phase of euthyroid state. Right. And congenital hypothyroidism can also be a cause. So there is no inflammation in congenital hypothyroid. It's just that there is either thyroid dysgenesis, there's abnormal thyroid gland, or there's dishormonogenesis, there's abnormal thyroid hormone, or there can be mutation to thyroid hormone, and there can also be resistance to TSH. So if there's resistance to TSH, it cannot form T3, T4, right? It has several causes for congenital hypothyroidism. So maternal hypothyroidism is also a cause. Right. And there can also be thyroglobulin binding deficiency, thyroid binding globulin deficiency, TBG deficiency, right? Okay, so let's see each one in detail. So see, the histology section is very important. There are also images that we'll discuss later on apart from these first aid images. Right. The first is Hashimoto's thyroiditis, also called chronic autoimmune thyroiditis. Most common cause of hypothyroidism in iodine sufficient regions, that is developed nations, that is in US, it is the most common cause of hypothyroid. In India, the most common cause of hypothyroid is iodine deficiency. Associated with HLA-DR3, differs by ethnicity, increased risk of primary thyroid lymphoma, that is DLBCL, diffuse large B-cell lymphoma. Okay. The findings are moderately enlarged, non-tender thyroid. So what I'm going to do is I'll put the significant differentiating points with blue pen, and I will put histology features with green pen, right? So it is a non-tender thyroid, may be preceded by transient hyperthyroid state, that is hashitoxicosis due to follicular rupture and thyroid hormone release. So there can be a stage of hashitoxicosis. There's antithyroid peroxidase positivity. There's also antithyroglobulin positivity. Right. If antithyroglobulin antibodies are there, it is going to inhibit thyroglobulin. So there's not going to be organification of the iodine. There's also not going to be enough thyroglobulin in the follicular cells. And if there's antithyroid peroxidase, it is not going to let any of the three O's happen, that is oxidation, organification. And the third C, that is coupling, right? And none of these will happen. The histology is Hürthle cells. Hürthle cells, lymphoid aggregates with germinal centers. So this is a Hürthle cell. There's going to be nucleus, and then there's going to be a cell membrane. There's also lymphoid aggregates with germinal centers. So these are the germinal centers in the arrow that has all the lymphoid aggregates. And there's rim of lymphocytes. Like, see if you can see, this is the rim of lymphocyte. Right, so that is also an important feature. Right, so yeah. So here is the image of Hashimoto's, that is much clearer. So as you can see, the circular structure, that is germinal center. There's lymphocytes aggregate surrounding that germinal center, that is called the rim of lymphocyte. There's also some infiltrate here in the right corner. Then this is the thyroid follicle with pale eosinophilic material, that is thyroid follicle because it contains colloid, right? And yeah, this is the Hürthle cell. It has a round nucleus. It is an eye-like structure. Hürthle cell is an eye-like structure. There's abundant granular and eosinophilic cytoplasm. Okay. So that's it. Now the subacute granulomatous thyroiditis, also called liquid vein thyroiditis. It's usually a self-limited disease. And why is it self-limited? Because there's a transient hyperthyroid, then euthyroid, and then again hypothyroid, and then again euthyroid state. So eventually it comes down to euthyroid state. So that is why it is a self-limited disease, and it is often preceded by viral disease, viral infection. That is the key word here, that it follows viral infection. And the findings are increased ESR, jaw pain, a very tender thyroid. That is again very specific. If it's a tender thyroid, most commonly it is a liquid vein thyroiditis, and liquid vein is associated with pain. That is a good mnemonic. And there's also granulomatous inflammation. So this is a granulomatous inflammation. As you can see, there's necrosis here, and there's lymphocytes surrounding it, right? This is the as whole called a granuloma. There is also, as I told you, there's inflammatory infiltrate surrounding that necrosed area. Plus there are also going to be macrophages and giant cells. Okay, so this is very important to remember, that there's granulomatous inflammation, and that granuloma consists of inflammatory infiltrates, macrophages and giant cells. Right. As you can see here, so there's thyroid follicles containing the colloid, okay, and here there is multinucleated giant cells. Also, yeah, we didn't discuss the postpartum thyroiditis, right? Yeah, I'm sorry. So postpartum thyroiditis is a mild, self-limited variant of Hashimoto thyroiditis arising less than 1 year after delivery. So that is the key word here, that is, it is within the 1 year of delivery. And also it is going to be initially hyperthyroid, and then subsequently it becomes hypothyroid. Why is it hyperthyroid at first? Because of the release of preformed hormones from the follicular ruptures that take place. So let me just write it down. The next is renal thyroiditis, that is also called invasive fibrous thyroiditis, may be associated with IgG4 related disease. Is autoimmune pancreatitis, retroperitoneal fibrosis, and non-infectious aortitis. This is a variant of autoimmune thyroiditis or a part of systemic fibrosing disorder. Wherever there is IgG4, there is going to be fibrosis throughout the body. And hypothyroidism occurs in 1/3 of the patients. Fibrosis may extend to local structures, that is trachea, esophagus, mimicking anaplastic carcinoma. And its findings are slow enlarging, hard, rock-like thyroid. So that is the keywords here. It is hard, rock-like, and it is non-tender. Okay. In dequer vein, that was a tender thyroid because there was inflammation and it was subacute. In renal thyroiditis, there is fibrosis, which is a chronic condition, and fibrosis never causes pain, right? So that is why it is non-tender. Now comes the congenital hypothyroidism, called cretinism. It is most commonly caused by thyroid dysgenesis, that is abnormal thyroid gland development in premature babies. Examples are agenesis, hypoplasia or ectopy, or dyshormonogenesis, that is abnormal thyroid hormone synthesis, that is due to mutation in thyroid peroxidase in iodine sufficient regions, right? Or there can also be TSH resistance. So the findings are the 6 P's: pot-bellied, pale, puffy-faced child with protruding umbilicus, protuberant tongue, and poor brain development. Because untreated patients can have neurocognitive deficits, right? It's not seen earlier in the case of disease. So initially the T4 is very normal because of the maternal supply, right? But when after a few months the maternal supply of T4 runs out and there's not enough thyroid gland left due to dysgenesis or dysharmonogenesis, there's going to be symptoms of hypothyroidism evident. Yeah, so T4 is initially normal, right, due to maternal supply. And also other cause of congenital hypothyroidism is I want to discuss is thyroid binding globulin deficiency. And so you have to understand what the function of thyroid binding globulin is. So it's in the name that it binds T3 and T4. So it is going to make bound T3 and T4. And just keep in mind that other thing that I told you about, that only the free T3 and free T4, mostly the free T4, can regulate the TSH and TRH release from hypothalamus and anterior pituitary, right? So here if there is the TBG is deficient, there is going to be decrease in bound T4, right? The T4 is bound T4 is less, but free T4 is normal, but the total T4 is less. Total T4 is decreased because of decrease in bound T4. But as the free T4 is normal, it is not going to do any change on the TSH levels. Right. So TSH is going to be normal. And if you measure thyroid binding globulin, it is going to be decreased. T4 is decreased because we measure total T4, right? In the labs, we don't measure bound T4 differently and free T4 differently. So measuring total T4, it is going to be decreased, but TSH somehow is normal. And so you have to figure out that there's thyroid binding globulin deficiency. Okay, that's it. Also, yeah, in Riedl's thyroiditis, we didn't discuss about the histology. So the thyroid is replaced by fibrous tissue and inflammatory infiltrates. So it is not much more commonly asked, but as you can see, this is fibrosis and inflammatory infiltrates, right? Darkened lymphocytes. Okay. And here is the child of cretinism, that is puffy faced pot, eyelid, protuberant tongue, protuberant umbilicus, and pale, everything like that. Poor brain development also there. And after treatment, the puffy face is gone. Now the other causes that are iodine deficiency, most common worldwide. It typically presents with goiter, because as there's less iodine, the thyroid gland undergoes hypertrophy to use even the decreased amount of iodine that it's getting, right? To make the full use of that iodine, it undergoes hypertrophy, right? So that hypertrophy is called goiter. Goiter can be due to hyperthyroidism as well as hypothyroidism. It's not hormone specific. It's just a finding. Goiter is just a finding. And iodine excess can also cause hypothyroidism, that is through Wolff-Chaikoff effect that we discussed in the thyroid hormone synthesis section in the physiology. But and there's drugs, that is amiodarone and lithium, non-thyroid illness syndrome, also called euthyroid 6 syndrome. So there's normal T3 with normal to decreased T4 and TSH in critical ill patients. So why is the T3 decreased? It is also called low T3 syndrome. So why is that so? It's because in sick conditions, ill conditions, there's going to be inflammatory cytokines, right? So that inflammatory cytokines are going to inhibit thyroid peroxidase for a while, not permanently, but just for a while. So when it inhibits thyroid peroxidase, there's going to be reduced conversion of T4 into T3. So that is going to cause less T3, and I think a little bit of accumulation of T4 eventually, not eventually, but a little bit of increase in T4 for just a little bit amount of time, and that increased T4 is going to inhibit TRH and TSH synthesis. So ultimately what happens is, initially there's just decreased T3, but then as TRH and TSH also gets inhibited, there's going to be decreased TSH, decreased T4 and decreased T3. So that is the euthyroid sick syndrome. It's mostly in the ICU patients, seen in ICU patients who are there for longer periods of time. Also in hyperthyroidism, when there's increased TRH, increased TSH, so as we know, TRH also increases prolactin secretion, right? So that is going to cause all the symptoms, galactorrhea and everything. It's not very pronounced. Just have to keep in mind. Right, and I told you about this earlier, but just let me just write it down. That T3 is often normal in hypothyroid because it has a shorter half-life. Right, and it is produced mainly in the peripheral tissues. Hence, it is a poor indicator of hyperthyroidism. So I want to write a few things down. Let me just show you the image first, and then we'll discuss everything else. So this is the differential diagnosis of thyroiditis. If it is a painful thyroiditis, it can be subacute or it can be acute. The acute suppurative type is not significant for our question stems. The one that is significant is subacute thyroiditis, that is decoy vein. It has tender goiter. There's going to be transient hyperthyroid phase. There's going to be it's going to be a post-viral syndrome, that is after a viral infection. And then the second is, if it's a painful, it will be subacute, definitely in the question stems. If it is painless, then you have to figure out, is it Hashimoto's thyroiditis or is it Riedl's thyroiditis, or is it postpartum? So postpartum, you can just figure out if it is within 12 months of delivery, it is going to be postpartum thyroiditis, and it also has a transient hyperthyroid stage. Now the left is Hashimoto's and the Riedl thyroiditis. So as you can see, if there is presence of antibodies, there will also always be given something that can lead to the diagnosis of Hashimoto's, right? Either there will be given positive antibodies like positive anti-thyroid peroxidase or positive anti-thyroglobulin, or in one of the questions I saw, there was given that the patient has history of type 1 diabetes mellitus. So type 1 diabetes mellitus is an autoimmune etiology, right? So and Hashimoto's can be associated with other autoimmune disorders. So that is how you diagnose Hashimoto's, from autoimmune history, and that is very most common, right? Usually hypothyroid diagnosis. And how can you figure out if it's a renal thyroiditis? So it is, if it is hard rock like and non-tender, it is going to be renal thyroiditis. There may or may not be given any history of fibrosing disorder like pancreatitis, retroperitoneal fibrosis and something like that, but just hard fixed rock like thyroid should give that away that it's a renal thyroiditis. And yeah, Graves' disease is also a kind of thyroiditis, right? But it causes but the antibodies in Graves are stimulating antibodies. The antibodies in Hashimoto's are anti-antibodies, right? So anti-thyroid peroxidase, anti-thyroglobulin, so it inhibits the normal function of these thyroid hormones, right? But in Graves' disease there are stimulating antibodies, like stimulating thyroid peroxidase antibody, stimulating thyroid receptor antibody. So it stimulates all the sites in thyroid hormone synthesis, increasing the synthesis of thyroid hormones. There's also going to be ophthalmopathy, right? And in fibrotic, that is renal thyroiditis, there can also be compression of esophagus and trachea due to the fibrosis. So wherever there is fibrosis, it stretches all the nearby structures. We saw it in respiratory too, right? If there's a fibrosing condition, it is going to cause mediastinal shift towards that side because it pulls everything towards that side, right? That is how we differentiate fibrotic. Right. So yeah, now I want to add a few things that I should write at the last page. The extra page that the first aid gives us for writing notes should be used sometime, right? So it is about congenital hypothyroidism. How can you differentiate between different causes of congenital hypothyroid? So free total T4 and TSH. So the first is primary hyperthyroidism. Primary hypothyroidism, that is due to thyroid dysgenesis and dyshormonogenesis. Dysgenesis is more common, so I'm writing that down. There's going to be decreased T4, there's going to be increased TSH. Plain and simple hypothyroidism, which is eminent after the maternal stores of T4 runs out. Second, if there's thyroid hormone resistance, so if whenever there is resistance, the hormone is going to increase, so T4 increases, right? And but still, if the thyroid hormones is resistant, the body is resistant towards the T4, so the body will feel that I don't have enough T4 in me, so that is going to stimulate TSH release even if there's enough T4, but it's just that there is resistance to that T4. So this is how you differentiate between dysgenesis and resistance. In dysgenesis, the TSH is going to be high. In both the cases, the TSH is going to be high, but in primary hypothyroid, the T4 is decreased. That is why it is called primary, right? But in thyroid hormone resistance, T4 is also going to be high. Then the central hypothyroid, which is very rare in children, TSH is low. That is why T4 is also low. Now The one that is important is maternal exposure to different things that can lead to hypothyroid in her kids. Maternal exposure of first iodine excess or iodine deficiency. If there's iodine deficiency in like iodine sufficient regions, that is in developing and underdeveloped nations, like in developing, like in India, there's iodine deficiency is the most common cause, not the Hashimoto's. So that is going to lead to decreased T4 and increased TSH. And even if there's iodine excess, it is going to cause Wolff-Chaikoff effect and cause reduced thyroid hormone synthesis. There's maternal exposure of TSH receptor blocking antibodies. That passes down to her kids. So that is also going to cause similar findings, decreased T4 and increased TSH. And last is NT. Third is exposure to anti-thyroid medications. So I can't remember which are the anti-thyroid medications are right now. I think we come across them somehow, right? Might also be increased dosage of propylthiouracil and methimazole. Right? Increased dosage of those can cause toxicity that can also pass down to fetus and cause hypothyroidism. Right? Yeah, that's just it. Where you can see protuberant tongue, where you can see goiter. So you can see the outline of the goiter. Right. So in hypothyroidism, there's Graves' disease. That's just the counterpart of Hashimoto's thyroiditis. Right? In Hashimoto's, there were antibodies. In Graves, there is stimulating antibodies. And there can also be toxic multinodular goiter. That is just hyperfunctioning follicular cells. Right? And whichever organ is hyperfunctioning, it can be malignant, right? There can also be cold follicles. There are cold follicles and there are hot follicles, hot nodules and cold nodules. Hot nodules are hyperfunctioning. They are rarely malignant, but cold nodules, they can be more malignant because a person does not work, who is lazy, is more prone to get diseases, right? Then there's thyroid storm, which typically occurs after hyperthyroidism that is not very well treated, and there's also a precipitating factor like infection, trauma, or surgery or something like that. Then there's Jod-based phenomena, which is counterpart of the Wolff-Chaikoff effect. In Wolff-Chaikoff, there was iodine-induced hypothyroidism. Here it is iodine-induced hyperthyroidism. But here the catch is there should be autonomous thyroid tissue present, that is autonomous nodule should be present. Right. Okay, let's so Graves' disease, most common cause of hyperthyroidism. Thyroid stimulating immunoglobulin IgG can cause transient neonatal hyperthyroidism and type 2 hypersensitivity, that is a type 2 hypersensitivity, right? So IgG can cross the placenta, as we know, right? And thyroid stimulating immunoglobulin is a kind of IgG which can cross placenta and affect the neonate, causing hyperthyroidism. It stimulates TSH receptors on thyroid, causing hyperthyroidism and diffuse goiter, dermal fibroblast causing peritibial myxedema, and orbital fibroblast causing Graves' orbitopathy. So activation of T cells will cause lymphocytic infiltration of retroorbital space, and lymphocytic infiltrate will secrete cytokines, that is TNF alpha and interferon gamma, that is going to increase fibroblast secretion of hydrophilic GAGs, increase osmotic muscle swelling, muscle inflammation, and adipocyte count, causing exophthalmos eventually. Right. So it often presents during stress, that is pregnancy, associated with HLA-DR3 and B8. So generally the thyroid stimulating immunoglobulins, that are T cells containing antibodies, so whenever those T cells are activated, there's going to be lymphocytic infiltration of retroorbital space. So in retroorbital space, whenever they increase cytokines, that is TNF alpha and interferon gamma, it will cause activation of fibroblasts, right? And that is going to cause osmotic muscle swelling and muscle inflammation. In short, the muscle enlarges and there is inflammation of those muscles, right? That is going to cause exophthalmos. Right. So main cause of muscle swelling is excess glycosaminoglycans and lymphocytic infiltration. These both are the primary cause of the eye muscle swelling. And on histology, there will be tall, crowded follicular epithelial cells and scalloped colloid. So what is scalloped colloid? Scalloped colloid means the follicles are colloid is pushed out of the follicle at the edge of the follicle to make space for the hormone synthesis, right? Because it is a hyperthyroid case. So to make more thyroid hormones, follicles will colloid will be pushed at the edge of the follicle, and that colloid is white oval blank space in histo, you will see it as a blank space that is white in color. So that is not actually blank space, but that is colloid that has scalloped to the edge of the follicle. Let me find an image if I can. This is of that Hashimoto thyroiditis that we just saw. You can clearly see the rim of lymphocytes and germinal centers. Yeah. So as you can see, this is the colloid that comprises the most amount of space in normal thyroid, but in Graves' disease, there is scalloping of colloid, that is this white blank space that is pushed at the edge of the follicles, And here you can see in normal thyroid that the follicular cells are very spaced, right? It's very spacious setting. Whereas in Graves' disease, there is crowding of follicular cells. That's a tall, crowded follicular epithelial cells, right? So there is hyperthyroid-induced bone loss, as we talked about. There's T3 activates osteoclasts, right? Okay, and yeah, so in Graves' ophthalmopathy, steroids are also used. So steroids has no function on the thyroid hormones, but steroids decrease the inflammation in the eyes in Graves' disease. So there was a very important question where it was stated that glucocorticoids are started for their patients. So what is the mechanism of the given drug in Graves' disease? So most of the people take that it reduces thyroid hormones and everything like that, because generally it was a case of hyperthyroidism. So basically everyone will think that, yeah, given any treatment, it is going to decrease thyroid hormones. But steroids are given for reducing the inflammation in the eyes. So it just helps with Graves' ophthalmopathy and not the hyperthyroid as a whole. So there's if we take the labs, there's thyroid stimulating immunoglobulins, TSI, and also there can be thyrotropin receptor antibody. Is TRAB positivity. So now the toxic multinodular goiter, that is focal patches of hyperfunctioning follicular cells distended with colloid working independently of TSH. So even if TSH is high, low, doesn't matter, but there are hyperfunctioning follicular cells that works independently of TSH levels. Due to TSH receptor mutations in 60% of the cases, increased release of T3 and T4. So now even if the TSH is low, as there's TSH receptor mutation, it can't decrease the level of T3, T4. They are going to be secreted from these hyperfunctioning nodules as per their choice. Increased release of T3 and T4 and hot nodules are rarely malignant. For someone who has I remember it that way, someone who has an active lifestyle, right, who works out and who exercises every day, goes on a walk, that is a hot nodule that works very hard. So they are rarely going to get diseases. It's very less likely that they are going to get diseases. So that is the same case for hot nodules, that they are rarely malignant. On the other hand, cold nodules, like the people who have sedentary lifestyle, have more chances of getting sick. So the cold nodules can get malignant. Right? Now the thyroid storm, uncommon but serious complication that occurs when hyperthyroidism is incompletely treated or untreated, and then significantly worsens in the setting of acute stress such as infection, trauma, and surgery. So it's not just untreated hyperthyroidism that can cause thyroid storm, but it should have an precipitating factor like infection, trauma, and surgery, just like in the case of diabetic ketoacidosis. So just reduced insulin cannot cause decay. That should have been a precipitating factor like infections and trauma or something like that, right? So presents with agitation, delirium, fever, diarrhea, coma, tachyarrhythmias causing a cause of death. So this is a very important topic, that important thing, that tachyarrhythmia is the cause of death. We say increased LFTs. So treat with 4 Ps, that is beta blockers, propranolol, propylthiouracil, glucocorticoids, prednisolone, and potassium iodide. So iodide load may decrease T4 synthesis, that is via Wolff-Chaikoff effect that we've already discussed about. Why does beta blockers are given? So beta blockers can decrease all the adrenergic side effects that are there, that is tachycardia, palpitations, tachyarrhythmias, everything like that, agitation. So all those can be blocked by beta blockers. Propylthiouracil obviously is an anti-thyroid medication. Glucocorticoids can reduce the inflammation, right? And potassium iodide, that is lugol iodine. It's very straightforward. It's not very complicated like hypothyroid differentials. Okay. So then there's Jod-based phenomenon. Iodine-induced hyperthyroidism occurs when a patient with iodine deficiency and partially autonomous thyroid tissue, that is autonomous nodule, is made iodine replete. So that autonomous thyroid tissue, which was functioning on its own, will now use all the extra iodine that we've been giving, and by using all of that extra iodine is going to make extra hormones, resulting in hyperthyroidism. It can happen after iodine IV contrast or amiodarone use, right? This is to be remembered that it is after IV contrast, iodine IV contrast. Is opposite to Wolff-Chaikoff effect, okay? And amiodarone can also cause hyperthyroidism. That is why before starting amiodarone, the levels of the TFTs are checked, right? Before starting TFTs, LFTs, both are checked before starting amiodarone. Causes of goiter are smooth. If it's a smooth diffuse goiter, it is Graves' disease, Hashimoto's thyroiditis, iodine deficiency, TSH secreting pituitary adenoma, right? All of these things, because in Graves' disease it's hyperfunctioning, it is hyperthyroid state, so obviously the thyroid gland is going to function more, and that is why it is going to cause goiter, that is enlargement. In Hashimoto's thyroiditis, there are receptor antibodies, and there are antibodies that stops thyroid gland from functioning. So to compensate that, thyroid gland undergoes hypertrophy so that it can try to make more hormones while there are inhibitory antibodies are present. And then there's iodine deficiency, as we talked about, right? In developing and underdeveloped nations, iodine deficiency is the most common cause of hypothyroidism. So to compensate those deficiency of iodine, thyroid gland decides to work more, and to work more it undergoes hypertrophy. And there's TSH secreting pituitary adenoma. More of TSH is coming in from pituitary gland. So to use that TSH to make more T3 and T4, it has to undergo hypertrophy, that is goiter. If it is nodular, you can actually feel the nodes if you palpate the thyroid gland in a nodular goiter, right? It's very easy to observe that. It can be toxic multinodular goiter, that is patches of hyperfunctioning nodules. It can be thyroid adenoma, thyroid cancer, or thyroid cyst. Now, what's thyroid adenoma? Benign solitary growth of thyroid. Most are non-functional, that is cold. And radioactive iodines can rarely cause hyperthyroidism via autonomous thyroid hormone production. Right, and most common histology is follicular. Okay, in absence of capsular or vascular invasion, unlike follicular carcinoma, that we will discuss. Like if this is the capsule, the follicle is going to enlarge here in follicular adenoma. And if it's a follicular carcinoma, you can easily see that it is going to pierce that capsule, invade that capsule, right? Because it is malignant, it can do anything it wants, right? Now, yeah, I forgot one thing about postpartum thyroiditis. That the phase 1, that is transient hypothyroidism due to follicular rupture and release of thyroid hormones, that is of 1 to 3 months. And the patient is hyperthyroid. Then there's phase 2, which is 4 to 8 months. And the patient is phase 2, that is 4 to 8 months, and their patient will be hypothyroid. And then phase 3 is of euthyroid, that is 8 months till delivery, and it is a type of Hashimoto's thyroiditis. Okay, it's not anything different, it's just a type of Hashimoto's. It's just that during pregnancy all of the autoimmune conditions are a little bit flared up because of increase in CD8 plus T cells. Okay, right. And yeah, there's another thing that there will be questions where there will be patients given who is a young female and who participates in beauty contests and everything like that, or who has a parents or who has a family member who has hypothyroidism and takes levothyroxine for that. So that kind of weird kind of history will be given, that there's a family member who is a hypothyroid and takes levothyroxine, but the patient given in the question stem will have symptoms of hyperthyroid. So what is that? So patient must be taking that levothyroxine as an abuse for weight reduction or something like that, mostly the weight reduction for the beauty contests and something like that. So how do we differentiate that exogenous intake of thyroid and endogenous thyroid synthesis? So if it is an endogenous hyperthyroid, thyroglobulin is going to be increased too. Because as soon as the T4 is released from the thyroid follicles, along with that thyroglobulin is secreted from the follicles too, right? So if it is an endogenous hyperthyroidism, T4 is increasingly secreted from the thyroid gland, there is going to be thyroglobulin releasing too. Right? And if it's exogenous hyperthyroid, patient is taking levothyroxine for levothyroxine abuse for weight reduction, something like that. So their thyroglobulin will be low, just T4 is going to increase, and it will mostly be young female in 20s. Thyroid cancer, it is typically diagnosed with fine needle aspiration and treated with thyroidectomy. Complications of surgery include hypocalcemia due to accidental removal of parathyroid glands, due to transection of recurrent laryngeal nerve during ligation of inferior thyroid artery, which leads to dysphagia and dysphonia, hoarseness. So there is the dysphagia and dysphonia is due to transection of recurrent laryngeal nerve which surrounds the inferior thyroid artery. So that will lead to dysphonia and dysphagia. And which are the nerves, that is, which are the muscles that are damaged by this recurrent laryngeal nerve injury resulting in dysphonia and dysphagia? It is cricoarytenoid and arytenoid. And superior laryngeal nerve surrounds I think it surrounds the external superior thyroid artery, external carotid artery, or something like that. I don't exactly remember. So that causes loss of tenure in the voice, and that is due to cricothyroid muscle. Right, so recurrent laryngeal nerve during ligation of inferior thyroid artery, an injury to external branch of superior laryngeal nerve during ligation of superior thyroid vascular pedicle. Okay, may lead to loss of tenure, usually noticeable in professional voice users like singers and speakers and all that. Now the papillary carcinoma. This is the most common one. There's empty appearing nuclei with central clearing. That is called orphan Annie eyes. So orphan Annie was a cartoon character, I think, which had eyes like this. Okay. So from that, they've taken the term orphan Annie eyes. And there are samoma bodies which are calcifications, which are just simply calcifications, and there are nuclear grooves. So there are three things that are important here. Let me so first is orphan Annie eyes, second is samoma bodies, and third is nuclear grooves. Right. Then there's increased risk with RET, PTC rearrangements, and BRAF mutations. And it can also be caused by childhood irradiation. Papillary carcinoma most prevalent palpable lymph nodes and has a good prognosis. Okay, so we'll see the histology of papillary. So as you can see here, there is samoma bodies which are very basophilic, and we know the calcifications appear very basophilic on histoslides. Then there's large overlapping tumor cells. Yeah. Then there's also orphan Annie nuclei if you see closely. And this picture very well shows the nuclear grooves. And there's also nuclear pseudo-inclusion present. Then there's optically clear nuclei, that is orphan Annie nucleus. And you just have to look out for the cells that have clearing, central clearing. Those are the orphan Annie nucleus. Okay. So numerous nuclear grooves as well as intranuclear inclusions composed of cytoplasm, that is pseudo-inclusions, can be seen due to invagination of the nuclear membrane. So what happens is cytoplasm invades the nuclear membrane and forms a groove in the nucleus. And that is called nuclear grooves. Follicular carcinoma has so how does this central clearing, and why does this central clearing forms? So it is due to finely dispersed chromatin that looks like empty ground glass. You should really see the picture of ground glass if you haven't seen it in real life, because that might help you a lot, because there are so many ground glass appearances in medicine, right? So that forms orphan any eyes. Follicular carcinoma, good prognosis. It invades thyroid capsule and vasculature. Because it is a cancer, it can do anything. Unlike follicular adenoma, uniform follicles are there. Heterogeneous spread is common. It is associated with RAS mutation and PARC8 PPAR gamma translocations. Fine needle aspiration cytology may not be able to distinguish between follicular adenoma and carcinoma. Right, so don't do FNAC. Yeah, it has RAS, it has PARC8 and PPAR gamma translocations. This is follicular thyroid carcinoma. Like I told you in the thyroid adenoma, that carcinoma is going to invade the thyroid capsule. So as you can see, this tumor cell is invading the capsule, right? And there are small follicles being developed inside that tumor cells. And this is a normal thyroid adenoma. So you can see there's intact capsule. There is development of follicles, but follicles with colloid in them. This white space is colloid, but it is not invading the thyroid capsule, right? Medullary carcinoma from parafollicular C cells produces calcitonin. This is very important to remember, that it produces calcitonin, right? So it can cause hypocalcemia. Sheets of polygonal cells in amyloid stroma, stains with Congo red, okay, and associated with MEN2A and MEN2B. So that is the only relevance of medullary carcinoma. So it produces calcitonin is less important, but its association with MEN2A and MEN2B is much more common to be asked. And whenever there is, if you think there's medullary thyroid carcinoma in the question stem, so you just have to look out for other options, other diseases that are associated with MEN2A and MEN2B, like pheochromocytoma and pancreatic cancer and all that, right? So pheochromocytoma and parathyroid hyperplasia, if it's MEN2A, and if MEN2B, you have to look out for pheochromo and mucosal neuromas and all that. And this is a mucosal neuroma. MEN2A and MEN2B both are associated with red mutations. Now, histologically, it will produce. So it is a kind of neuroendocrine cells, okay? Parafollicular cells is a kind of parafollicular cells. Not parafollicular cells, yeah. It's a kind of neuroendocrine cells. That is why it is associated with pheochromocytoma or in MEN2A and MEN2B. And histologically, it has polygonal cells and amyloid stroma. So this pink material you can see here is amyloid stroma. You can also see amyloid deposits in between. And there are polygonal tumor cells as well. If you can figure out the outline of these cells, so it is polygonal, and those polygonal cells are derived from parafollicular cells. The last is undifferentiated anaplastic carcinoma. It is found in older patients. Presents with rapidly enlarging neck mass, compressive symptoms, that is dyspnea, dysphagia, and hoarseness. Thus, very poor prognosis. It is associated with TP53 mutations. So, rapidly enlarging neck mass is the keyword here. Then its differential is Riedl's thyroiditis, because it is also a rock-like thyroid mass, and that also causes dyspnea, dysphagia, hoarseness due to pulling of all the structures surrounding it. But so you just have to biopsy it. On histologically, it's not given here, but I'm just telling you that it has pleomorphic cells. Because it is a rapidly enlarging tumor, it has all kind of cells in it, that is pleomorphic cells, and irregular giant spindle cells. Just remember that. I don't think you'll ever get a question for histological slide that you have to diagnose with anaplastic carcinoma, right? So the key mutations are RET, PTC, BRAF, and papillary. In follicular, it is RAS, and PPAR, gamma, PAX, PPAR. In medullary, it's RET, and here it is TP53. Also, one more thing that I think I didn't mention in the scallop colloid, about scallop colloid. That we did discuss about the crowded follicular epithelial cells, right? But we didn't discuss what is scallop colloid. So this is the scalloping of colloid. So what really happens is that colloid is white in color, right? White blank spaces like in color. But colloid is pushed to the periphery of the follicles, right? Because follicles has to make space to grow more hormones, right? To synthesize more hormones. Colloid needs to be shifted to the periphery of the follicles. And that is what is scalloping of colloid. And yeah, there's also crowding of follicular epithelium that we have discussed when we were discussing that Graves' disease. So follicular epithelium is very spacious normally, but in Graves' disease, as we have to synthesize more and more hormones, the follicular cells start becoming crowded. Yeah, so now how do you diagnose parathyroid diseases? So primary hyperparathyroidism is, it can be due to hyperplasia, adenoma, and carcinoma. Right? It's just primary parathyroid gland pathology. So that is going to increase calcium, and that is also going to increase PTH levels. Right? Then there's secondary hyperparathyroidism. So parathyroid hormone acts hyperactively in response to decreased calcium. That decreased calcium can be due to vitamin D deficiency. It can be due to decreased calcium intake, or it can be due to increased calcium loss, that is in chronic kidney disease. Right? Then there's primary hypoparathyroidism. So again, primary, so that is due to etiology of parathyroid gland, and hypoparathyroidism can be due to surgical resection or autoimmune. And there's PTH independent hypercalcemia. There's excess calcium intake or it can be due to cancer, where there is independent secretion of parathyroid hormone releasing peptide, not from the gland itself but from the neoplasia, or there is increase in vitamin D. Now, hypoparathyroidism. So it is due to injury to parathyroid glands or their blood supply, usually during thyroid surgery. So most commonly, this hypoparathyroidism occurs after thyroid surgery. And autoimmune destruction or Dijod syndrome, which can be evident even before or without thyroid surgery. And findings are tetany, hypocalcemia, and hyperphosphatemia. The Shostak sign, that is tapping of facial nerve, will cause in contraction of facial muscles. So that is like a twitch on the unilateral side of face, wherever there is tapping of facial nerve, on whichever side the tapping of facial nerve is done. And the trozo sign is occlusion of brachial artery with cuff, BP cuff, and it will, as you start inflating the BP cuff, there is going to be carpal spasm. Then there's pseudo hypoparathyroidism. So it is pseudo hypo, which means the parathyroid hormones are going to be raised, but it is not able to uh, act on the body, because there's mutation in the PTH receptors. So that is why it is called pseudo hypoparathyroidism. Like even if there's so much of parathyroid hormone, it cannot act on the body. So that is a case similar to hypoparathyroidism, right? So it is autosomal dominant, maternally transmitted mutations, that is imprinted GNAS gene. It is maternally transmitted, that is important. GNAS 1 inactivating mutation coupled to PTH receptor that encodes GS protein alpha subunit. Inactivation of adenylase cyclase when PTH binds to its receptor, that is going to cause end organ resistance to PTH, and it is seen in kidney and bones. Right, so this is an inactivating mutation. It is going to inactivate this GNAS gene, which encodes for the GS protein alpha subunit. So now if it's inactivated, it is not going to respond to parathyroid hormone as it normally does. Right, and if you don't want to remember this everything, it's just fine, because I haven't actually seen any questions on pseudo hypoparathyroidism, like not also this pseudo hypoparathyroidism. Right. And physical findings are Albright hereditary osteodystrophy, that is shortened 4th and 5th digits. Here. Short stature, round face, subcutaneous calcifications, and developmental delay. And yeah, so PTH is high, as you can see. And if there's mutation to this parathyroid hormone, there's going to be decreased calcium and increased phosphates. So these two findings are of hypoparathyroidism, but this finding is of hyperparathyroidism. So that is why it is called pseudo hypoparathyroidism. Right. So there's osteodystrophy, there's short stature, round face, calcifications, and developmental delay. Pseudo hyperparathyroidism is autosomal dominant. It is paternally transmitted mutation, and it does not have end organ resistance, but without end organ resistance to PTH due to normal maternal allele maintaining renal responsiveness to PTH. So kidney is responsive to PTH, but bone isn't, right? Because maternal allele is still normal. It's just the paternal transmitted mutation. Right. So physical findings same as Albright hereditary osteodystrophy. Labs normal PTH, calcium, and phosphate. Right. So that is why it is pseudo hypoparathyroidism, because even the labs are normal. Okay. Now the lab values. It is in vitamin D deficiency. There's just decrease of calcium and phosphate, right? Because if vitamin D is deficient, is not going to reabsorb calcium from the bones, and also absorb phosphate from the intestine, absorb calcium from the intestine, right? So that is going to lead to increase in PTH secretion, increased ALP because of increased bone turnover, and decreased vitamin D as usual. So I'm going to make this arrow to signify what happens first and what leads to what, right? I'll use separate colors so that you can differentiate. So now the second is hypoparathyroidism. So hypoparathyroidism is due to decrease in PTH, and it can be due to surgical resection or autoimmune. Surgical resection is after thyroid hormone surgery. So first PTH decreases, and then it leads to decreased calcium and increased phosphate. Right. Third is secondary. So ALP is normal in that, and vitamin D is decreased. Okay. Because calcium is not being resorbed from the bones, the ALP is normal. Third is secondary hyperparathyroidism. So if phosphate is increasing here, phosphate is the more driving force, so that is going to lead to increased PTH secretion, and calcium is also decreasing, which leads to increased parathormone. Then ALP is increased and vitamin D is normal or decreased. Pseudo hypoparathyroidism, as we've discussed, calcium is decreased, phosphate is increased, and parathormone is increased, but there is resistance to that. Hyperphosphatemia is going to lead to increased PTH. ALP is increased in everything, and vitamin D is decreased in hyperphosphatemia. Now the hyperparathyroidism. Primary hyperparathyroidism is usually due to parathyroid adenoma or hyperplasia. It causes hypercalcemia, and if there's more calcium in the blood, obviously there's going to be more calcium in the urine, right? So calcium in the urine goes through from the kidneys to the ureter, and to kidney to the bladder and to the ureter, right? So it's going to also cause hypercalciuria and cause renal stones as well. And it can also cause polyuria, hypophosphatemia, and labs will suggest that it has increased PTH, increased ALP, increased urinary camp, most often asymptomatic. May present with bone pain, weakness, and constipation. There is groans and abdominal flank pain, and kidney stones are due to acute pancreatitis. It can also cause neuropsychiatric disturbances like psychiatric overtones. So yeah, this is a very good mnemonic, that stones, thrones, bones, groans, and psychiatric overtones. Stones means the renal stones, thrones is polyuria, bones is bone pain, groans is abdominal groans, that is due to constipation, and psychiatric overtones, that is due to neuropsychiatric disturbances. The osteitis fibrosa cystica, cystic bone spaces filled with brown fibrous tissue, that is, it is called brown tumor, consists of osteoclast and deposited hemosiderin from hemorrhages, causes bone pain. Right. So osteoclasts get filled with hemosiderin from hemorrhages. Hemosiderin comes from hemoglobin. So when osteoclast is deposited with hemosiderin, it causes bone pain, and due to increased PTH, classically associated with primary hyperparathyroidism. Secondary hyperparathyroidism, secondary hyperplasia due to decreased calcium absorption or increased phosphate. So most often in chronic kidney diseases, it causes hypovitaminosis D and hyperphosphatemia. So that is going to cause decreased calcium, and decreased calcium will lead to increased synthesis of PTH. Hypocalcemia, hyperphosphatemia in chronic kidney disease versus hypophosphatemia with most other causes. Right, so in other cases where PTH is secreted first, like in primary hyperparathyroidism, so PTH is secreted first, then it is going to increase calcium in the blood and reduce phosphate in the blood. But in secondary hyperparathyroidism, so it is the main pathology is due to chronic kidney disease, where there is decreased calcium in blood and increased phosphate in blood. So that is going to lead to secretion of PTH, right? Not the other way around. So that is why this is the only case where there is hyperphosphatemia in hyperparathyroidism. Right? In other cases, there's going to be increased PTH but decreased phosphate. There's going to be increased ALP and ATP, PTH as well. And renal osteodystrophy is renal disease, secondary and tertiary hyperparathyroidism, and that will lead to bone lesions. Tertiary hyperparathyroidism, that is refractory hyperparathyroidism resulting from chronic kidney disease. Yes, so PTH increases so much. And in secondary hyperparathyroidism, it just starts increasing the PTH, but when the CKD goes to the later stages, end stages, so the PTH increases so much that it is called tertiary hyperparathyroidism. And there's going to be very, very high levels of PTH and increased calcium as usual. Now, familial hypocalciuric hypercalcemia. So generally, whenever there is hypercalcemia, there is always going to be hypercalciuria, because if there's more calcium in the blood, there is always going to be more calcium in the urine. But that is not the case in FHH. So in FHH, there's hypercalcemia, but there is hypocalciuria. Right? So the calcium isn't being secreted into the urine. Defective G-coupled calcium sensing receptors in multiple tissues. There is parathyroids and kidneys. Defective G-coupled calcium sensing receptors in multiple tissues. So generally what happens is the tissues like parathyroid and kidney senses the calcium levels in the blood. And how does it senses the calcium levels? It senses it by G-coupled calcium sensing receptors. So whenever there is decreased calcium in the blood, these parathyroids and kidney will sense that there is less calcium in the blood, we need more parathormone. So that is going to stimulate PTH secretion from the parathyroid gland. So generally that is the case. But in FHH, what happens is these receptors in parathyroid and kidney are not able to sense the decreased calcium levels. Right? So there has to be so much increase in serum calcium that then only the receptors in these parathyroid and kidney can sense that there's so much of calcium level that we have to suppress PTH. Excessive renal calcium absorption. So there's mild hypercalcemia always and hypocalciuria with normal to increased PTH levels. Right? So generally normal calcium levels or even a slight increase in calcium levels can suppress PTH through this calcium sensing receptors. But in FHH, we need higher than normal calcium just to suppress that PTH secretion. And these due to these defective receptors in kidneys, there's also decreased calcium reabsorption. Increased calcium reabsorption. Right? So there's always going to be mild hypercalcemia and hypocalciuria with normal to increased PTH levels. This is very low yield. Okay. Mild hypercalcemia, hypocalcemia. And this is the only case where there's hypercalcemia and hypocalciuria together. Okay. now comes the most important section of this. One of the most important, along with thyroid, is the diabetes mellitus. Everything about DM is important, right? So even if it's pharmacotherapy is very, very important too. Now, the acute manifestation of diabetes mellitus is polydipsia, polyuria, polyphagia, weight loss, DKA type 1, or hyperosmolar hyperglycemic state, that is in type 2. So rarely can be caused by unopposed secretion of growth hormone and epinephrine. Growth hormone and epinephrine. Also seen in patients on glucocorticoid therapy, that is steroid diabetes. Because as we know that glucocorticoids are diabetogenic, right? So the first of all, let's discuss what is the risk factor. So what is the complication of diabetes mellitus? So diabetes mellitus is the strongest risk factor for coronary heart disease. So for coronary heart disease, diabetes is the strongest risk factor. Not genetic factors, not smoking, not aging, not anything else, not obesity, not metabolic syndrome, just diabetes mellitus is the strongest risk factor. Now the chronic complications. So due to non-enzymatic glycation, there is going to be small vessel diseases and large vessel diseases. Small vessel disease, there is diffuse thickening of the basement membrane, which is going to cause retinopathy, hemorrhage, exudates, microaneurysms, and vessel proliferation, glaucoma, nephropathy, right? And nodular glomerulosclerosis will cause progressive proteinuria. Initially, it is microalbuminuria. ACE inhibitors and ARBs are renoprotective. Right, because they constrict the efferent arterioles, right? And arteriosclerosis may also happen causing the hypertension. So arteriosclerosis is just the hardening of the arteries, right? So if the renal arteries are hardening, it can also lead to chronic kidney disease, and it can cause large vessel atherosclerosis that will lead to coronary artery disease, peripheral vascular occlusive disease, PVOD, and gangrene that can lead to limb loss, and cerebrovascular diseases that can lead to stroke. And EMA is the most common cause of death. The osmotic damage, sorbitol accumulation in organs with aldose reductase, and decrease or absent sorbitol dehydrogenase. So glucose gets converted into sorbitol with aldose reductase, and then from sorbitol it is metabolized by sorbitol dehydrogenase. So in absence of decrease of sorbitol dehydrogenase, there's going to be increase in sorbitol accumulation, because as there's increased glucose in diabetes patients, that increased glucose will lead to increased sorbitol, but we have just normal amount or even decreased amount of sorbitol dehydrogenase with aging, so that will lead to sorbitol accumulations in different organs. So sorbitol accumulation in organs will lead to osmotic damage, and due to that it is going to lead to neuropathy, that is motor sensory, that is glove and stocking distribution in palms and the foot, autonomic degeneration, that is GERD, gastroparesis, and diabetic diarrhea. And it can also lead to cataracts. So cataract is a kind of physiological thing, but in diabetic patients we see cataracts at younger age too. So let's just first discuss diabetic gastroparesis. So diabetic gastroparesis is a kind of autonomic neuropathy, as we saw, and it will lead to delayed emptying of food. So it is going to lead to delayed emptying. So it's in the name itself that gastroparesis. So paralysis of the gastrointestinal system. So if there's paralysis, obviously there's going to be delayed emptying and all that. And how do we treat it? We can treat it with metoclopramide and erythromycin. What erythromycin does is it stimulates motilin receptors. We have saw this in physiology section of GIT. And side effects of this is nausea, vomiting, and early satiety. And MI is the most common cause of death. As I told you, that for coronary heart disease, diabetes is the strongest risk factor. Nearly 30 to 40% of the DM patients has MI as their cause of death. And also there's one more thing due to autonomic neuropathy, autonomic degeneration. All the three we saw that it can lead to GERD, that the esophageal sphincter can't really close, so the acid coming in from, because there's autonomic degeneration, there's also degeneration of the nerves supplying the esophageal sphincter, so that is going to lead to reflux of acid from the stomach to the esophagus, hence causing GERD. Then we saw gastroparesis, and it can also lead to diabetic diarrhea. Okay. And there's also one more thing, that is infrequent urination. So it can also damage afferent nerves. Autonomic degeneration can affect the afferent nerves, which can lead to inability to sense the full bladder. And that will lead to infrequent urination. So that will lead to infrequent urination due to damage of afferent nerves. Now I don't really have space here, so now what happens to damage to damage to efferent nerves. So there's going to be incomplete urination. And there's going to be residual volume in the bladder. Just like residual volume in the lungs, there's going to be residual volume of urine in the bladder. And so first, whenever the bladder gets filled with the urine, it can't sense that it is getting filled with urine. It can't send the messages to the brain that bladder is getting full and you have to urinate. Right? First of all, that is the problem. That is the problem when the afferent nerves are damaged. And whenever the person ultimately the person will realize that he has to pee, right? then whenever he tries to pee, there is going to be damage to efferent nerves as well. So the message from the brain can't reach the bladder that you have to fully void the bladder. So if the message is not passing on to the bladder that you have to fully void the bladder, there's going to be residual volume in the bladder, right? So that is the problem because of both damaged efferent and damaged efferent nerves. Now, how is the diagnosis? It's very simple. If the HbA1c is more than 6.5, fasting plasma glucose is more than 126, 2-hour glucose, that is pp2bs, is more than 200, and random plasma glucose is more than 200, but presence of hyperglycemic symptoms is present, like polydipsia, polyuria, polyphagia, weight loss, and all that. So HbA1c reflects average blood glucose over prior 3 months, influenced by RBC turnover. It's influenced by RBC turnover, right? So if it's iron deficiency anemia, there's going to be decreased hemoglobin in men, like in men of older age. There is chances that they have iron deficiency anemia, so that is going to lead to false low HbA1c, right? Because HbA1c is just the glycated sugar on the membrane of the RBC. Now, if the RBC is low itself, there's going to be less glycated sugar on the surface, right? Because there's less RBC, so that is going to lead to false low HbA1c, and that is also the case in thalassemia, right? Because there's different kind of hemoglobin in thalassemia, major and minor, so that is also going to lead to decreased HbA1c. So then fasting plasma glucose should be done at fasting with more than 8 hours. 2-hour oral glucose tolerance test should be done after consumption of 2 hours after consumption of 75 gram of glucose in water. And random plasma glucose in more than 200 with presence of hyperglycemic symptoms is required. Now, the insulin deficiency or severe insulin insensitivity. First of all, if there's insulin deficiency, there's going to be decreased glucose uptake, which can lead to hyperglycemia. So, and insulin was suppressing glycogenolysis and gluconeogenesis. It was doing everything it can to decrease glucose from the serum, but now as insulin is deficient, glycogenolysis and gluconeogenesis are going to flare up. That is also going to lead to increased glucose in the serum, that is hyperglycemia. Insulin was also keeping proteolysis and lipolysis in check, but now as the insulin is decreased, it was keeping proteolysis and lipolysis in check, because insulin is used for protein synthesis, and insulin also decreases lipolysis. Whenever there's insulin deficiency, now there's going to be increased proteolysis, resulting in increased decreased muscle mass and weight loss, right? And increased lipolysis will lead to increased free fatty acids, right? And proteolysis results in secretion of amino acids into the serum, and those amino acids can also lead as substrates for gluconeogenesis, right? And there is also the case with free fatty acids. Like free fatty acids will convert into ketone bodies, and hence it will cause ketogenesis, ketonemia, and ketonuria. So that is also one of the key features of DKA, why there is ketone bodies in DKA. And due to that ketone bodies, there's going to be vomiting, and due to those ketone bodies, there's going to be anion gap metabolic acidosis due to increase in lactate, right? And due to metabolic acidosis, so what is the compensation of metabolic acidosis? It is to excrete the carbon dioxide from the lungs, right? So to excrete the carbon dioxide from the lungs, the patient will start hyperventilating and Kussmaul's respiration. So that is all the things of DKA, right? This is how all the symptoms of decay arises, that is vomiting, hyperventilation, Kussmaul's respiration, anion gap, metabolic acidosis, abdominal pain and all. Vomiting is due to increased ketone bodies. That in ketone bodies came from free fatty acids, which came from increased lipolysis, and those ketone bodies can also increase metabolic acidosis, and that hyperventilation and Kussmaul's respiration just came from the compensation, respiratory compensation of the metabolic acidosis, right? That is respiratory alkalosis, right, compensating the metabolic acidosis. You don't have to just go very deep into that, but I thought we've just completed the respiratory system, so it's a quick little explanation, quick little revision to that. And now the hyperglycemia. Coming back, hyperglycemia and glycosuria will cause increased plasma osmolality, right, because there's more glucose in the blood, and to manage that increased osmolality, we need water too, right, in the serum, same amount of water in the serum. And to keep the same amount of water in the system, in the serum, we need to drink more water, so that is going to lead to increased thirst. And as there's glycosuria, as there's hyperglycemia, there's also going to be glycosuria, and once there's glycosuria, it is also going to bring water with it and excrete the water along with it, so that is going to cause osmotic diuresis. And so what happens is glucose goes into the urine, it takes water with it, and if water is going with it, it is also going to take sodium and potassium with it, and hence everything goes out of the urine, right? So we are hypovolemic, and hypovolemia may lead to circulation failure and decreased tissue perfusion, that is hypovolemic shock. And whenever there is hypovolemic shock, the tissues aren't getting enough oxygen to perform aerobic respiration, right? And if it's not getting enough oxygen to maintain aerobic respiration, it is going to convert to anaerobic pathways, and as we know that anaerobic pathway will lead to synthesis of serum lactate, and increase in serum lactate may cause lactic acidosis, right? So if you work in ICU, you may have seen that the first thing residents do to the admitted patients is draw blood for the ABG, right? And the first thing they look for is the serum lactate, because that gives them the idea that if the patient is in metabolic acidosis, and if the patient is in hypovolemic shock or any other pathology, if the patient is in pulmonary edema, and the patient is hyperventilating, and you can get so many things from the ABG, right? Because I didn't realize that very late, since very late, that why is ABG so important, right? Sorry, so where were we? Yeah, so ABG is initially I didn't think ABG was that important, and why ABG is that important, but it can give us so much information about what's going on in the body, right? Just by looking at the ions and the electrolytes, we can figure out what's happening. Right, so circulation failure and decreased tissue perfusion may lead to increased lactate. It can also lead to coma and death. Right, and now I just want to write here about MODI. That is maturity onset diabetes. It is due to genetic defect in glucokinase. That is, glucokinase is a glucose sensor. It acts as a glucose sensor in pancreatic beta cells to limit the entry of glucose into the cell. So So here glucokinase acts here and inhibits this channel to limit the glucose entry into the cell. Okay. And also I don't think I discussed about this PI3 kinase, that is phosphoinositide 3 kinase pathway. And so first what happens is, let me change the color. First what happens is insulin stimulates IRS1 phosphorylation, that is going to stimulate PI3K pathway, and PI3K will stimulate protein phosphatase, and that will lead to glycogen synthesis. Right. So this protein phosphatase that dephosphorylates the glycogen synthase. So right, it's in the name that it is a phosphatase. So it is going to remove phosphate from glycogen synthase, hence activating it. And once the glycogen synthase is activated, it is going to synthesize glycogen. So that is how this glycogen is synthesized. Right. So glycogen synthesis is through PI3K pathway. This protein synthesis is also through PI3K pathway. And the cell growth and DNA synthesis is through RAS or MAP kinase pathway. Right, so now type 1 and type 2. Autoimmune T cell mediated destruction of beta cells, that is due to presence of glutamic acid decarboxylase antibodies, that is also called GAD antibodies. It's not like we check for these GAD antibodies very commonly, but it is there if you check for it, and it is an autoimmune, right? So it can be associated with several other autoimmune disorders. Type 2 is due to increased resistance to insulin, progressive pancreatic beta cell failure. And insulin is necessary in type 1 always, and sometimes in type 2 if HbA1c is raised than 10%. And type 1 is found normally in the young population, that is less than 30, and type 2 in more than 40. Associated with obesity, no and yes. Genetic predisposition relatively weak, 50% concordance in identical twins, and it's a polygenic, so it depends on several factors rather than just one, that is genetic. And type 2 is relatively strong genetic predisposition. There's 90% concordance in identical twins, and it's polygenic. Association with HLA, that is HLA-DR4 and DR3, 4 minus 3 is type 1. Because it's autoimmune disorder, it is likely that it will have HLA association. And type 2, no HLA association. Glucose intolerance is severe in type 1 and mild to moderate in type 2. Insulin sensitivity is high in type 1 and low in type 2. Ketoacidosis is common in type 1, rare in type 2. Beta cell numbers in the islets is low in type 1 and variable in type 2. And it will have amyloid deposits. Insulin level is low, increase initially but decrease in advanced disease. Classical symptoms of polyuria, polydipsia, polyphagia, weight loss is common but not very common in type 2. Histology is islets, leukocyte infiltration, because it is T cell mediated autoimmune destruction of the pancreatic beta cells, so there has to be leukocyte infiltrates. In type 2, there's amyloid polypeptide, islets of amyloid polypeptide deposits. And in a CKD, as there's decreased GFR, there's going to be decreased insulin excretion, right? So there's going to be increased pronounced hypoglycemia, because we are not able to excrete the insulin out, right? And patient will keep on taking insulin as per his daily dosage, so that will lead to accumulation of insulin, and that will lead to hypoglycemia. Now DKA, so the pathogenesis is insulin non-compliance or increased requirements due to increased stress, that is infection. And as we know that insulin deficiency will cause lipolysis and proteolysis. So lipolysis and proteolysis will cause increased ketone bodies, mainly due to lipolysis. That ketone bodies are beta hydroxybutyrate and acetoacetate, more beta hydroxybutyrate than acetoacetate. So insulin is deficient and ketones are present. And signs and symptoms are DKA is deadly. There is delirium, psychosis, small respiration, abdominal pain, nausea, vomiting, dehydration, fruity breath odor due to axial acetone. Right, it will be a small kid, little kid, maybe around 10, 15, 20, presenting with abdominal pain and hyperventilation. That is very specific, right? You can figure out from the hyperventilation itself that it's a case of DKA in such a young patient. Right, there can be vomiting, nausea, and also history of dehydration. Right. And I don't know about this fruity breath odor, because I haven't smelled this fruity breath odor in any patients, right? But there might be. And labs are hyperglycemia. Labs will suggest hyperglycemia, obviously. There's going to be H plus, because there's there's accumulation of serum lactate, so that is going to lead to lactic acidosis. And if there's acidosis, there's going to be increased hydrogen, decreased bicarb, so anion gap metabolic acidosis, increased urine and blood ketone levels, leukocytosis, normal or increased serum potassium, but depleted intracellular potassium due to transcellular shift from decreased insulin and acidosis, right? So we've discussed about this, that there can be only one thing in the blood, either insulin or potassium, and insulin tend to push potassium into the cell, right? So now if the insulin is deficient, potassium is going to spring back into the blood, right, causing increased serum potassium levels. Osmotic diuresis will cause increased potassium loss in urine and total body potassium depletion, right? So due to insulin deficiency, first the insulin from the cell jumped back into the blood, and due to osmotic diuresis as well, because of hyperglycemia, right? We just saw here that hyperglycemia and glycosuria will lead to osmotic diuresis. So along with water, sodium and glucose, potassium will follow too. So from the blood, potassium will go into the urine, hence the total potassium loss in the body. There can be life-threatening mucormycosis, cerebral edema, cardiac arrhythmias, right? More commonly with COVID patients, diabetic COVID patients, they are very prone to mucormycosis. Right? And the treatment is IV fluids, IV insulin and potassium to replete intracellular stores. And glucose may be required to prevent hypoglycemia from insulin therapy, right? So first of all, what is done is insulin is not given straight ahead. I'm just writing this zone from my 4th year medicine notes, that 1 liter of fluid is given straight away. Then after 1 liter of fluid is given, we start insulin, right? First, I think 10 units is given just bolus, and then 0.1 microgram per kg is given, right, through infusion, IV infusion. And at every few pints of fluid, ampule of potassium is also given, right, to replete the potassium stores. And also at the beginning of fluid replenishment. There is also bicarbonate given to reverse the metabolic acidosis. Right? You may not need to remember that. Glucose may be required to prevent hypoglycemia from insulin therapy. So that is called DI drip, okay, dextrose insulin drip. Right? So along with insulin, dextrose is also given after some amount of insulin and fluid has gone. Right? Not DI drip, it's called GI drip. Right? Yeah, so again, so profound hyperglycemia may lead to excessive osmotic diuresis, and osmotic diuresis may lead to dehydration and increased serum osmolality, that is hyperosmolar hyperglycemic state. So what's happening is the patient has hyperglycemia, right? And it's most common in the type 2 diabetes mellitus patients. So if there's hyperglycemia, it is going to absorb all the water into the serum, and there's glycosuria, so there's going to be osmotic diuresis as well. So there's hyperglycemia, and then there's also osmotic diuresis. So that is what is going to cause that hyperglycemia will stay in blood, but due to osmotic diuresis, there's going to be more water loss in the urine. So ultimately what happens, if there's less water in the blood and more glucose, there's going to be increased serum osmolality. So that is why it's called hyperosmolar hyperglycemic state. And it is classically seen in older patients with type 2 DM and limited ability to drink, and it can lead to dehydration as well because of the osmotic diuresis, because older patients who have limited ability to drink or have in general decreased fluid intake throughout the day, so they are very prone to this HHS, and insulin is present and ketones are deficient. Okay. Signs and symptoms are thirst, polyuria, lethargy, focal neurologic deficits, seizures. And hyperglycemia is often more than 600, even more than what is seen in the DKA patients sometimes. Right. So in DK it's generally around like 400, 500, but in HHS it's tend to be much higher than that too. And increased serum osmolality, that is more than 320. Right. If there's osmolality given in the question stem, it's most probably a HHS kind of question, because they wouldn't give osmolality in DK unless they want to just confuse you. Right, so you can just differentiate between those two with the age group. Right, in DK there will be young patients, HHS there's going to be older patients. Osmolality will be given in HHS, not in DK. There's going to be ABG report given. So most commonly, if there's ABG report given in the question stem, it's going to be diabetes ketoacidosis, but you still have to figure out if it's metabolic acidosis or not. They may just put it for the sake of confusing you. Right. So increased serum osmolality, that is more than 320. Right. There's going to be normal pH, no acidosis, no ketones. Normal and increased serum potassium and decreased intracellular potassium. Right, so due to increased so insulin is present in HHS, so that is why it is not going to push that is not going to bring so much of potassium into the blood, just a little bit amount of bringing potassium from the cells into the blood. So that is going to cause normal or just slight increase in the serum potassium. Right. There's going to be decreased intracellular potassium, right, because there is insulin present, but it's there is insulin resistance too, right? And there's not much that kind of insulin, right? That normal amount of insulin, because as we saw that serum insulin level is increased initially, but decreased in advanced disease, right? So due to decreased insulin in advanced disease, that is going to be decreased intracellular potassium as well. Complications can progress to coma and death if untreated, right? And we treat the HHS the same way we treat DKA. And the hypoglycemia in diabetes mellitus patients, just 2 days ago, and so I went to watch a cricket match in the stadium. So there I came across a diabetic patient who was there, who was very dizzy and was very confused and dizzy and sweating a lot and sitting on a side of the road, right? So me and my friends just went over there to see what's wrong, and the patients started complaining about this sweating and everything. So we ruled out chest pain if the patient had any kind of chest pain and everything. And when I asked him about his history, any disease medical history, he said that he has diabetes, and obviously in cricket stadiums you can't take food with you, take water with you, and take anything with you. So the patient was hungry since the afternoon, and this was around like 11 p.m., right? So the patient was fasting for around 6 to 7 hours, and then and there it was evident that it's hypoglycemia. It's just we didn't even have to check the glucose levels, though the ambulance came later on and they did everything that was necessary. But yeah, so the point is, hypoglycemia is very, very common in diabetes mellitus who are taking everyday drugs and who are not keeping up regularly with their diet plans. Right? So they have to eat at the specific time according to their schedule. They have to take medications according to their schedule. Right? Everything needs to be on schedule for the diabetic patients. Right? Otherwise, hypoglycemia may occur very, very easily. Right, so treated with insulin, usually occurs in patient treated with insulin or insulin secretagogues. Right, there is sulfonylureas and meglitinides. You can see this is sulfonylurea and meglitinides, that is increase insulin secretion. Right, it closes potassium channels in pancreatic beta cell membrane, cell deposes, insulin release by increased calcium influx. Right, so here you can see that hypoglycemia is risk in these secretagogues. Insulin secretagogues are drugs which stimulates the secretion of insulin, right? Despite the glucose levels, right? Because we'll see other classes of drug, that is like the GLP-1 peptide and all, they release insulin just whenever there is increased glucose, right? So there is less risk of hypoglycemia, fasting hypoglycemia. Okay, so insulin will be released just after when the patient is going to take oral glucose. But the insulin secretagogues like sulfonylureas and meglitinides make the body secrete insulin no matter what the level of glucose is. So in those kind of drugs, hypoglycemia is very common. Right? In the setting of high dose treatment, especially when it's taken in high doses, inadequate food intake, like I talked about, that the patient was hungry for 6 to 7 hours, or exercise, it will cause neurogenic autonomic symptoms like diaphoresis, tachycardia, tremors, anxiety, hunger. So the patient had all of these symptoms. Like I felt when we went to the patient, so first of all I felt the pulses of the patient. So it was very high volume tachycardia. So first of all I think the patient might be hypertensive, but when we gave him water, he couldn't even handle the water bottle himself. He was having tremors of that intensity. Right? So these are pretty common symptoms. Even if you know your friends who have diabetes type 1, it's very common. It's very evident in boys hostel that some of the people will have type 1 diabetes, and they'll go around the hostel rooms at midnight asking for food. Right? So everybody borrows food from each other in boys hostel, if you know what I mean. Right? So this allows perception of decreased glucose, that is hypoglycemia awareness. And so these all symptoms are very necessary so as to let the patient know that he is having hypoglycemia, right? And neuroglycopenic symptoms, altered mental stresses, seizures, death due to insufficient glucose in CNS may occur in the absence of preceding neurogenic symptoms in patients with attenuated autonomic response, that is hypoglycemia unawareness. So if there is hypoglycemia unawareness, like if the patient is not having all these symptoms, it's very likely that it will lead to damage of CNS. Right? It may lead to altered mental stresses, seizures, and death at less than 50, at less than 30 mg per dl. Right? And treatment is simple carbohydrates, that is glucose tablets, fruit juice, right? Because that can lead to increased glucose in several minutes. Right? We gave him the sugar packets that we got from the cricket board association. Yeah, right. So what the sugar packets they use for coffee, we just asked them to bring a few packets for the patients, and the patient was better in a span of 5 to 10 minutes. Right? The tremors were gone, the diaphoresis was gone, tremors were gone. Right? And you can also give IM glucagon and IV dextrose. Right, so what glucagon does is it is going to decrease glucose uptake in liver. It is going to increase glucose in the serum, right, by decreasing glucose uptake in liver and increasing glycogenolysis. Right, and hypoglycemia in diabetic patients are also, in addition to patients who take sulfonylureas and meglitinides, also in patients who take exogenous insulin, like in type 1. Right? I said that in boys hostel there are several people in all boys hostel who are like boys hostel people are studying in colleges, so they are in between the ages of 18 to 22, right? So that is the age group prone to type 1 diabetes. And as I told you, there are several people with type 1 diabetes who will roam around the hostel rooms at midnight asking for food or any chocolates or anything sweet kind of food. So why is that very prevalent? It's because they take exogenous insulin, right? And exogenous insulin is not very well regulated. Like, it is going to keep absorbing even if glucose is low. So, and also in type 1 diabetes, there's destruction of type beta cells but there's also destruction of alpha cells. So they also have deficiency of glucagon, which increases glucose in the serum. Right. So if the insulin is low, there's going to be high glucose, and also there's decreased glucose. There's going to be decreased glucose in the serum. I don't know if that made sense, but let me just write it down. So people who take exogenous insulin, that insulin is not very well regulated. It is going to be absorbed even if serum glucose levels are low. Even if serum glucose levels are low. And also in type 1, there's decreased alpha cell mass as well. So decreased glucagon, that may lead to frequent hypoglycemia. And if the patient is having frequent hypoglycemia, frequent hypoglycemic episodes, what it's going to do is it's going to downregulate the beta receptors, because all of the symptoms that we saw is diaphoresis, tachycardia, tremors, anxiety is due to the activation of beta receptors. Right. So if there's frequent hypoglycemic episodes, it is going to cause decreased beta receptors regulation, down regulation of beta receptors, and that is going to cause low hypoglycemic awareness. So the patient might not have these kind of symptoms every time, so often, and if the patient does not have these kind of symptoms every time, that is low hypoglycemic awareness, it can straight away lead to CNS damage, and the patient wouldn't even know, and the patient would come in directly with altered mental stresses, seizures, and even death. Right. The Cushing syndrome, again very important topic, this one, and the next one, that is adrenal insufficiency. Now the Cushing syndrome etiology is increased cortisol due to a variety of causes. First is if the patient is taking exogenous glucocorticoids, that is going to suppress ACTH levels, and if the ACTH are suppressed, there's going to be bilateral adrenal atrophy, right? And if there's bilateral adrenal atrophy, there's going to be reduced secretion of adrenal glands. Sorry, not adrenal gland, adrenal glands hormone. But we are just taking glucocorticoids from outside, so that will lead to increased cortisol action. Second is primary adrenal adenoma, hyperplasia, or carcinoma. Right, so in that case, ACTH is going to be low, and atrophy of the uninvolved gland because ACTH is low. Right, so one gland will be hyperplastic, or it will have adrenal adenoma mass like carcinoma, and the other adrenal gland will be atrophied. Right. And third is ACTH secreting pituitary adenoma, that is Cushing's disease, or paraneoplastic ACTH secretion from small cell lung cancer or bronchial carcinoids, that is going to stimulate adrenal glands and cause bilateral adrenal hyperplasia. And Cushing disease is responsible for the majority of endogenous cases of Cushing syndrome. Right, so both of these primary adrenal adenoma, hyperplasia, and carcinoma, and ACTH secreting pituitary adenoma are known as endogenous cases, whereas taking glucocorticoids from outside is exogenous cause of Cushing syndrome. Right, and if there's primary adrenal adenoma or hyperplasia, there's just going to be hyperplasia of that zona fasciculata, right? Because that is the one producing the cortisol. Zona glomerulosa and zona reticularis will be normal in size, right? Similarly, in ACTH secreting pituitary adenoma, ACTH is just going to stimulate the zona fasciculata to produce more cortisol, right? So the zona glomerulosa and zona reticularis are going to be normal in size, and that is why aldosterone is also normal in size, normal in levels, right? And even if the ACTH is secreted ectopically, like in small cell lung carcinoma, that can lead to melanocyte stimulation, that can lead to hyperpigmentation. It's not like only if there's a primary pituitary adenoma, there's going to be increased MSH. But even if the ACTH is secreted ectopically, it is going to increase the melanocyte levels. Now the findings are increased cholesterol, increased urinary free cortisol, skin changes, that is thinning and stria, facial plethora, acanthosis nigricans, hypertension, immunosuppression, neoplasm. Neoplasm is a cause and not a finding, right? So if there's small cell lung carcinoma and bronchial carcinoma, that is going to cause Cushing syndrome, right? And Cushing syndrome is not causing these neoplasms. Growth restrictions in children, increased sugar, like we talked about, cortisol is diabetogenic, and there's going to be hyperglycemia, insulin resistance, right? Also amenorrhea, moon facies, buffalo hump, osteoporosis, increased weight, that is truncal obesity, and hirsutism. Right, so why is hypertension here? As I said, aldosterone is normal, but still there's hypertension in Cushing's. So why is that so? Because cortisol also has MR action, right? Increase mineralocorticoid receptor activity, right? So that will lead to increased adrenergic activity. The screening tests include increased free cortisol on 24-hour urine analysis, increased, right, so cortisol is obviously increased, that is what Cushing syndrome is. There is increased late night salivary cortisol. So cortisol follows that pattern of day and night. I don't know what is it's called. Forgot the term for it. Right. So at night the salivary cortisol should decrease normally, and cortisol is highest at the morning at morning, and it is the least at afternoon around 3 p.m. and at night. Right. So in Cushing syndrome, even at night the cortisol is raised, and there's no suppression with overnight low dose dexamethasone test. Dexamethasone is exogenous glucocorticoid, right? So that should reduce the cortisol level, but it's not able to do so because the cortisol is already so much high that it can't be suppressed with low dose dexamethasone. Only high dose dexamethasone can suppress that amount of cortisol, right? We'll see that in short. Yeah, so there's images of stria, that is purple stria. It can be very easily seen in the abdominal region, and there's facial plethora in this B. Moon facial plethora, there's moon facies, right? As you can see. Now how is the Cushing syndrome diagnosed? Right, so first 24-hour urine free cortisol is checked, right, and late night salivary cortisol is checked. That is the first step, and if that is raised, then we go on to 1 milligram overnight dexamethasone test, that is low dose dexamethasone test. So normally dexamethasone should inhibit the secretion of cortisol. Not cortisol but ACTH, right? It should inhibit the levels of ACTH, right? Here it is exogenous glucocorticoids reduces the synthesis of ACTH. So on giving dexamethasone, ACTH levels should decrease, and following that cortisol should also be decreased, but we just measure ACTH, right, because we want to differentiate if it's ACTH primary pituitary adenoma or it's adrenal adenoma, right? So we can differentiate between those two only from ACTH levels, right? And the radiological test, we can also differentiate it from radiological, but this is the first step. So 1 milligram overnight dexamethasone test, and then we measure ACTH in the morning. So if it is suppressed, then we know that it's an ACTH independent Cushing syndrome. Right. Right, so we measure cortisol. If that is high, then we measure ACTH. Now if the ACTH is low, it is ACTH independent Cushing syndrome, right? So cortisol is somewhere secreted by itself, so that can be due to either exogenous glucocorticoids or adrenal tumor, right? So cortisol is suppressed, cortisol is secreted from itself, like in exogenous glucocorticoids we are giving cortisol from outside, or adrenal tumor, that tumor is producing cortisol by itself, right? So to confirm, we will do adrenal CT. And if the serum ACTH is also elevated, so that means that ACTH is regulating the increased secretion of cortisol, right? So if ACTH is also increased, we know that it's an ACTH dependent Cushing syndrome. So now we just have to figure out that, yeah, so ACTH is increased in the body, so it might come from pituitary gland, as in pituitary adenoma, or it might come from paraneoplastic syndrome, like from small cell lung cancer, or from bronchial carcinoid as well, that can secrete increased ACTH too, right? But if it is coming from pituitary, we can suppress it through dexamethasone. But if it's coming externally from like small cell lung cancer or bronchial carcinoid, it can't be suppressed by dexamethasone, because dexamethasone has only action on the normal secretion of ACTH in the body, right? And normal secretion of ACTH is from the pituitary gland. So if the ACTH secretion is not normal, like in the small cell lung cancer and bronchial carcinoids, dexamethasone will not be able to inhibit that kind of secretion, because tumor listens to no one, right? Tumor does whatever it wants to, so it is going to keep secreting ACTH despite suppression from the dexamethasone. So yeah, so we do high dose dexamethasone suppression test. So if it is adequate suppression of ACTH, then we know that it can be pituitary adenoma. So to confirm, we'll do MRI of the pituitary. And if there's no suppression of ACTH, we know that ACTH is coming in from outside the pituitary, that is from lungs, right? So to confirm, we do CT of the chest, abdomen and pelvis to look for malignancies like small cell lung carcinoma and bronchial carcinoids, right? We also do CRH stimulation test, that is cortisol releasing test. So in that we give CRH, and then if the ACTH is increased and cortisol is also increased, we are just exaggerating the disease, so that will mean that there is pituitary adenoma, right? So to confirm that, again we do MRI of pituitary, and no increase in ACTH and cortisol, right? Even if with CRH, because CRH will can only stimulate the secretion of cortisol and ACTH if it's coming from pituitary adenoma, right? It can only increase ACTH levels from pituitary. So only if there's pituitary adenoma, the ACTH levels are going to increase. Otherwise, if the ACTH is coming from somewhere else, like from the chest, from the carcinomas, we cannot increase the ACTH level through CRH. So there's no increase in ACTH and cortisol. So it's ectopic ACTH secretion. It is CT of the chest and abdomen and pelvis. Right, so let me just draw a diagram. Now, first of all, let me just add that high dose dexamethasone suppression test is 2 milligram orally is given every 6 hours, 6 hourly for 2 days. Right. So every 6 hours we give 2 milligram of dexamethasone for 2 days, and on the third day in morning we measure the ACTH and cortisol. Right. So this is the ACTH coming from pituitary, and here is the ACTH of ectopic coming in from ectopic sites, that is ectopic carcinoma. Carcinoma of lung. So now dexamethasone suppression test, it can inhibit the ACTH of pituitary, right? And CRH can stimulate ACTH of pituitary. But dexamethasone and CRH has no effect on the ACTH coming from the ectopic sites. And this ACTH of pituitary increases cortisol from adrenal gland. Right. There's also exogenous glucocorticoids, right, that will act as cortisol. So let me just and they will inhibit ACTH of pituitary. Right, so this is the first cause of Cushing syndrome. Now this is the second cause of Cushing syndrome, that is adrenal adenoma. So that can inhibit ACTH. So this is the second cause. And this is the third cause, that is ACTH of pituitary through pituitary adenoma, or ACTH of ectopic carcinoma, that is small cell lung cancer and bronchial carcinoids. Right. Yeah, I don't know if I talk. Yeah, so the aldosterone is going to be normal, okay, in Cushing syndrome. It's just that cortisol has mineralocorticoid receptor activity, that is why it's causing hypertension. Now the Nelson syndrome, that is enlargement of pre-existing ACTH secreting pituitary adenoma after bilateral adrenalectomy for refractory Cushing's disease. That is, increased ACTH will also lead to hyperpigmentation, mass effect, that is headache, bitemporal hemianopia. And the treatment for it is transsphenoidal resection and postoperative pituitary irradiation for residual tumor. So after bilateral adrenalectomy, that we have removed the adrenal glands, there is not much production of cortisol. So what this pre-existing ACTH secreting pituitary adenoma does, it enlarges itself in a veiled attempt to increase the cortisol from the adrenal glands that are not even there, right? So it tries to increase the cortisol levels by increasing the ACTH, and hence for increasing the ACTH levels, the size of the pituitary adenoma also increase. And there's adenoma, pituitary adenoma. If it enlarges too much, it can also rupture and form apoplexy, that is pituitary hemorrhage. It can present as apoplexy, then bitemporal hemianopia, and ophthalmoplegia, and hypotension, seizures. Hypotension because it's a hypovolemic shock circulatory failure, right? Severe headache can also be there. So this is an emergency as well, pituitary apoplexy. We can give post-op pituitary irradiation for any residual tumor. Okay. Now the adrenal insufficiency, okay, more commonly known as the Addison's disease. It's the inability of adrenal glands to generate enough glucocorticoids and plus or minus mineralocorticoids for the body's needs. It can be acute or chronic. Symptoms include weakness, fatigue, orthostatic hypotension, muscle aches, weight loss, GI disturbances, sugar or salt cravings. And this salt cravings is very specific, and you need to remember that. Although you need to remember all the symptoms, but we'll go through each symptoms and how it's manifested, right? And the treatment for adrenal insufficiency is just give glucocorticoids and mineralocorticoids that the person isn't making, like due to insufficient adrenal gland. So the primary adrenal insufficiency is the etiology is in the adrenal gland itself. Decreased gland function, decreased cortisol, decreased aldosterone. So unlike Cushing syndrome, where only zona fasciculata was affected, right? So in adrenal insufficiency, whole of the adrenal gland is being affected, right? All of the layers. So cortisol is also decreased, aldosterone is also decreased, and if aldosterone is decreased and cortisol is also decreased, it is going to cause hypotension due to hyponatremic volumic contraction, right? If there's less aldosterone, it's going to lose sodium in the urine along with water, and that is going to lead to hypovolemia and also hypotension. And it can also cause hyperkalemia and metabolic acidosis, skin mucosal hyperpigmentation, increased melanin synthesis due to increased MSH, a byproduct of POMC cleavage. Right, so if the adrenal isn't functioning properly, what will happen is pituitary gland will secrete more ACTH from the POMC, right? And if the ACTH is being increased, as a byproduct, MSH is also going to be increased. That will lead to hyperpigmentation. Now, metabolic acidosis is also there because, as you can see, there's hyperkalemia as well, and we know that wherever there's potassium, there is going to be hydrogen ion, right? So if we are not able to excrete out potassium, we are also not able to excrete out hydrogen ion. And primary pigments the skin and mucosa, if you want to just remember that, right? And this is very evident hyperpigmentation, right? It's generally very evident in the patients of adrenal crisis. It doesn't need a genius to identify hyperpigmentation of Addison's disease. And Addison's disease, it's chronic primary adrenal insufficiency caused by adrenal atrophy or destruction, most commonly due to autoimmune adrenalitis in US, right, that is resource-rich countries, or TB, that is in India, resource-limited countries, right? So mostly if the patient here in India, we've not been to US healthcare yet, right? So whenever there is patients of adrenal insufficiency detected in India, it's just taken that there has to be a past history of TB. All right. So TB destroys the adrenal gland. Right, now the secondary and tertiary adrenal insufficiency. Decreased pituitary ACTH secretion, that is secondary, or hypothalamic CRH secretion is decreased, that is tertiary. No hyperkalemia, there is aldosterone synthesis is preserved due to functioning adrenal gland, intact RAS, and no hyperpigmentation. Okay, so in this case ACTH is being decreased, so there's going to be less of cortisol, right? But ACTH can't control the aldosterone secretion from the zona glomerulosa, right? So that is why aldosterone is normal here, and there is intact renin-angiotensin aldosterone system as well. And as the ACTH is low, there is also no hyperpigmentation. Secondary adrenal insufficiency is due to pituitary pathologies. Tertiary adrenal insufficiency is most commonly due to abrupt cessation of chronic glucocorticoid therapy. Right? Just like in Cushing syndrome, whenever we give exogenous glucocorticoids, there's going to be decrease in ACTH. Right? So due to that ACTH, there's going to be suppression of the adrenal glands too. Right? Adrenal glands undergo atrophy, and that is why here there's adrenal insufficiency. Right? And whenever there is abrupt cessation of chronic glucocorticoid therapy, so in Cushing syndrome we were giving exogenous glucocorticoids continuously, and due to that exogenous glucocorticoids we were having symptoms of Cushing syndrome. But whenever there's the exogenous glucocorticoids are being stopped abruptly, so what happens is body is now used to that exogenous glucocorticoids, right? So body has suppressed its ACTH secretion, it has suppressed its adrenal gland function by undergoing atrophy of the adrenal gland, right? So body is wholly dependent on that exogenous glucocorticoids. So now if we suddenly stop that glucocorticoids, then what happens is there's going to be very low steroids throughout, very low glucocorticoids throughout the body, because adrenal gland has already undergone atrophy, right? So due to abrupt cessation, there's going to be tertiary adrenal insufficiency. And it can also lead to adrenal emergencies, right? Adrenal crisis is it's what it's called. We'll see later on. Acute adrenal insufficiency, it's also called adrenal or Addisonian crisis, often precipitated by acute stresses that increase glucocorticoid requirements, that is infection, in patients with pre-existing adrenal insufficiency or on glucocorticoid therapy. May present with acute abdominal pain, nausea, vomiting, altered mental status, and shock. That is, this shock is very important. Shock plus acute abdominal pain. Right. So the question stem will go like something. The patient presented with shock, abdominal pain, nausea, vomiting. From that only you can't guess that it's adrenal insufficiency, right? So what they'll do is they'll give a history of associated autoimmune disorder, right? Because we saw the most common cause of Addison's is autoimmune adrenalitis. So that may be associated with other autoimmune diseases as well, like Hashimoto's thyroiditis or Graves' disease or even type 1 diabetes. So from that you have to figure out that the patient has autoimmune etiology, and autoimmune can also cause primary adrenal insufficiency, that is Addison's disease. Right. That is how you differentiate it from diabetes ketoacidosis, because DK also has same kind of presentation, like acute abdominal pain, nausea, vomiting, altered mental status. But in DK there will be younger patients, and also there will be hyperventilation and Kussmaul's breathing and everything. Right, and there may be something ABG may also be given in the DK, right? ABG would not be given in the questions of Addison's diseases. So whenever there is Addison's crisis, there's going to be decreased cortisol, there's going to be decreased ACTH, and there's going to be decreased CRH. So Waterhouse-Friderichsen syndrome is bilateral adrenal hemorrhage in the setting of sepsis. That is in meningococcemia, acute primary adrenal insufficiency. So we've seen in Neisseria meningitis in microbiology in sketches. You must have seen it in sketchy videos, right? That there's Waterhouse-Friderichsen syndrome in Neisseria meningitis due to the setting of sepsis developing. Right? So it can also present as primary adrenal insufficiency. And there's Neisseria meningitis meningococcemia, which history will be given as students who are living together in the that boys hostel or in the dorms, right? So it's common in the dorms, right? And we didn't discuss about the symptoms. So the weakness, fatigue, orthostatic hypotension can all be explained by the loss of sodium in the urine. Right. And as there is hyponatremia, there's going to be increase in ADH secretion, and that ADH will lead to water retention. So that may lead to more euvolemic hyponatremia. And muscle aches, weight loss, GI disturbance, muscle aches and weight loss all are due to decreased cortisol secretion. And GI disturbances are also due to decreased sodium. Sugar and salt cravings are also due to decreased sodium. Now, how do we diagnose adrenal insufficiency? We first check for cortisol levels. Right? We check for cortisol levels in the morning. So normally cortisol is less than 1.8 microgram per deciliter. So in Cushing's syndrome, it will be increased. So it will be increased around more than 20 microgram per deciliter. But in adrenal insufficiency, it will be very, very low. So the normally cortisol should be less than 1.8 microgram per deciliter. And then we do ACTH stimulation test too. So if we check cortisol, if it's decreased AM cortisol, and if we do ACTH stimulation test, and if there's is decreased peak cortisol, so with ACTH cortisol should rise, right? But there is not enough rise in the cortisol as we've assumed with ACTH stimulation. Then it's adrenal insufficiency. And then we measure, first we've measured cortisol, then we measure random serum ACTH. So if serum ACTH is increased, we know that it's primary adrenal insufficiency, that adrenal gland isn't making much enough cortisol, and that is triggering the pituitary to make more and more ACTH, right? But if the ACTH is also decreased or appropriately normal, we know that it's secondary or tertiary adrenal insufficiency, and the pituitary isn't secreting enough ACTH to stimulate adrenal glands to secrete cortisol, right? And another function of cortisol that I want to write down is decreased cortisol is going to increased ADH, as we saw, right? Because decreased cortisol will lead to hypotension and decreased sodium, and that will lead to increased ADH, and it's also going to cause increase in norepinephrine, right? Because as we know, it's not a direct effect, but decrease in cortisol will also decrease epinephrine, and therefore there is going to be compensatory increase in norepinephrine. And if you want to go back to that physiology section, yeah, here it is. Right, it upregulates alpha-1 receptors on arterioles, increased sensitivity to norepinephrine and epinephrine, right? So cortisol generally increases blood pressure by upregulating the alpha-1 receptors, and at high concentration, that is in Cushing's, it can act on the mineralocorticoid receptor as an aldosterone. Right, so that is why there's compensatory increase in norepinephrine functions. But even I have not understood it very clearly, but I just remember it that decrease in cortisol will lead to increase in norepinephrine levels. Maybe it's in compensation for the hypotension, God knows, okay? Because we know that adrenal insufficiency will cause hypotension, so it might be that to compensate for that hypotension, norepinephrine must be increasing, okay? So yeah, first we check for the cortisol, then we can also do ACTH stimulation test to see if ACTH can trigger cortisol levels or not. It may not if there's adrenal insufficiency, right? So ACTH will not be able to raise the levels of cortisol if it's Addison's disease. Then first we figured out that yeah, cortisol is low, so it is a case of Addison's disease, right? It is a case of adrenal insufficiency. Then we have to figure out if ACTH is low or high to differentiate between primary or secondary adrenal insufficiency. So if ACTH is high, so that means it's a primary adrenal insufficiency, and if its ACTH is low, that means the etiology is in pituitary gland and it is secondary or tertiary adrenal insufficiency. So it's very similar, a very simple test compared to what we saw in the Cushing's disease, right? In Cushing's too, I think it's pretty easy, but I think I made it very difficult and I might have confused you guys. So yeah, we just look for cortisol, right? So cortisol is increased in Cushing's, or we can also do low dose overnight dexamethasone test, and right, so low dose may not be able to suppress the cortisol levels, right? So if it's not able to lower the cortisol levels, we diagnose it as Cushing's syndrome. Now then we have to go to the cause of the Cushing syndrome. To find the cause of anything endocrine, that is Cushing's or adrenal insufficiency, we have to look for ACTH levels. Just like in adrenal insufficiency, we saw for serum ACTH, we measured serum ACTH for figuring out if it's primary or secondary adrenal insufficiency. In Cushing's too, we look for serum ACTH. So if serum ACTH is suppressed, we know that it's due to adrenal tumor or exogenous glucocorticoids, right? So the adrenal gland is producing cortisol on its own, or the patient is taking cortisol on its own from outside, that is exogenous glucocorticoids. So there will be suppressed ACTH. Now if the ACTH is also elevated, it can be from two things. It can be from either pituitary gland secreting ACTH, that is stimulating adrenal gland to produce more cortisol, right? In that case, we have to scan pituitary gland with MRI, right? Or it can be due to something else that is producing ACTH on behalf of pituitary gland. And what that may be the small cell lung cancer or bronchial carcinoma, that's secreting ACTH, that is stimulating adrenal gland to secrete more cortisol. So in that case, we just have to look for that tumor via CT scan of chest or abdomen or pelvis. And we can also do CRH stimulation test, and that is called ACTH dependent Cushing syndrome. So ACTH is raised and that raises cortisol, right? So that is called ACTH dependent Cushing's. And you can also do CRH stimulation test. If we give CRH, it has to act on the pituitary, right? So if it acts on pituitary and increases ACTH and increases cortisol, we know that it's a defect in the pituitary gland, right? So but if we give cortisol and nothing happens in the ACTH levels, there's no effect on the ACTH levels, we know that ACTH is not coming in from pituitary. If it's coming in from pituitary gland, our CRH should have increased that ACTH, right? So ACTH must be coming from somewhere else, that is small cell lung cancer or bronchial carcinoma. So in that case, we again have to do CT scan of the chest, abdomen or pelvis, right? Sorry if I made that even more confusing for you guys. And I also want to discuss about metabolism stimulation test. I know we've talked about this in brief, but let's just go over it again because it is used in Addison's disease. So what metabolism does is, I don't know if I'm pronouncing it right, metabolism inhibits cortisol formation in zona fasciculata. How does that? We'll see. So let me go back to that. Right, so metabolism inhibits that 11 beta hydroxylase enzyme. So what is happening is it is going to increase 11 deoxycortisol levels, it's going to increase 11 deoxycorticosterone levels, and it is going to increase the ACTH levels as well. Here the ACTH part is very important for us, that it increases ACTH levels. Okay. So it inhibits 11 beta hydroxylase and it is going to increase. That is why it is going to increase 11-deoxy cortisol in serum, and that 11-deoxy cortisol in serum gets converted into 17-hydroxy corticosteroid in urine, and that is why its levels 17-hydroxy corticosteroid levels in urine also increases. But for us, the 11-deoxycorticosterone level is important, and even more than that, even more than the 11-deoxycorticosteroid levels, increased ACTH levels are important. So it increases ACTH levels, and all of these happen in a patient with normal HPA axis, that is in patients who does not have adrenal insufficiency, right? So what happens if the patient has adrenal insufficiency? So in adrenal insufficiency, these hormones does not increase. As ACTH is already very much decreased. Right. Decreased, so can't form 11-deoxycorticosteroid. So this is the HPA axis. So what is the case in this adrenal insufficiency? That ACTH is going to be low, right? So whatever happens here, we inhibit this 11-beta hydroxylase at this step, right? So methyropon acts at this stage. So if the ACTH is already low, then there's not going to be any kind of increase in its level like in normal HPA axis patients. So that is why ACTH is not going to increase. Right. So yeah, this test, there are only 1 or 2 questions that I came forward about this test, and this test is also, I think, very obsolete now. It's nowhere used nowadays, and it's very complicated test. It's very easy to just measure cortisol and ACTH levels. Now the hypoaldosteronism or Cone syndrome. It's just like adrenal insufficiency, but in adrenal insufficiency there was decreased cortisol as well as decreased aldosterone. Here only aldosterone is decreased. Aldosterone is increased. Okay, that is hyperaldosteronism. Right. So yeah, it's like Cushing's disease, but in Cushing's just cortisol is increased. In hyperaldosteronism, Cone syndrome is just aldosterone is increased. Right, and there's just one important thing about this topic, that is aldosterone escape mechanism. So how is the patient stable even if there's increased aldosterone in the blood? How is the patient not much hypertensive, not much edematous, everything that we'll see. That is the only important concept here. So increased secretion of aldosterone from adrenal gland. Clinical features include obviously hypertension, decreased or normal potassium, metabolic alkalosis. And because if potassium is decreasing, hydrogen is decreasing too. Right? Hydrogen is being lost from the kidneys as aldosterone is increased. Primary hyperaldosteronism does not directly cause edema due to aldosterone escape mechanism. However, secondary causes of hyperaldosteronism, that is heart failure, impair the aldosterone escape mechanism, leading to worsening of edema. So, what is this aldosterone escape mechanism? So, as aldosterone increases, the BP increases too, right? So, patient is in hypertension. So, and not just hypertension, there is increased in the volume of the blood flow too, right? There's increased in volume of blood due to absorption of sodium and water from the kidneys, right, due to increased aldosterone. So what happens is increasing blood flow to kidney also due to increased blood volume, the GFR is going to increase too, right? And if the GFR is increased, there's going to be increased sodium excretion too, right? Relatively increased sodium excretion, like compared to normal people. And also if there's increased blood volume, there's going to be stretching of the heart, stretching of the blood vessels, stretching of the atrial and ventricular walls, right? And if you've forgotten till now, watch what we saw in cardiology, that whenever there's atria and ventricles wall stretching, it's going to release ANP and BNP. And what ANP and BNP does, they do natriuresis and diuresis. So that way sodium is going to be excreted from the kidney, right? Even if there's increased aldosterone and it's reabsorbing all the sodium, but with the help of ANP, BNP and increased GFR, we are getting rid of the extra sodium from the body. And that is why the patients are relatively stable due to this escape mechanism. But if there's heart failure, right, so there's already heart failure, there's already increased blood volume in the, there's already increased preload on the heart, right? So that is going to numb down the ANP and BNP receptors, right? And also if there's increased preload in heart and it's a systolic failure, there's going to be decreased GFR. So that is also going to affect sodium excretion, right? So that is why it is said that in certain causes of secondary, in certain secondary causes, that is heart failure, that is impair the aldosterone mechanism, leading to worsening of edema. Right. So let me just write it down. So if aldosterone is increasing, it's going to cause hypertension. As hypertension and blood volume is increasing, is going to cause increased renal blood flow and increased GFR, right? Whenever there is increased GFR, there is going to be increased sodium excretion, right? Because kidney is getting more and more blood to get rid of the sodium. And also if there is increased blood volume, there's going to be ANP and BNP being secreted. So that is also going to cause sodium excretion. ANP and BNP also causes diuresis too. And now if there's heart failure, what's going to happen is there's ANP, BNP will not be released because there is numbing down of this ANP, BNP. But more important than that, there's going to be systolic failure, right? If there's systolic failure, there's going to be decreased cardiac output, and that is going to lead to decreased GFR as well, and that will lead to decreased sodium excretion. Yeah, so that's pretty much it. There's not much to understand here. like heart failure, can lead to worsening of the edema. Yeah, there's hypertension, there's normal or low potassium, and due to decreased potassium, there can be muscle weakness, and there can be paresthesias. There's metabolic alkalosis. Primary hyperaldosteronism is seen in patients with bilateral adrenal hyperplasia or adrenal adenoma. Right, adrenal adenoma, just like in Cushing syndrome. Here the adrenal adenoma is in zona glomerulosa. Increased aldosterone, decreased renin, because as there's increased aldosterone, there's not much need of renin. Right. And aldosterone is being secreted from the adenoma. It is not being stimulated by the renin as it is normally, right? So whenever there is low blood volume, there's some stimulation of RAS system. So that goes like there's a first increase in renin, then there's increase in angiotensin, then there's increase in aldosterone, all that. So that will lead to increased renin as well as increased aldosterone. But here aldosterone is secreted from the adrenal adenoma, right? So there is no need of going through the renin pathway. It leads to treatment-resistant hypertension. Right. Secondary hyperaldosteronism is seen in patients with renovascular hypertension, juxtaglomerular cells tumors, renin-producing tumors, and edema, that is cirrhosis, heart failure, nephrotic syndrome. So the secondary hyperaldosteronism, it all depends on increased renin, increasing the aldosterone. So why is this renin increased? It may be due to several reasons. It may be due to renal artery stenosis that decreases the GFR, right? And whenever the GFR is decreased, it stimulates the juxtaglomerular cells, JG cells, to secrete more renin, and through that aldosterone is also increased. Or it can be a juxtaglomerular cell tumor, or it can be congestive heart failure where there's systolic dysfunction. So there's also going to be decreased renal perfusion, just like we saw here. Decreased GFR will cause increase in renin to bring back the blood volume to normal. Right? It's a vain attempt to increase the blood volume to normal. Right? Nothing beats the heart failure eventually. Right? Heart failure triumphs everything. Right? This petty renin and aldosterone are not going to do anything helpful to the blood volume once the end stages of heart failures are near. Right, now the neuroendocrine cells. So first let's just look at the name neuroendocrine. Neuro means it's a nerve-like, and endocrine means it's hormone producing. So neuroendocrine cells are nerve-like cells that produces different kinds of hormones, and the tumors of it may have both of these symptoms, like it may produce hormones too, and it may produce it may look like a neurons too, right? It may look like a cluster of nerves, but it may produce hormones. So heterogeneous group of neoplasm originating from neuroendocrine cells, which have traits similar to nerve cells and hormone producing cells. Like most neoplasms occur in the GI system, that is in carcinoid and gastrinoma, pancreas, insulinoma, and glucagonoma, and lung, that is small cell carcinoma. Also in thyroid, that is medullary carcinoma, and adrenals, pheochromocytoma. carcinoid and gastrinoma, insulinoma, glucagonoma, small cell lung carcinoma, and medullary carcinoma that produces calcitonin, and pheochromocytoma that we'll shortly see. These neuroendocrine cells, that is like the pancreatic beta cells or enterochromaffin cells in GI, share a common biologic function through amine precursor uptake decarboxylase, that is APUD, despite differences in embryologic origin, anatomic site, and secretory products. That is, it secretes chromogranin A, NSA, neuron-specific enolase, synaptophysin, serotonin, histamine, and calcitonin. We check for these secretory products in the blood to diagnose neuroendocrine tumors. Treatment is just surgical resection and somatostatin analogs, octreotide, right? Now the neuroblastoma is the most common tumor of the adrenal medulla in children. Most common tumor in children. And most common tumor of adrenal medulla in adults is pheochromocytoma. So in children it's neuroblastoma, in adults it's pheochromocytoma. Usually less than 4 years old, originates from the neural crest cells, occurs anywhere along the sympathetic chain. The most common presentation is abdominal distension and a firm irregular mass that can cross the midline. Versus Wilms tumor, which is smooth and unilateral, it cannot cross the midline. Right? That is the most important differentiating feature between the Wilms and the neuroblastoma. The neuroblastoma is an irregular mass which can be felt in the abdominal examination, and it can cross the midline. And Wilms tumor may not cross the midline, and it's a smooth. Less likely to develop hypertension than with pheochromo, because neuroblastoma is normotensive, right? And also it's just usually less than 4 years old. So we haven't seen much cases of hypertension in less than 4 years old, right? So neuroblastoma may not be causing hypertension. Right? That's one way you can remember. Can also present with opsoclonus myoclonus syndrome, that is dancing guys, dancing feet. The HVA and VMA, that is homovanillic acid and vinyl mandelic acid, increases in urine, that is catecholamine metabolites. Right? Because it's catecholamine metabolites, because it's a tumor of adrenal medulla that leads to norepinephrine and epinephrine synthesis. Right? Adrenal medulla is responsible for epinephrine and norepinephrine. So HVA and VMA are it's metabolized in urine. Homoryte rosettes, that is neuroblast surrounding a central area of neuropil. That is, rosettes is rose-like. So this is surrounding a neuropil. These neuroblasts are surrounding the neuropils, right, in a rose-like pattern. Characteristic of neuroblastoma and medulloblastoma, right? All the blasts. And Bombay seed and NAC is also positive, associated with amplification of NMYC oncogene. So the mnemonic includes everything, starts with N, like it's normotensive, it has NAC positivity, that is neuron specific enolase positivity, it is associated with NMYC oncogene, right? And it originates from the neural crest cells. And yeah, one thing I forgot to mention, the mechanism of hypokalemia causing muscle cramps in Conn syndrome, that is hyperaldosteronism. So generally in hyperkalemia, or whenever the potassium is increased, this is the normal action potential in muscles. In hyperkalemia, this graph is going to be somewhat like this. So this is called depolarization, right? Like if this is 0, this is negative, this is positive. So wherever there is depolarization, there's going to be increased muscle excitability, right? Because muscle needs to be depolarized in order to contract. And in case of hyperaldosteronism, the graph will show something like this. That is, it's hyperpolarization due to hypokalemia. Kalemia is, potassium is a positive ion, right? So decrease in potassium is always going to cause decreased negative action potential, right? Sorry, not decreased, but decrease in positive ion will lead to more negative charge, right? So more negative charge or more negative potential. So that is what hyperpolarization is. And if it's hyperpolarizing, there's going to be decreased excitability. Pheochromocytoma, that is, it's the most common tumor of the adrenal medulla in adults. So in children it's neuroblastoma, in adults it's pheochromocytoma. It's derived from the chromaffin cells that arises from the neural crest, just like neuroblastoma. Okay. It may be associated with germline mutations, for example NF1 VHL RET, that is in MEN 2A and MEN 2B. NF1 VHL and RET. Rule of tens, that is now absolute and is not considered much now. That is 10% of pheochromo may be malignant, 10% bilateral, 10% extra adrenal, bladder wall, organ of Zuckerkandl, 10% calcify, and 10% in kids. So this is something like 25% is now malignant and 25% maybe bilateral and something like that. But this rule of tens is not used nowadays. Symptoms is most tumors secrete epinephrine, norepinephrine and dopamine, which can cause episodic hypertension. May also secrete EPO, polycythemia, right, due to erythropoietin. Polycythemia may be there, and symptoms occur in spells, that is relapse and remit. So episodic hyperadrenalic symptoms, that is pressure, increased pressure, that is hypertension, pain, headache, perspiration, palpitations, tachycardia, and pallor. Right. And as common as the hypertension, there's also postural hypotension, that is equally more important in pheochromocytoma. It's not much discussed theoretically, but patients who have pheochromocytoma, they are very, very prone to postural hypotension as well. Right. So much common that the patients admitted in the ward with pheochromocytoma are not even instructed to walk on their own, because they can have postural hypotension anytime, right? And there should always be a person or a relative that can assist that patient when walking towards bathroom or something like that, right? They are not allowed to walk on their own. And pallor is due to alpha mediated vasoconstriction. Hypertension is also through alpha mediated vasoconstriction, right? Findings are increased catecholamines and metanephrines, example homovenilic acid, vinylmandelic acid in urine and plasma, just like in neuroblastoma. HVA and VMA. Chromogranin, synaptophysin, and neuron-specific enolase are also positive. These goes for all the neuroendocrine tumors, right? Be it small cell lung carcinoma, be it carcinoid tumor, gastrinoma, or medullary carcinoma. Right? Treatment is irreversible alpha antagonist, that is phenoxybenzamine followed by beta blockers prior to tumor resection. So mostly the treatment of the pheochromocytoma is of 10 to 15 days. So alpha antagonist, that is phenoxybenzamine, is given for 10 days or so. Then the patient is shifted on the beta blockers for a couple of days, and then the tumor is resected. Why is that? So we give alpha antagonist and beta blockers so that we can minimize the adrenergic side effects and minimize the release of these catecholamines if there's any during tumor removal. Like during tumor removal, there can be leakage of some catecholamines from the tumor itself. So we give phenoxybenzamine and beta blockers. And also to decrease this BP, so that due to during tumor resection and leak of catecholamines, there may not be increased hypertension, like sudden hypertension during the tumor removal. Alpha blockade must be achieved before giving beta blockers to avoid hypertensive crisis. A before B, right? Because if we just give beta blockers only, then there's going to be unparalleled, uncompensated stimulation of alpha receptors. So we have to achieve alpha inhibition first, and then we achieve beta inhibition as well, right? And not the other way around. The MEN syndromes, that is multiple endocrine neoplasias. So all MEN syndromes have autosomal dominant inheritance. The X-men are dominant over Allens. So in the earlier first stage, there was the mnemonic that all men are dominant, but no wonder they removed it. And MEN1 includes pituitary tumors that secretes prolactin or growth hormone, pancreatic endocrine tumors, and parathyroid adenoma. So I would like to remember it as pituitary, then parathyroid, and then pancreatic. So going from head to below in the body, you have to remember pituitary, that is very specific to MEN1. Then there's parathyroid adenomas, and then there's pituitary endocrine tumors, that is Zollinger-Ellison syndrome, insulinoma, VIPomas, and glucagonomas that are rare. Is associated with mutations of MEN1 tumor suppressor codes for menin chromosome 11. Okay, so this is MEN1 tumor suppressor codes for menin chromosome 11. Angiofibromas, collagenomas, and meningiomas can also be present. MEN2A is parathyroid hyperplasia. Medullary thyroid carcinoma is neoplasm of parafollicular C cells, and it secretes calcitonin. And prophylactic thyroidectomy may also be required if MEN2A is diagnosed earlier than medullary thyroid carcinoma, right? If the patient is presenting with pheochromocytoma and is then tested for RET mutations and it comes out positive, we do prophylactic thyroidectomy so that medullary thyroid carcinoma does not develop. It is associated with mutations in RET, that is a proto-oncogene, and it codes for receptor tyrosine kinase on chromosome 10. And MEN2B is for medullary thyroid carcinoma, pheochromocytoma, and mucosal neuromas. Right, so medullary thyroid and pheochromo are same as in MEN2A, but mucosal neuromas are added in MEN2B, and it can be oral intestinal ganglioneuromatosis. Right. So this is the image of that mucosal neuromas. Right, so this is mucosal neuromas, numerous small papules and nodules on the tongue. It is associated with marfanoid habitus, and mutation in red gene. So yeah, starting from above, pituitary, then parathyroid and pancreas is in MEN 1, then the parathyroid, thyroid and pheochromo, that is in MEN 2A. Right. So pituitary is just in MEN 1, then we move downwards, then there's no pituitary in MEN 2A. Right. So MEN 2A is little downwards than MEN 1, so there is no pituitary in that. There's just parathyroid, thyroid and pheochromo, that is in adrenal medulla. And then even if we go more downwards, then there's just thyroid and pheochromo. So that is in the order that pituitary is in the head, then there's thyroid, and above that there's parathyroid glands. So this is MEN 1, this is MEN 2A, and then there's MEN 2B in the adrenal medulla. And this is MEN 2B as well. And this is MEN 2A. And mucosal neuroma is frequently asked, so that is usually in the MEN 2B. It is associated with marfanoid habitus as well. So MEN 1 has 3P, that is pituitary, parathyroid and pancreas. MEN 2A has 2 P's, is parathyroid and pheochromo, and also medullary thyroid cancer. And MEN 2B has just 1 P, that is pheochromocytoma. Another pancreatic islet cell tumors, that is insulinoma. It is a tumor of pancreatic beta cell and causes overproduction of insulin, which causes hypoglycemia. May see Whipple's triad, that is low blood glucose, symptoms of hypoglycemia, lethargy, syncope and diplopia, and resolution of symptoms often after normalization of plasma glucose levels. So that is the Whipple's triad. Right? Low blood glucose, symptoms of low blood glucose, and resolution of low blood glucose after giving plasma glucose. Symptomatic patients have decreased blood glucose and increased C-peptide levels versus exogenous insulin use. So insulin is being secreted from the tumor, right? So that is going to convert. So insulin from tumor is also secreted via pre-proinsulin, then proinsulin, and insulin and C-peptide secretion, that pathway. Right? But in exogenous insulin, we give directly the formed insulin without the pre-pro and pro-insulin and C-peptide. So in exogenous insulin use, there's just increase in insulin, but due to insulinoma, there's going to be increase in insulin as well as C-peptides. 10% of cases associated with MEN 1 syndrome. And treatment is surgical resection. Glucagonoma is tumor of pancreatic alpha cells, overproduction of glucagon. Presents with 6 Ds, that is dermatitis, necrolytic migratory erythema, diabetes, hypoglycemia, DVT, declining weight, depression and diarrhea. And the treatment is again surgical resection, and octreotide may also be given. Okay. So there's dermatitis, that is necrolytic migratory erythema. It is important, some image-based question may be given for dermatitis that would have erythematous plaques, crusting and scaling. And there may be hyperglycemia also. So that way you can diagnose it as glucagonoma. And somatostatinoma is tumor of pancreatic delta cell, overproduction of somatostatin. So it will inhibit everything, right? So decrease secretion of secretin, cholecystokinin, glucagon, insulin, gastrin, GIP. May present with diabetes, glucose intolerance, steatorrhea due to malabsorption of fat, right? Due to decrease in secretin and decrease in cholecystokinin, gallstones due to decrease in cholecystokinin due to gallbladder stasis, echlorhydria due to decreased synthesis of gastrin. Treatment is surgical resection, somatostatin analogs, that is octreotide, for symptom control. Carcinoid tumors arise from neuroendocrine cells, most commonly in the intestine or lung. Neuroendocrine cells secrete 5-HT, that is serotonin, which undergoes hepatic phosphorus metabolism and enzymatic breakdown by MAO, that is monoamine oxidase in the lung. It's in the lung. Okay. If 5-HT reaches the systemic circulation, that is after liver metastasis, carcinoid tumor may present with carcinoid syndrome. But I've written this here that, but with bronchial carcinoid, the thing is, even without metastasis, it can lead to secretion of serotonin directly into the systemic circulation, leading to carcinoid syndrome without metastasis. Right? So if the carcinoid is in the GI system, it has to reach liver. It has to metastasize to liver to enter the systemic circulation, right? But if it's in bronchial system, it can secrete serotonin directly into the system. So what is carcinoid syndrome? It's mostly due to increased serotonin that will lead to episodic flushing. There's going to be diarrhea, wheezing, right-sided valvular heart disease, that is tricuspid regurgitation, that is very specific. Like, we don't see tricuspid regurgitation very normally. So whenever there is question of tricuspid regurgitation, we should first of all think about the carcinoid tumors and also about IV drug abuse, right? So there was a mnemonic in cardio that don't try drugs. So IV drug abuse may lead to tricuspid valve pathologies, right? And pulmonic stenosis may also be there. Niacin deficiency, pellagra, and increased urinary 5-HIAA. Histology may show prominent rosettes like in neuroblastoma that we saw, the Homer-Wright rosettes. And chromogranin A and synaptophysin may be positive. Treatment is surgical resection, somatostatin analogs, that is octreotide, or tryptophan hydroxylase inhibitor, that is talotrecet, for symptom control. So tryptophan hydroxylase inhibitor, that is talotrecet, is used for symptom control. So it may lead to increased metabolism of 5-HT, right? Increased metabolism of serotonin or something like that. I don't know exactly. It may be due to tryptophan hydroxylase may help in increasing the enzymatic breakdown of 5-HT, okay, by monoamine oxidase or something like that. And rule of thirds is 1/3 of them metastasize, 1/3 present with second malignancy, and 1/3 are multiple. Okay. Now the Zollinger-Ellison syndrome. It's a gastrin-secreting tumor, gastrinoma of duodenum or pancreas. And acid hypersecretion causes recurrent ulcers in the duodenum and jejunum. It presents with abdominal pain, peptic ulcer disease, distal ulcers, diarrhea, malabsorption, positive secretin stimulation test, that is increased gastrin levels after administration of secretin, which normally inhibits gastrin release. So normally after giving secretin, there is decrease in gastrin release, but in Zollinger-Ellison there is gastrin releasing from the gastrin secreting tumor, that is gastrinoma, right? So the gastrin that is secreted from the tumor can't be inhibited by the secretin. So it is just like that dexamethasone suppression test. So dexamethasone can suppress ACTH of pituitary, but not ACTH of any tumors. Right. So in the same way, secretin can inhibit gastrin coming in from the stomach, but not the gastrin coming in from the gastrinoma. Maybe associated with MEN1. Like we saw this, there is pancreatic tumors in MEN1. So there can be Zollinger-Ellison, insulinoma, VIPoma, glucagonoma, anything like that. Right. And so there's also a confusion that there's confusion in some people that acid hypersecretion causes acid hypersecretion leads to gastrinoma. So that is not true at all. Right. I know this because few people were discussing in the WhatsApp group that why is it that acid hypersecretion is leading to gastrinoma. Right. So it should inhibit the gastrin secretion or something like that they were discussing. But I just want to clear that it's not this, but it's the other way around. That gastrinoma secretes gastrin, and that gastrin leads to increased acid secretion. And that increased acid secretion may lead to ulcers. And as this glucagonoma is in the pancreatic cell, is in duodenum or in the pancreatic area of the duodenum, which is far from the stomach, right? So the ulcers caused due to increased acid secretion due to gastrinoma, these ulcers are found in distal duodenum, not distal duodenum, but distal stomach, that is proximal duodenum, proximal or middle duodenum, right? Unlike the normal gastric ulcer that is found in the pylorus area. So also the ulcers, gastric ulcers that can't be treated with PPIs, even with second or third line PPIs, then after endoscopy is done, and then after ulcers are found in the proximal duodenum. So it's then after that this gastrinoma is suspected. Alright, gastrinoma is suspected whenever ulcers are found in the proximal duodenum or they are not responding to the standard treatment of proton pump inhibitors. Now the pharmacology section. The first is diabetes mellitus therapy. It's such a huge topic that it can't be summarized in just 2 pages of the first aid. Okay. But we are still just going to see the diabetes mellitus therapy, and we'll see the drugs that are used and the side effects of those drugs, which is asked commonly, right? Because there's so much more to it than just these getting to know about these drugs. There's something to know about the dosage as well, what dosage insulin should be started, and what kind of drug should be started for what kind of patients, and everything like that. So all patients with diabetes mellitus should receive education on diet, exercise, blood glucose monitoring, and complication management. Treatment differs based on the type of diabetes and glycemic control. So generally type 1 diabetes mellitus are given insulin replacement, and type 2 diabetes mellitus are given oral agents, that is metformin is first line, and non-insulin injectables, insulin replacement if the HbA1c gets more than 10, then weight loss, particularly helpful in lowering blood glucose. And the gestational DM, insulin replacement if nutritional therapy and exercise alone fail. So just in gestational DM is the only case where first 2 weeks of exercise and nutritional therapy, that is DASH diet and low carbs diet, is given to see if it helps, and then only after 2 weeks insulin replacement is given, right? So generally even after nutritional therapy and exercise in type 2 diabetes we give oral agents, but in gestational first we give nutritional therapy and exercises, and then 2 weeks after that, if it doesn't help, we start insulin replacement. So regular short-acting insulin is preferred for DKA, IV, and hyperkalemia, for hyperkalemia and stress hyperglycemia. And for hyperkalemia, because insulin can push potassium back into the cell where it belongs. And these drugs help to normalize pancreatic functions, GLPs, GLPs, and GLPs. So let's just see in brief what these drugs are. So first is biguanides and thiazolinidions, that is this PPAR gamma activators, right? Like proglitazone and rosiglitazone and all. And biguanides include metformin. So they increase insulin sensitivity in adipose tissue and skeletal muscle, right? So that glucose uptake can be done efficiently. And second, they also decrease glucose production in liver. That is, it suppresses gluconeogenesis in the liver by inhibiting the action of glucagon. So that is the first things. And second is let's discuss the sulfonylureas, meglitinides, GLP-1 analogs, and DPP-4 inhibitors. So one way or other, they increase insulin secretion from pancreatic beta cells. Now, sulfonylureas and meglitinides, they both increase insulin secretion despite of the serum glucose level. Right? They are just going to close the potassium channels on pancreatic beta cell and increase the insulin production, no matter what the serum glucose level is, no matter what the body needs, it's just going to secrete insulin. On the other hand, GLP-1 analogs and DPP-4 inhibitors, they are going to induce insulin secretion only when there is increased blood glucose levels, right? So whenever we have intake of oral glucose, there's going to be secretion of GLP-1 in normal physiology, but we give GLP-1 analogs which will act in the same physiological way and promote insulin secretion whenever there is glucose intake. And DPP-4 inhibitors are just, DPP-4 is an enzyme that just deactivates this GLP-1. So we just deactivate the DPP-4 itself. So GLP-1 can act in its own way like it generally does. Along with amylin analogs, they also decrease the glucagon release from pancreatic alpha cells, right? And they also decrease the gastric emptying from the stomach. So if they are decreasing gastric emptying, it's also going to provide satiety, right? That is often desired in diabetic patients, to not eat more, right? And the next is this SGLT2 inhibitors. They just decrease the glucose reabsorption from the kidney. They let the glucose excrete out in the urine, but along with that they also allow sodium to go out with glucose, right? So due to sodium going out, it's going to cause hypotension, and due to glucose going out into the urine, into the urinary bladder and ureter and everything, so getting glucose in contact with ureter and urinary bladder is always a bad idea, as it can lead to UTIs and vulvovaginal candidiasis, and the females are more prone to UTIs than males because of the shorter ureters. And the alpha glucosidase inhibitors, that is, it inhibits the intestinal brush border alpha glucosidase, right? So that is delayed carbohydrate hydrolysis and glucose absorption. So they just decrease glucose absorption from the intestine. So this is how it goes, right? Metformin and thiazolidinediones, they increase insulin sensitivity. Sulfonylureas, myelinated DPP4 inhibitors, they increase insulin secretion. Like sulfonylureas and myelinides increase insulin secretion despite the blood glucose level, no matter what the blood glucose level is. And DPP4 and GLP-1 increase insulin level whenever there is increase in glucose levels. And there's SGLT2 inhibitors decreased glucose reabsorption, riscanagliflozin, dapagliflozins, all the gliflozins. And this is alpha glucosidase inhibitors, that is acarbose, that they are not used much. They just decrease glucose absorption from the intestine. So rapid acting 1 hour peak lispro aspart glulicin, no lag. These are the rapid acting ones, and they are mostly used for postpartum hyperglycemia. They are used for postpartum hyperglycemia. Then there's short acting, that is 2 to 3 hour peak, that is regular insulin, just like the insulin secreted in the body. So for postpartum hyperglycemia, subcutaneous is used, and for DKA, IV is used, as we saw here. For DKA, IV is used. Okay. For hyperkalemia 2, regular insulin is used, and stress hyperglycemia 2 is regular insulin use. And for intermediate acting, that is NPH, that is taken, if taken, it is taken twice daily. And long acting, that is no real peak, detamate or glargine, it is just to maintain normal regular insulin level in the body, like to maintain baseline insulin levels. These long actings are used, and so it mimics steady insulin secretion. Of pancreas, that is, it controls fasting hypoglycemia. Right, so for fasting hyperglycemia, it's not hyperglycemia. Right, so diabetic patients may also have fasting hyperglycemia, right? That is what diabetes is. So fasting hyperglycemia, the glucose can be more than 126 mg per dl in fasting as well. So long acting insulins, that is detamate and glargine, can keep that in check. So mechanism of this insulin is it binds insulin receptor via tyrosine kinase activity, and in liver it increases glucogen storage as glycogen via formation of glycogen that we saw via PI3K pathway. It stimulates the glycogen synthase. It dephosphorylates the So first of all, it stimulates PI3K, then that stimulates IRS1, and that IRS1 dephosphorylates the glycogen synthase, and glycogen synthase synthesizes glycogen. In muscle too, it synthesizes glycogen and proteins. Proteins are also synthesized via PI3K, and fat is, it increases triglyceride storage. It decreases fatty acid, increases triglyceride storage. That is why in insulin deficient states, the triglycerides form free fatty acids, and that form ketone bodies that play a major role in decay. Right? In cell membrane, it increases potassium uptake. Adverse effects: hypoglycemia. As you know, the exogenous insulin is more prone to cause hypoglycemia because exogenous insulin cannot be regulated as well as the endogenous insulin from the pancreatic beta cells. There's lipodystrophy, there's hypersensitivity reactions, which is very rare, and the weight gain. Why does the weight gain occur with insulin? Because there is increased glucose uptake with insulin, but there's also fatty acids uptake and formation of triglycerides, that is fat. There's decreased glucose excretion. There is also another important thing, that is decreased dietary adhesion. Okay, and snacking in response to hypoglycemia. Right, so once the patient is diagnosed DM and he started on insulin, so now the patient will think that, okay, so now I'm taking the meds, I don't need to worry about anything, and the patient does not stick to its dietary regulations, right? They start eating whatever they want to, and that may lead to weight gain, because along with that eating habits, we are also giving insulin, which is going to increase the glucose uptake, right? Increase the fatty acid uptake, increase the formation of triglycerides. And also the patient, if they come across episode of hypoglycemia, so after that episode of hypoglycemia, the patient feels that they should eat all the time to avoid that symptoms, of avoid the frequency of hypoglycemia, right? So the snacking generally increases snacking generally increases in response to the hypoglycemia, right? And that is generally seen in the working class people, right? So they don't want to be hypoglycemic, so they keep snacking all the time. Now, to increase the insulin sensitivity, we give biguanides, that is metformin, BDS 500 mg. It inhibits mitochondrial glycerol 3-phosphate dehydrogenase, that is mitochondrial GPD, and due to that inhibition, there is inhibition of hepatic gluconeogenesis and the action of glucagon, right? Because this glycerol 3-phosphate dehydrogenase is a substrate for gluconeogenesis. Because this glycerol 3-phosphate dehydrogenase forms glycerol and lactate. So glycerol and lactate may act as substrate in gluconeogenesis. Inhibition of hepatic gluconeogenesis and the action of glucagon. glycolysis increases, and peripheral glucose uptake increases because of increased insulin sensitivity. They also increase AMP protein kinase, so there's inhibition of lipogenesis, so no more triglycerides are being formed. And as there's no more of fat or triglycerides being accumulated, there's also going to be weight loss that is often desired. So first aid says that it causes weight loss. Uworld says that it is weight neutral, right? But most of the texts that I've come across, they say that weight loss is there with metformins, right? And at one point, metformin was used for just weight loss, right? Even in non-diabetic patients, the metformin abuse had begun. Adverse effects is GI upset, lactic acidosis because lactate is being formed, as I told you. Use with caution in renal insufficiency. So every anti-diabetic and every oral hypoglycemic agent should be used with caution in renal insufficiency. And it can also cause vitamin B12 deficiency. Right. So, yeah, RFTs are checked before starting metformin. Okay. And also, there's very less risk of hypoglycemia. Okay. Why is that so? Because the circulating insulin levels are normal as previous, right? It's just that we are increasing the sensitivity of that insulin. It's not like we are increasing insulin secretion from pancreas via sulfonylureas or myelinidase, or we are increasing insulin secretion via GLP or DPP4 inhibitors, just like that. So, as the circulating insulin levels are just normal. That is why risk of hypoglycemia is nil. Now the thiazolinidions, that is pioglitazone and rosiglitazone, they activate PPAR gamma, a nuclear receptor, and it increases insulin sensitivity and level of adiponectin as well. So there's increased regulation of glucose metabolism and fatty acid storage. So it's not written very clearly here what actually happens, so you can't even understand what the mechanism is by just reading that activates PPAR gamma, so it increases insulin sensitivity and levels of adiponectin. But how is it doing it actually, you may never understand from reading the text alone. So this adiponectin that is increasing, that leads to increased insulin responsiveness in adipocytes. Hence, the insulin uptake increases in the adipocytes, right? So there is increased fatty acid uptake too in the adipocytes. And as there's increased fatty acid uptake too, there can be weight gain, right? Because fatty acid uptake, they will eventually form triglycerides for storing purposes, and increased triglycerides means increased fat eventually, and increased fat means weight gain, right? And it is also used in NASH and metabolic syndrome, right, to decrease the fatty acids in the blood, right, to decrease the circulating LDL in the blood, because as we talked about, it increases fatty acid uptake. So that is why it is also used in NASH and metabolic syndrome to reduce cholesterols. In layman language, to decrease cholesterol. Okay, so weight gain is the most important side effect. Then there's edema, heart failure, increased risk of fractures too. There's delayed onset of action of several weeks, and rosiglitazone also increases the risk of MI and cardiovascular death, right? And they also increase carcinoma of bladder risk. And so it's mostly not recommended nowadays, right? Now the second is increase insulin secretion. Okay. No matter what the serum glucose is. Okay. So that consists of sulfonylureas and meglitinides. Sulfonylureas, first gen is chlorpropamide and tolbutamide, and second gen, that is glipizide, glyburide and glyclazide. Okay. So the safest drug of sulfonylurea, that is glyclazide, is not mentioned here. Yeah. So they close potassium channels in pancreatic beta cells membrane, and cell depolarizes and insulin release via calcium influx. So if you want to go back and see the diagram that is given in the physiology section, that once the glucose intake is done via GLUT4 into pancreatic beta cells, thereafter that glucose undergoes glycolysis and phosphorylation and everything, and it synthesizes ATP, and due to that ATP the potassium channel closes, that because it is ATP sensitive potassium channels, and once the potassium channels closes, potassium increases inside and causes dephosphorylation, and due to that depolarization calcium influx is also there, and due to that calcium influx insulin is released from the secretory granules. Okay. So the side effects of it is disulfiram like reaction with first generation sulfonylureas only. That's why it is rarely used, and there's also risk of hypoglycemia and weight gain due to increased risk in renal insufficiency. There's hypoglycemia because insulin is secreted no matter what the level of glucose is in the serum, right? And glyclazide is the only drug that is heart and renal protective. Meglitinides include nataglinide and repaglinide. The third is increased glucose-induced insulin secretion. So it is glucose-induced. So that itself suggests that whenever there is increased glucose, then only the insulin will be secreted, and that is why it has lower risk of causing hypoglycemia. Right, because if there's hypoglycemia, there's also going to be less insulin being secreted. And first is GLP-1 analogs, that is exenatide, liraglutide and semaglutide. The Ozempic that is used mostly these days, that is semaglutide. it decreases glucagon release, decreases gastric emptying, and increase glucose dependent insulin release. So whenever we take oral glucose, not the IV glucose, just the oral glucose can stimulate GLP-1 secretion. And what GLP normally physiologically does is it decreases glucagon release, it decreases gastric emptying, and it secretes insulin. And so so what GLP actually does is, this are the GLP receptors. Once glucose is taken, it is going to activate GLP-1, and GLP-1 is going to increase CAMP in the pancreatic beta cell, and that CAMP will lead to exocytosis of insulin granules. So increased glucose dependent insulin release. Side effects are nausea, vomiting, pancreatitis is important. Weight loss is also important because there are only few drug classes that causes weight loss. First we saw is metformin. Now this Ozempic GLP-1 analog, right? So that is why it is more popular these days, Ozempic, because it also causes weight loss, right? And it also causes increased satiety, right, due to decreased gastric emptying. Now the DPP-4 inhibitors, that is linagliptin, sexagliptin, sitagliptin. Okay. So I always get confused between the drugs of DPP-4 inhibitors and SGLT2 inhibitors. Like if the gliptins are in SGLT2 or the gliptins are in DPP-4. And I don't know why, or I don't know if you people have the same problem or not. But if you do, I figured out a way that DPP, it ends with P, and the gliptins has P. So I don't remember gliptins, right? I just remember pitin, right? So DPP, pitin. Okay, so that is a very silly way that I have finally remembered these drug classes. Okay. Yeah, so it inhibits DPP-4 enzyme that deactivates GLP-1, right? And that is why GLP may act for longer periods of time, causing decreased glucagon release, decreasing gluconeogenesis, and decreasing gastric emptying, which causing increased satiety that is desired, and glucose-dependent insulin release. So it can cause respiratory and urinary infections, and it is a weight neutral drug. And there's also serious side effect, but it's a very rare side effect, that is in GLP-1 analog, that is medullary thyroid carcinoma. But it's not proven yet, or not seen in the very commonly. Okay. I should just write it down what we discussed. What's that? As the effect is glucose dependent, risk of hypoglycemia is minimal. Now the SGLT2 inhibitors that it blocks reabsorption of glucose in proximal convoluted tubule, and these include canagliflozin, dapagliflozin, and empagliflozins, or the glifosins, right? Glifosins and G, right? And as it increases glucose excretion through urinary bladder ureters, right? So that can lead to UTIs and vulvovaginal candidiasis. It is a very, very important side effect, probably the most important side effects of all the oral hypoglycemic agent. Okay. So there are several questions you might see of the patients taking canagliflozin or dapagliflozins and presenting with UTIs, right? And or orthostatic hypotension may also be given in the question stem. Okay, so you have to figure out what kind of disease is that, or what kind of drug are they taking, or something like that. Okay. And also there's weight loss, which is a very important side effect, or it may be needed sometimes. So use with caution in renal insufficiency, because decreased efficacy with decreased GFR, because the effect of SGLT2 inhibitors solely depend on the reabsorption of glucose in PCT, right? Blocking the reabsorption of glucose in PCT. But if the GFR itself is decreased, like in renal insufficiency, there is not going to be much glucose reaching the kidneys, right? And there's orthostatic hypotension, because along with glucose, sodium and water is lost too, right? Glucose, sodium and water, all three are lost. So again, RFTs are checked before starting SGLT2. Just like before starting metformin, we check RFTs. And as there's natriuresis and diuresis, that is loss of sodium and loss of water in the urine, there's natriuresis and diuresis are useful in heart failure patients, hypertension, to decrease mortality, and also decrease the risk of diabetic nephropathy. Okay. Because diabetic nephropathy is due to sorbitol accumulation in diabetes, right? So indirectly, accumulation of glucose is there in diabetes, in kidneys. But if we are getting rid of glucose through urine and not letting the glucose stay in the kidneys, we are preventing formation of diabetic nephropathy and the accumulation of sorbitols as well. And glucose filtration is proportional to the serum glucose, right? If the serum glucose is high, the filtration of glucose is going to increase. If the glucose is low, that is, the person is hypoglycemic, the glucose filtration is going to decrease. So therefore the risk of hypoglycemia is also low. Glucose filtration is proportional to serum glucose. Therefore, risk of hypoglycemia is also low. So only when the glucose level increases in serum, only when there is hyperglycemia, these SGLT2 inhibitors are going to act and let the glucose excrete out from the kidneys. Right? There is not going to be any case where there is hypoglycemia and still the kidneys are letting go of the glucose. On the alpha glucosidase inhibitors, that is acarbose and miglitol. One more thing, it causes weight loss that we saw, but just write down which are the drugs that causes weight loss, because it is important to remember them and differentiate them for the question stem that the patient may present with weight loss after starting oral hypoglycemic agent, and you should be able to differentiate what kind of drug are they taking. So there are only three drugs, that is metformin, then GLP-1 analog, and SGLT2 inhibitors. Okay. And DPP-4 is special mention, weight neutral. Okay. So metformin, here we saw metformin has weight loss ability, GLP-1 has weight loss ability, and SGLT2 has weight loss ability. Now the alpha glucosidase inhibitors, that is acarbose and meglitol, inhibits intestinal brush border alpha glucosidase, so there's delayed carbohydrate hydrolysis and glucose absorption, and it decreases postprandial hyperglycemia. It causes GI upset and bloating and not recommended in renal insufficiency. It's not very important drug. Okay. Just remember that it decreases glucose absorption, and it's used to decrease postpartum hyperglycemia. Last is amylin analogs, that is pramlintide. It decreases glucagon release and decreases gastric emptying. It causes hypoglycemia, nausea, and increased satiety. Where else did we see increased satiety? In GLP-1 analogs and DPP-4 inhibitors, because they are decreasing gastric emptying. So which all drugs causes hypoglycemia mostly? It's the insulin preparations, then it's the sulfonylureas, then it's the amylin analogs. Right. So metformins, GLP-1 analogs, DPP-4 inhibitors, and SGLT2 inhibitors, they don't cause hypoglycemia. Okay, fasting hypoglycemia, they don't cause fasting hypoglycemia, because like we discussed in metformin, that metformin only increases insulin sensitivity. So the circulating insulin levels are normal, hence the circulating glucose levels are also going to be moderately low, not of the hypoglycemia levels, right? Only if there is increased insulin secretion in hypoglycemia, it is going to cause severe hypoglycemia, right? Like in sulfonylureas. So the circulating levels are normal in metformins, that is why it does not cause oral hypoglycemia. And GLP-1 and DPP-4 just causes glucose-induced insulin secretion, so there is not going to be any chance of hypoglycemia. SGLT2 inhibitors excrete glucose through the PCT in the kidneys, but the glucose filtration depends on the glucose levels in the serum, right? So if there's decreased glucose, like in hypoglycemia, there is also going to be decreased glucose filtration, so there's not going to be any chance of hypoglycemia. The only very important drugs that you have to remember for hypoglycemia are sulfonylurea and Insulin. Insulin, you may get questions like, there was hypoglycemia with insulin or weight gain with insulin. So what is the mechanism behind that? So it's the increased glucose uptake, increased fatty acid uptake, decreased dietary adherence. Okay. And with sulfonylurea, why is there hypoglycemia? It increases insulin despite the glucose levels. Okay, and they also cause weight gain. Weight gain is caused by thiazolinide ions, that is pioglitazone and rosiglitazone. And also, why with pioglitazone, rosiglitazone? Because it already activates PPAR gamma, that activates uptake of fatty acids and formation of triglycerides. So increased triglycerides means increased fat means increased weight. And why with sulfonylureas there's weight gain? Because there's insulin secretion, right? And insulin secretion despite the glucose levels, and that insulin will lead to increased glycogen, increased protein synthesis, increased triglyceride storage, everything. Okay. Thionamides, that is the drugs that are used for hyperthyroidism. So that is propylthiouracil and methimazole. So its main mechanism is it blocks thyroid peroxidase, so inhibiting the oxidation of iodide as well as the organification and coupling of iodide. So if you remember, thyroid peroxidase helps in all the three steps, that is oxidation, organification and coupling of iodine. So it is the main hormone, it's the main enzyme on which all the functions of thyroid gland is dependent. So thionamides block that thyroid peroxidase. And inhibition of thyroid hormone synthesis is done. And PTU also blocks 5' deiodinase, that is decreases peripheral conversion of T4 to T3. So PTU has this additional function. Clinical use is in hyperthyroidism. PTU used in primary, that is first trimester of pregnancy, due to methimazole teratogenicity. And methimazole is used in second and third trimester of pregnancy due to risk of PTU-induced hepatotoxicity in the later stages of pregnancy. Okay, so PTU is used in the first trimesters, right? Because if methimazole is given, it can be proven teratogenic to the fetus. And methimazole is used in second and third trimester due to risk of PTU-induced hepatotoxicity. Not used to treat Graves' ophthalmopathy treated with glucocorticoids. Okay, so we also discussed that in Graves' disease, that giving steroids, that is glucocorticoids, will only help with the Graves' ophthalmopathy, right? It reduces the infiltrates that is settle down in the eyes, right? So it only helps with Graves' ophthalmopathy and not the hyperthyroidism itself. Right. And adverse effects are skin rash, agranulocytosis, that is rare, aplastic anemia, hepatotoxicity, and PTU use has been associated with ANCA-positive vasculitis. And methimazole is a possible teratogen. It can cause aplasia cutis. And so it can also cause neutropenia. Okay, and neutropenia mostly presents as oral ulcers. Plus fever. Because why is the neutropenia occurring? Because these thionamides plus the reactive oxygen products, that is myeloid peroxidase and H2O2, that is hydrogen peroxide, when thionamide is given, it interferes with that, and the drug metabolites which are formed, it sticks on the neutrophil, and they become the target of the antibodies. Okay, so the antibodies acting on the antibodies acting on the drug metabolites that are stuck on the neutrophil surface are going to damage neutrophils as well. So that is why it causes neutropenia. So the reactive oxygen species, that is H2O2 and MPO, plus when thionamides are given, they form drug metabolites that stick on neutrophils. And gets attacked by the antibodies. Okay, hence attacking the neutrophils as well. And if propylthiouracil is taken for longer periods or in increased dosage, it can also cause congenital hypothyroidism. Plus goiter. Okay, through transplacental passage. Transplacental transfer. Okay, so yeah, skin rash is there, agranulocytosis, aplastic anemia, hepatotoxicity with propylthiouracil mostly, and ANCA positive vasculitis and aplasia cutis with methimazole, because methimazole is teratogenic, so that it causes aplasia cutis. There is absence of skin. Okay, and beta blockers can also inhibit peripheral conversion of T4 to T3, right? Just like PTU, beta blockers can also do that. Okay, mostly the propranolol. Now the levothyroxine and leothyronine. It's the hormone replacement for T4, that is levothyroxine, and T3, that is leothyronine. Its clinical use is in hypothyroidism, myxedema, may be misused for weight loss. There are going to be many questions which focus on this misuse of levothyroxine for weight loss. Like the history may be given of a patient who is an influencer or who is a model trying to reduce weight, or she will not tell you that she is trying to reduce weight, but she will be malnourished and she will be underweight. And when taken the history of her family members, it will be found that her mother has hypothyroidism, and for hypothyroidism people take levothyroxine, right? And if the family member is taking levothyroxine, this patient may steal some levothyroxine for her own self and start abusing it for weight loss. And when you do the thyroid tests, the T4 will be raised, T3 will be raised. Okay. And the TSH will be low, but thyroid binding globulin, that will be normal or decreased, because only the T4 releasing from the thyroid gland will cause increase in TBG as well. The exogenous T4 will not cause any kind of increase in this TBG. Okay. Distinguish exogenous hypothyroidism from endogenous hypothyroidism by using a combination of TSH receptor antibodies, radioactive iodine uptake, or measurement of thyroid blood flow on ultrasound. So yeah, you can also use TSH receptor antibodies for Graves' disease. No, sorry, not for Graves' disease, but for Hashimoto's thyroiditis, radioactive iodine uptake, right, and measurement of thyroid blood flow on ultrasound. Yeah. Okay, sorry, so that is TSH receptor antibodies for Graves' disease, because we are distinguishing the exogenous hyperthyroidism and endogenous hyperthyroidism. Right. So in endogenous hyperthyroidism, there is going to be positive TSH receptor antibodies. There's going to be increased radioactive iodine uptake to synthesize more and more hormones from the gland, and thyroid blood flow will also be increased on ultrasound because thyroid is functioning more to secrete more T4 and T3. That all will be normal if patient is just taking exogenous levothyroxine. And adverse effects are tachycardia, heat intolerance, tremors, and arrhythmias, mostly AFibs, atrial fibrillations, right, due to tachycardia and increased myocardial contractility. Right, so mostly levothyroxine is prescribed and not liothyronine. Why? Because T4 is given because it can convert to T3, right, with the help of 5-deiodinase, 5'-deiodinase. It can convert into T3 peripherally, but if T3 is given, it is going to just decrease the level of TSH, because TSH responds to mostly the free T3 levels, right? So if TA3 is given routinely, the TSH is going to decrease, and if TSH is going to decrease, the thyroid gland is going to underperform and hence secrete less amount of T4, right? So the patient was already in hypothyroidism and we are decreasing T4 in addition to that, so patient is going to worsen. So that is why T3 is not given. T3 not given routinely, because if TSH will decrease and that will lead to further decrease in T4. Okay, and this T3 can also activate osteoclasts that we've seen a couple of times. So that is going to lead to bone resorption. Now I want to add a few things to this, but I don't think I have space here, so let me just write it down here. So levothyroxine is not just given for hypothyroidism, but levothyroxine is also given after thyroidectomy for thyroid cancers, right? So after thyroidectomy, there may be some residual tumor left in there, right? So the TSH coming in from pituitary gland can promote the growth of this residual metastasis, right? After all, it's a thyroid tissue, so TSH can promote the growth of that residual thyroid metastasis, and therefore we need to suppress that TSH. So to suppress that TSH, we are going to provide T4. Okay. So levothyroxine also given after thyroidectomy for cancers, because TSH can promote growth of residual metastasis. So T4 will suppress that TSH levels. Right, so one last thing about levothyroxine is that if with levothyroxine soy, iron, calcium or antacids are given, it is going to decrease levothyroxine absorption. These things interfere with levothyroxine absorption. That is going to cause further hypothyroidism, not further hypothyroidism, but patient will stay hypothyroid even if it's on therapy, right? So the patient may be compliant with his drugs, or Patient may be compliant with his drugs, right? But the labs may still suggest that the patient is in hypothyroidism. So on for taking further history, the question stem will show you that the patient takes soy for something, or takes antacids for its GERD or something like that, or takes calcium multivitamins. So that may lead to decreased levothyroxine absorption. Yeah, so we're done finally. So hypothalamic pituitary drugs, that is conivaptan and tolvaptan, are ADH antagonists that is used in SIADH, the block action of ADH at V2 receptors. Demeclocycline is also ADH antagonist. It is a tetracycline. It is used in SIADH and it interferes with ADH signaling. So conivaptan and tolvaptan block action at V2 receptors, and demeclocycline interferes with ADH signaling. And desmopressin, that is ADH analog, is used in central diabetes insipidus, von Willebrand disease, sleep enuresis, and hemophilia A. Growth hormone, it's used in growth hormone deficiency and Turner syndrome, because in Turner syndrome there is short stature. Okay. Oxytocin is used in induction of labor, stimulates uterine contractions and control uterine hemorrhage. Somatostatin, it's used in acromegaly, carcinoid syndrome, gastrinoma, leukogonoma, esophageal varices. Right. And also octreotide, that is analog of somatostatin, that has altered amino acid sequences, right? So it is more resistant to degradation. It has altered amino acid sequence than the somatostatin. That is why it has more resistance to degradation. So it acts more powerfully than somatostatin. Now fludrocortisone, its mechanism is synthetic analog of aldosterone with glucocorticoid effects. So fludrocortisone retains fluid. And mineralocorticoid replacement in primary adrenal insufficiency. Adverse effects are similar to glucocorticoids, also edema, exacerbation of heart failure, and hyperpigmentation, because it is going to act as mineralocorticoid, right? So mineralocorticoids exacerbate heart failure due to retention of fluid, due to edema. There may not be aldosterone escape mechanism if we are giving aldosterone, additional aldosterone-like drug, that is fludrocortisone, from outside. And there may also be hyperpigmentation. Right. Now let me just, okay, I'll write it down later on. I wanted to write about that estrogen receptor modulators, tamoxifen and raloxifene, but I'll write it down later on. So cinacalcet sensitizes calcium sensing receptor in parathyroid gland to circulating calcium. Okay, so that will lead to decreased parathormone. Okay, so it increases the sensitization of parathyroid gland towards the circulating calcium. So previously what was the problem? That parathormone couldn't realize that body has enough calcium, so it needs to reduce down the parathormone secretion. But giving this cinacalcet, it is going to sensitize sensitize the calcium sensing receptors on parathyroid gland to circulating calcium. So now parathyroid gland can see that there's enough calcium in the body, so I need to calm down, I need to reduce the secretion of PTH. So that is why this action to reduce the secretion of PTH when there's enough calcium in the blood is used in secondary hyperparathyroidism in patients with CKD receiving hemodialysis, hypercalcemia in primary hyperparathyroidism if parathyroidectomy fails. So in secondary hyperparathyroidism, where there is decreased calcium absorption and increased phosphate in the blood due to CKD, so their PTH levels are going to be raised due to decreased phosphate and due to increased phosphate and decreased calcium. PTH is going to be increased, so that is where this drug comes into use. And in hypercalcemia, where there's parathyroid adenoma and parathyroid hyperplasia, there's increased PTH secretion, so that is also where this drug comes into use if the parathyroidectomy fails. Okay. Or in carcinoma as well. Adverse effects are just hypocalcemia, obviously. So if PTH is decreasing, it is going to cause hypocalcemia, right? Then this cevilamide, it's non-absorbable phosphate binder that prevents phosphate absorption from GI tract. So it binds phosphate, so that is why. So then phosphate becomes non-absorbable. Its clinical use in hyperphosphatemia in CKD. There's obviously more phosphate in blood in CKD because the chronic kidney diseased kidney is not able to excrete out the phosphate, and the adverse effects are hyperphosphatemia and GI upset. Cation exchange resins, that is Pathoma, sodium polystyrene sulfonate and zirconium cyclosilicate. It binds potassium and colon in exchange for other cations, that is sodium and calcium. And so potassium can't be absorbed and excreted in feces. Its clinical use in hyperkalemia. Adverse effects are hypokalemia and GI upset. So basically just giving insulin will help in hyperkalemia. Setting up a GI drip will help in hyperkalemia. Okay, so insulin can push the potassium back into the cell. Now some other drugs, that is ENaC inhibitors. That is amiloride and triampterine. It blocks the aldosterone action by inhibiting sodium ENaC channel through which sodium was being reabsorbed in the kidney. So it can be used in hyperaldosteronism as well, right? Also in Cushing's syndrome. Okay. Sorry, not in Cushing's syndrome, just in Cohen syndrome, that is hyperaldosteronism. And second is aldosterone antagonist, that is spironolactone and eplerenone. They just straight away inhibits aldosterone. Right. And now Now these are just going to be very vague points that I couldn't fit in any other topics, so I'm just randomly writing them down. Okay. So gynecomastia is caused by estrogen, first of all, in hormone replacement therapies, then testosterone inhibitors, then finasteride, that is the 5-alpha reductase inhibitor, right? So it decreases dihydrotestosterone peripherally, so it causes imbalance between testo and estrogen that leads to gynecomastia. Then there's spironolactone, then there's ketoconazole also, then cimetidine, right? Ketoconazole just inhibit the cholesterol desmolase, which forms pregnenolone from cholesterol. So that is the first step in the formation of adrenal gland hormones, right? All of the hormones. And last is cimetidine, that is antihistaminic. Okay. Now we'll talk about subcutaneous lipodystrophy caused by NRTIs in HIV patient. NRTIs like stavudine, zidovudine, plus also with protease inhibitors, all those navirs, indinavir and all that. So that's just subcutaneous lipodystrophy. But with any other HART regimen, there is always central fat accumulation. Central fat accumulation is seen with any HAART regimen, right? But this subcutaneous lipodystrophy is specific with NRTIs and protease inhibitors. And yeah. Now with endogenous testosterone, not endogenous but exogenous testosterone, a few things happen. Mostly exogenous testosterone, these performance enhancing drugs are used by athletes or bodybuilders or pubertal teens who are insecure, okay, about their appearances. So it is going to increase muscle mass. That is one positive thing, and there are a lot of negative things about it. It will cause acne. It is going to cause increased erythropoietin, which will lead to increased viscosity of the blood, which may lead to hypercoagulopathy. It will lead to psychiatric imbalances. Testosterone inhibits GnRH, right? So inhibition in GnRH will also it also inhibits LHS and FSH independently, and as also by decreasing GnRH. So because of that, there is going to be decreased spermatogenesis. There's going to be decreased endogenous testosterone. Okay, and there's going to be testicular atrophy. In this exogenous testosterone that we give, it can convert into estradiol, that is E2, peripherally with the help of aromatase enzyme. And there's a decrease in testosterone through this mechanism, and increase in estrogen through this mechanism may lead to gynecomastia. And also due to increased estrogen, there is going to be premature epiphyseal closure. So the person is going to be of short height. So the height stops increasing. And also there are a few other things. I don't know where to write it down. It will also lead to increase in prostate specific antigen, which can also lead to prostate cancer. It is going to inhibit hepcidin and also increase iron absorption, and along with increased erythropoietin, it can lead to increased viscosity and risk for thromboembolism. That is everything that happens with exogenous testosterone or testosterone replacement therapy. So the last thing that I want to talk about is giving continuous GnRH agonist, that is leuprolide. So giving continuous GnRH agonist, so initially it is going to it's GnRH agonist, right? So initially it is going to increase the GnRH levels, and that is going to cause increased LH for a while. But as we keep on giving continuous GnRH agonist, that is leuprolide, there's going to be decreased regulation of those receptors, the GnRH receptors, and that is going to lead to decreased LH and decreased testosterone. So you may see a graph. This is the time period of giving continuous GnRH agonists. Normally, physiologically, GnRH is secreted in a pulse-like manner, not continuously. But as we are giving it continuously, it is going to cause inverse effect on the body, unlike the natural effect. Okay. And this is the LH level. So the graph goes something like this. Okay. So this initial phase is GnRH increase, which will lead to increase in LH. But this phase is explained here that there is going to be decreased regulation of GnRH receptors, and that will lead to decreased LH levels. And decreased LH will cause decreased stimulation of Leydig cells, and that is going to cause decreased testosterone. So that is why it is used in medical orchiectomy first, and also medical management of prostate cancer. So to compensate for this effect, to compensate for this increase in GnRH and LH level for a while, that is called the tumor flare. So if we are starting just leuprolide, it is going to cause tumor flare, that is increased LH for an initial period of time. We give another drug, that is bicalutamide. So that is going to inhibit GnRH for that initial period of flare. Right. So GnRH is androgen receptor antagonist. Right. So leuprolide along with bicalutamide is used for medical management of prostate cancer. And in cases of some infertility in females, or also in males, I don't remember if it's given in males too, but pulsatile GnRH agonist is going to increase GnRH for chronic periods of time, which is going to increase LH and FSH for chronic period of time. So pulsatile GnRH agonist and continuous GnRH agonist both have opposite effects on the body. Right. So yeah, we are done with this section finally. Okay, so see you again in next system, whichever system I decide to do next.